Nice to have on TYAcon 2025. This is the 14th National Conference of Teenage and Young Adolescents. We are going to start the first session, that is Hematology in AYA. For this chairperson, I am inviting Dr. Sandeep Shah and Dr. Anupa Joshipura. Dr. Sandeep Shah, sir, please. Dr. Anupa Joshipura. Both are leading hematologist in Ahmedabad, and at least we had a very good their presence in early morning. For that, the speaker or the topic for this hematology, there are total 4 or 5 sessions, starting from first role of genomics in ALL, and that is by Dr. Neeraj Arora. There are some other hematological, like choosing a protocol, pharmacology, transforming quality of life in hemophilia, hope beyond the relapse and recurrence in leukemia, lymphoma, and case-based panel discussion by Dr. Nikita Mehra. So we are going to start. Let us start with Dr. Neeraj Arora.
Very good morning to all of you. And at the outset, I would like to thank Sir for giving me this opportunity, and I would like to congratulate him. Usually, you would see genomics in the end, last. So we are starting with genomics, and this has been rightly, appropriately, with the theme precision oncology in young persons cancer. We are starting with genomics, so that is very, very appropriate, and I would like to congratulate Sir. Though I felt this might be a little too much for many of us, but I have kept it because the intent is to be able to know what is happening, latest thing, and this is where the field is moving. So we all need to be aware of what is happening latest in this area. So in this 15 minutes or so, I will be touching primarily BALL, and I want to introduce some of the newer things happening in this area, that is transcriptomics, which is coming in. So that is what I would like to highlight more in this area. So ALL, as we know, there have been a lot of improvements in ALL, and there are two driving things in that. One is risk stratified based classification or risk stratified based treatment, and MRD. So two key parameters which have driven the improved survival in childhood ALL. Of them, genomics forms a key part of whatever we are doing. So in ALL now we have these established subgroups like high hyperdiploidy ETV6, TCF PBX, low hypodiploidy, near haploidy, IAM, BCR ABL, HLF, and ABL class. These are some of the established subgroups of BALL in which treatment is being given. And we usually do a battery of tests starting from flow, karyotype, and FISH. And that is how we kind of get to know all of these entities like hyperdiploidy, hypodiploidy, and other entities. So it is a karyotype, FISH, and flow. And then sometimes based on the markers, we do FISH analysis like CD371 associated with DUX1, CRLF2 rearrangement associated, then MEF-D2. Based on immunophenotype, you are directing further FISH markers in those areas. So this is the common strategy that we use. There are newer things happening in this area. There is a whole subgroup of cases like PH like ALL. It is a big subgroup, and a lot of fusions are there, which includes JAK-STAT pathway, ABL class, RAS mutation, and rare subtypes, each with a therapeutic treatment implication. So established subtypes, PH like ALL, these are newer things which are there in ALL. Moving further, in ALL settings, you have gene expression coming in a big way, which is usually done on RNA subtyping. So RNA gives you gene expression, And these are different distinct gene expression subsites, which we were early doing in research, but now it is coming into our clinical subtyping as well. So gene expression is in a big way. And now a lot of other additional things are there. So this is a list of additional genetic subtypes in BALL, which are there into the WHO category, which includes CRLF2, DUX4, MEF-D2, ETV6, RUNX1 like ALL, PAX5 altered ALL, ZNF384, JAK2, BCL2, MYC, IGH, ID4. These are some of the newer subgroups which are there in ALL. Complicating a bit further, there is a group of categories called PAX5 altered, and there are more partners in that. As I mentioned, that many of those categories have been included in the WHO classification. So it is not just for diagnostic purpose. Even the NCCN 2024 has mentioned those as high risk and low risk categories, and this is, you see those categories being described in the NCCN as well. And these subgroups or different subgroups that I showed, they vary as per the age. Like there are different subgroups which are common in children, and there are different subgroups which are common in adults. So this distinction is there between the various age groups that is there. And it is not in the diagnostic settings, it is there. All those subgroups have treatment implications, and this is the list of different treatment implications based on the different genetic subtypes that I mentioned. So it has got treatment implications as well. So in this background, so I mentioned like ALL, different subtypes of ALL, you use karyotype FISH, NGS, RT-PCR. So there now one single assay in terms like RNA sequencing is being looked upon as a single assay for diagnosing of BALL. So rather than doing a battery of tests where we do FISH, karyotype, so many things, a single assay, RNA sequencing, this is whole genome RNA sequencing is being looked upon as an alternative for diagnosing all of these assays. And this has been going for some time now. There are a lot of people working, and they have brought out a lot of softwares are available. So what they've done is they have done a lot of work, and a software is there. And this is a list of softwares like ALL sorts or MDALL. So what we do here is that you sequence or do whole RNA sequencing, you upload into these softwares, and it will automatically classify into different subgroup of cases. So there's a lot of work being done in this area. That area is also being translated into the clinics now. So this is one paper, another paper showing that a single transcriptome based assay can reliably classify in a clinical practicing laboratory most of the cases. So you are able to now, not only in research, this was practically in research earlier. Now this is coming into the clinics, and this has showed that you can reliably do into the clinics as well. Another paper, 2025, this is 2 months back paper, where again they have classified that RNA sequencing is a reliable tool to unveil different landscapes of BALL. So this is the way in which world is moving. RNA sequencing has emerged as a single marker for being able to classify your BALL. So that is the point that I want to make. So with this background in mind, that you have different subtypes of ALL, you're doing karyotype, you're doing FISH, you're doing sometimes NGS. In that settings, RNA has emerged as a key marker, and we have just been working in this area for the last 3-4 years, and we have introduced a assay. This is an RNA-based assay. This is called TransSeq. This is one of its kind attempt in India. Nobody else is being able to do this kind of an assay, where we are able to classify into ALL subtypes. We are also giving mutations. We are giving fusions, germline mutations, pharmacogenomics information. So all from a global RNA profiling, you are able to get that kind of information. So when I say subtypes, there are 26 subtypes we are able to classify. When I say mutations, we target around 14 mutations. Then germline mutations, then there are 69 pharmacogenomic genes and gene expression profiling. So all in all, a complete solution where we are able to classify in ALL. And just to give you the background that what we do. So don't get seeing these images, what is this? So this is the background on which this assay is based. So on top right side is the gene expression profiling of a case. Different gene expression, blue, green subtypes are there. On below is the fusion. On left side is the CNV analysis, and downstream is the prediction heat map based on which we are able to predict what this subtype is there. So this is the background work which is involved in getting out or diagnosing the case. With respect to pharmacogenomics, there are genes related to methotrexate, prednisolone, NUDT, TPMT, and different subgroups. So some of those polymorphisms, because of those polymorphisms, the drugs don't respond. So those information you are able to get out. So this has been extensively validated. We have been working with ACTRAC with Dr. Prashant Temre and Dr. Dhanlakshmi from cytogenetics, and this is, you can see, it is almost 90% accurate with more than 200 samples and 865 touch points. We have used this much to be able to say that this is almost 90% accurate and reliable in terms of bringing to the clinic. So we are doing a lot of samples for validation. This has been published data. So this is a published data. So when you use RNA sequencing, getting CNVs, 9p deletion, 10p deletion is a problem. So we have used published data from the literature. This is Dr. Mayur Pariha's data in hyperdiploid ALL. So we use that data and compared with the transseq. So this is transseq versus SNP array data. And you can see that in terms of modal karyotype number, if the assay is calling 50 chromosome number, that is what is being picked up on the array as well. So this is just a comparative analysis of those, showing that CNV analysis on the transcriptome works well. And this is the data that we used for the validation. I'll just take you few cases. I know it will little bit it won't get into the head, but few cases would make that inappropriate. So this is one case. On the right side, you can see the test sample, like it is falling in the, so 26 subtypes are seen here. So we know that now this is falling in a category, and prediction heat map is showing that this is CDX2-UBTF type of BLL. On the down, you can see a fusion with 500 base pairs, and there is an 8p deletion. So this is the case of CDX2-UBTF type of BLL. You won't be able to pick up on your routine arrays. This is not available because FISH is not there. So you won't see that. And they behave differently to what the ALLs are there. Another case, you can see this is falling in an area where pH is falling. Okay, so this is a pH. In terms of gene expression, falling in the purple area. The prediction heat map is also showing this is a purple, showing that this is a gene expression wise, it is falling in the pH area. But if you look at the downstream fusion, this is not BCR-ABL fusion. Usually pH will have a 922 BCR-ABL fusion. So expression is like pH. The fusion is PD8Y CD99. This is not a pH. So this is a pH like ALL. pH like ALL I mentioned earlier. That is how you identify that this is a pH like ALL. Gene expression showing the expression of pH. The fusion is different. So pH like ALL. And also we see a KRAS mutation and other CNV is documented in this case. So all through a single assay. So single RNA-seq giving you gene expression, showing you fusion, showing you mutation, showing you CNV, holistically classifying that this is a pH like ALL. Another case. So this is falling in the category of PAX80R subtype of gene expression. So gene expression is showing that this is PAX80R type. The heat maps, you see red colors, completely showing that this is a PAX80R. This is a mutation in ALL, defining mutation, distinct subtype of ALL. And if you look at downstream, you can see there is a PAX80R mutation. There is a mutation NRAS, and there are CNV alterations like 9p alteration, 20, and loss of heterozygosity. So this is a case of PAX80R subtype of distinct ALL. Again, usually many of the times you won't be able to figure out that, if your assay doesn't include PAX80R or other things, you won't be able to get out this subtype. This is a very interesting case. This is on gene expression, you are seeing that this is a low hypodiploid case of ALL. Very nicely low hypodiploid. on the prediction heat map also showing this is a low hypodiploid. And you are seeing the down, if you look at, there is a TP53 mutation. This is a likely germline, and you have the modal karyotype number, which is 45, and there is losses you are seeing in CNV. So this was a case of, this was a doctor not responding to treatment, referred by Dr. Anupam, and he wanted to look at for something more, and we got very less sample and not growing for karyotype and not working for other assays. Single assay showing that this is a low hypodiploid ALL, showing that there is an associated TP53 mutation in that, which has got germline implications, where whole family could be picked up based on this TP53. So nicely showing that this is a case of hypodiploid ALL on the single assay. So this is the background which is there. When we give out a report or when we share that report, it is not, doesn't look that complicated in the setting that you would be scared of reading those graphs. Or so this is how the report kind of looks like, how we report out that there is a final subtype. In this case would be low hypodiploid, then fusion type nil, germline gene expression low hypodiploid, there are CNV losses, somatic mutation nil, germline variations are TP53, and the pharmacogenomics information like TPMT, NUDT, and other things which are not responding is mentioned in this easily understandable format. So this is, I mean, whatever I showed was the background work that is there, but when the report or the thing which comes out is in a way which we are able to understand that. Another case, this is on the gene expression, you can see this is a hyperdiploid green area, and the heat map showing very nicely the green color hyperdiploid, and there is a KRAS mutation, and you can see the modal karyotype number 47 with the gains which are typically associated with the hyperdiploid ALL. So this is a case of hyperdiploid ALL. Many a times there is karyotype failure, they don't grow, so karyotype doesn't work. It is not picked up on routine NGS. So whatever NGS you do, hyperdiploid ALLs, you won't be able to pick up. RNA sequencing, FISH is the only solutions in that. And RNA sequencing, so no other assay is going to pick up hyperdiploid or hypodiploid ALLs. So this is very nicely picked up. And this is how we report that. This is the report looks like. One last case, I know 15 minutes only. This is the last case where, this is what the true karyotype looked like for a case, where it was showing an add 21 here, and an NGS was done, which was NRAS and KMT2D. So this was a case. So you have done your karyotype, you have done your NGS in that, and we were validating this case for some of our this work. And when we ran this, it was showing intrachromosomal amplification of chromosome 21. So this is an IM21, which is a distinct subtype of ALL, which is a poor category, which doesn't behave well. So I have a case where karyotype was showing AD21, FISH not done, other tests not done, NGS showing that there is KMT2, nothing with respect to IM. And this assay is showing that this is a distinct type of ALL, which is IM, which has poor prognosis. And we went back to the clinician and retrospectively, we did FISH in this. It was not ordered, we did FISH to show that this is proved to be a case of IM21. Again, IM21, you won't be able to pick up on your routine NGS. The only thing that might be reflected is the amplification of RUNX1. Some copies increase. That is all you would get in your assay. But this assay showed us this is an IM, very nicely showing, and this was proved retrospectively that this is an IM21. And this is how the report looked like in this particular case. And this is the 26 subtypes that we kind of categorize with respect to RNA sequencing. So with that, I would like to end here and conclude that RNA genomics has a huge role in ALL. I showed different subtypes, it is a category which is ever expanding. And RNA-seq is emerging as a key diagnostic assay for these subtypes of ALL. So with that, I would like to end here and would like to thank you for your attention. We're happy to take any questions which are there.
Dr. Neeraj, for excellent summarizing the genomics. I think it is difficult for us also to understand. So as you told, we also go to the last part of the report only.
Yes, sir.
My question is whether we are doing MRD with NGS or by this method MRD instead of flow cytometry, which is I think more sensitive than flow cytometry.
Yes, sir. Sir, like there are two assays available on NGS. One is the IGH TCR based MRD analysis. Usually the sensitivity is 10 to the power -5. It is available, but we are not doing as yet because I think flow is an easier solution in the same sensitivity, same less cost. You're able. I have not been working in this area as yet because of this issue. This assay does pick up clones. In the next update, we are going to add HLA subtyping, KIR typing, the clone identification, and even use it for MRD post validation. So once that part is available, then this will be available in this assay as well. So RNA seek giving you clone information which you can use subsequently for your downstream monitoring or using the same assay for that.
Big question from.
You can ask.
Very nice presentation.
Thank you.
So one question, I'm sorry, I missed the initial part. Can you do this on the peripheral blood?
So not a problem. We need blasts. What I've realized now is the more the sir was mentioning regarding MRD kind of setting. So we've been trying to validate in that settings, but at the moment it is in diagnostic settings where blast is 20-25%. But peripheral blood or bone marrow, not a problem with us. We just need blast for being able to extract RNA and subclassify. That is it. I mean, I need blasts. So whether it is there in the first pool or third, fourth pool, 20-30% blast is what is sufficient for this.
Talked about pharmacology.
Yeah, yes.
I recently came across a flyer where they want to do a DPYD for the offering that test in labs.
Yeah.
For the general population.
Yeah.
What are your thoughts?
So DPYD is a germline, no? So if you want to screen out for more population, you can screen hundreds of population in that sense. So you can do that. I mean, I can get my genetic information. So that is one way of doing it. This is included in this. So DPYD, TPMT, prednisolone resistance, all of that ALL specific polymorphisms. After going to the literature, we figured out 69 genes which are implicated in the drugs for like cytarabine, prednisolone. So the data I showed for CNV validation, that is hyperdiploid ALL. In those, there were 3 cases were poor responders to prednisolone, and we picked up an MTHFR variation in those 3. That has not been, they were treated in terms of prednisolone, but they didn't look at the pharmacogenomics initially. So now we know that there is a MTHFR variation in that. This has been very recent what we've been looking.
No more questions.
Thank you, sir.
After that, we're going to deep down into the laboratory. Let's get back to the clinics. And after knowing all the information that the lab we eventually have to choose a protocol for the leukemia and the lymphoma patients. And I would request Dr. Nikita Mehta to enlighten us on the same. Welcome, Dr.
Very good morning. At the outset, I'd like to thank the organizing committee for inviting me to this conference. My name is Nikita, and I am from Silchar, Assam. So this is the little throwback to TYAcon in 2018, where many of you were there. This was at the Cancer Institute, Adyar in Chennai, where I served for 11 years. And it was a lovely meeting. It was the coming together of survivors for whom it was very nicely centered. And I see that TYAcon is very much, it is all about its patients and what more we can do. So this was another, it was a lovely experience with Chitalkar sir leading from the front, where we had very similar to the meeting now, where there were sessions on survivorship and clinical and lab sessions. So I will talk to you a little about essentially a tale of two institutes, two cities, and really the goals are quite similar. So to quickly talk to you about what is important. This topic was given to me on how we choose leukemia and lymphoma protocols in India. And essentially, this is something I talk about frequently. There are problems to address. Everyone has problems across the world. There are several research questions, but this is not really region specific or country specific. This is also institute specific. So there are two, the cartoon that you see on top, or the diagram that you see on top, is from the Max Foundation. It was posted on LinkedIn very recently, and they talk about the availability of a comprehensive cancer care. You see 90% of it available in high income countries, and only about 10-15% in low middle income countries. And as everyone knows here, India falls under low middle income countries. So you will see this recurring theme. You'll see this coming in several publications and several newspaper articles all the time. Now, what you see in the bottom left cartoon is this image on again, the distribution of countries, right? You're looking at and regions. So if you have to focus on South Asia, which is India and its neighboring countries in the Indian subcontinent, we are about 8 countries, and this constitutes about the distribution of partner countries. This is basically data from the World Bank. What you see on the right is the economic classification. So what you see on top in blue in color in the map is the global north. And these are obviously the developed countries, the wealthy countries. You often see that access to cancer care is better, access to cancer diagnostics is better, and of course, clinical trials. There was a study that was published a couple of days ago in an international journal showing the cancer trial landscape in globally. And you see that despite the population being huge in regions like in Global South, in South Asia, in India, the number of trials that come in, we understand that a lot of these trials now are pharma sponsored. Pharmaceutical companies lead these studies from across the world. Unfortunately, that reach to countries which need it the most is a little less. So I come from the Kachar Cancer Hospital and Research Center, which like I said earlier, is in Silchar, Assam. And here, this is an NGO that was set up by the Kachar Cancer Hospital Foundation in 1992. And it was a group of lay people in the community who decided to start this facility because patients had to travel very, very long distance. So Assam's a huge state, and patients had to travel 10-12 hours, if not a lot more, back in the 1990s for treatment. So of course, you would know a lot of them did not take treatment. And the hospital was then set up in 1996. Now, this was an article that came out last year, which there were several reasons. I was obviously contemplating several options for my future earlier this year. And when I came across this article, I was quite clear of what I wanted to do. So there was an internal study that was done at Kachar Cancer Hospital. Some of it has been published. What you see is only about 30% complete the entire treatment. And you see the attrition rate is almost 3 in 4. 60% do not come back to the hospital after a diagnosis of cancer. And of the 40% who do return, most dropped out before the finishing line. And cut to, this is 2010, but cut to 2024, where we're doing a study right now, this isn't very different. The statistics are similar. They've gotten a lot better in terms of awareness through community outreach programs, but we're still seeing a lot of dropouts. So the hospital has adopted different strategies to try and improve compliance to treatment. So to tell you about the hospital is situated, or the place where we are is a difficult terrain, and people living in nearby districts sometimes find it very hard to come to hospitals. So home visits are made frequently, not just for those who are end of treatment, but also, I mean, on palliative care, but also for routine treatment. If they're not able to come to the hospital for several reasons, home visits are done. And given the resource constraints and difficult terrain, early adoption of technology by the leadership was key. So my director is Professor Ravi Kannan, who's here in the picture. And what we did was, there was early adoption. What the organization did was early adoption of tele ICU. So we have these high definition cameras in the ICU, and we have a critical care team that is in the south. Of course, we have doctors in-house as well. We have training programs and consultants, etc. It's an organization of 500 members, but sometimes it's not easy to get specialists. And if you're going to treat patients with advanced malignancies or hematological malignancies like leukemias, lymphomas, you see a lot of patients with a delay in diagnosis. I'll show you a couple of examples after this. You do need services of several of the specialists. And one thing that we also have is telepathology. So we can get an urgent report on the same day, even if the patient came at 6 p.m. The slides will be ready in the pathology lab, and we can get the report in about 2 hours. We also have virtual tumor boards. These include pediatric oncology groups. We treat a large number of pediatric patients as well. And we're very grateful to the Can Kids and Cuddles Foundation for their support. So to tell you very quickly about some patients that I've seen in the last 5.5 months. This is the patient who's about 35 years old and was diagnosed with CML a little while ago, a chronic phase. He was doing well. And about 2-3 years down the treatment, he came with some intense itching over his thigh and lower abdomen. And as I told you, was earlier on treatment for CML. However, his CBC shows anemia. There's a high WBC, there's a low platelet, and the peripheral blood smear confirms a CML that is now in B lymphoid blast crisis. But there are so many protocols we have to make, that we have to tailor make to our patients, because a lot of them do not want to stay at the hospital for long. A lot of them want to go home for some time, and that's about 3-4 hours away. So they develop a fever, infection. They cannot report to the hospital all the time immediately. So we normally give them SOS medications, including antibiotics. But we have to be a little careful of the intensity, because we do not want them to land up in a severe febrile neutropenia. And if there's a major flood, and if they're not able to come, then that can be quite detrimental. So this patient basically had a cutaneous lava migrans that I'd studied in all the textbooks, including Harrison's, which is the Bible for general medicine, a textbook from the US. And here, with a single dose of ivermectin, the patient was fine. The patient is presently on modified BFM 95 with dasatinib 100 milligram OD. He's on his consolidation phase and is doing well. So to tell you very quickly about some retrospective data that was published from the Hematology Cancer Consortium that was set up in 2018. This was retrospective data on ALL, and we did have a large representation of of the AYA age group. So the median age was 16 years. However, we took patients, we included patients from 1 year to 75. So the representation of AYA in this study was a lot higher than the extremes of age group. And 75% had received protocol-based treatment. Again, sad reality, which is not very different across the country. 3% underwent an allotransplant in CR1. And of course, the numbers would be a lot higher if you are taking adult patients with ALL, where the indications are also higher. And access to transplants can be very, very difficult. Even if you have all the funds, the patient does not want to leave the city. They do not want to leave their village, because leaving their village for 6 months means losing their livelihood and the entire family coming to the streets. So we have to be very cognizant of these facts. This is some work in the earlier picture that I showed you of Chitalkar sir and Shanta madam. There's also Dr. Prashant Ganeshan in that picture, who was at Adyar Cancer Institute and then moved on to JIPMER, where he led the Department of Medical Oncology and continues to serve as professor. So this was data on AYA ALL, where we've included patients between 18 and 30 years from Adyar Cancer Institute. And you're seeing a very high MRD positivity rate. It's 50%, which means the likelihood of patients requiring a transplant, that is, if the situations were ideal, is a lot higher than that number that we saw from registry data, which was just 3%. And again, if the patient is MRD positive, of course, we know at week 16, the outcomes are worse. The overall survival almost halves. From 80%, it's down to 40%. To tell you very quickly about my interest in CD20 as a marker, if patients are CD20 positive in ALL, adult ALL, there are studies to show that the outcomes can be worse. So we do have simple drugs like rituximab, and we need to, if patients are now telling me at Kachar that I cannot go, I cannot travel for a transplant, I don't want a transplant, we're obviously looking at setting up these facilities within the institute, but there are still many patients who do not want it. So then we need to look at other strategies. And this is to really see, can we incorporate rituximab in different ways in our patient population to show better outcomes. And some of these studies from MD Anderson, from the GRAL group that was published in NEJM, have clearly shown there seems to be some benefit. And is it possible for all of us across the country to come together? Of course. This was a study that was published way back in 2004 and was led by Dr. V. Shanta. Madam passed away in 2021 from the Adyar Cancer Institute, and Professor Ian McGrath, who was at the National Cancer Institute, Bethesda, USA. And this was a study where several centers, there's, as you can see, Tata Memorial is a part, AIMS is a part, Cancer Institute, of course, was part of the study. And we also have a center in Riyadh that was a part of the study. So this really, this was a corridor conversation of Padma Vibhushan, Dr. V. Shanta, with Professor Ian McGrath at NCI, saying that the event-free survival is only 20%. What can we do? And they devise a protocol. They talk about, what they can do, how they can intensify, but meaningfully without losing patients, and without losing patients because of bad infections. That event-free survival at 4 years, that was only about 15-20%, you can see has gone up to 60%. So Tata had the highest number of patients in the study. Advani sir is, of course, a part of the project, Sagar sir, Banavli sir. And you can clearly see with Tata having the highest numbers, about 652 patients, the 4-year event-free survival is 60%. So it is possible for all of us to come together in order to address questions that are relevant to our region. To quickly complete the presentation, this is another patient who we managed recently at the organization. She came in with a stage 4 gastric DLBCL. When I joined Kachar in my first few weeks, I was baffled because the average weight was about 30-35 kgs, and I'd never seen this. And, when we saw patients like this who were malnourished, we would say they're not fit for chemotherapy because they're emaciated, etc. But over time and under the guidance of my director, we've been able to, there are some patients who are fit for palliative chemotherapy. Not everyone, needs to be dismissed and said, no, this is only for best supportive care. So this was a patient with DLBCL. We were only able to give rituximab. We gave a bi-weekly cyclophosphamide and steroids. They were very regular on treatment, but somehow they've not come very recently. When I go back, we will call the patients, but they did not want IV chemotherapy. So they came in for rituximab for some time, and then we gave them oral metronomic. And the real question was, the patient lives about 4-5 hours away. Family is very nice, but it's hard for them to bring her every time. Her albumin is only 1.9. We really wanted to know, should we even, I did not want to give vincristine to this patient. I was worried about giving reduced doses of doxorubicin. So I was really wondering, should we do rituximab with Gemox in the frontline setting? Because this patient has not come back in some time for treatment. And this is another paper to show you the financial toxicity of cancer treatment in India. You see, this is a study that was led by Professor Shankar Prinja from PGI Chandigarh, a health economist and the former executive director of Ayushman Bharat, PMJ, NHA. And here we really look at, what is the cost incurred for diagnostics, medicines, what's really happening to patients. There's a lot of catastrophic health expenditure. There's impoverishment. There's a lot of out-of-pocket expenses. And how can we really address this and improve things? Of course, Ayushman Bharat for our region, for Kachar Cancer Hospital, has been an absolute game changer. We have, from the most recent data that we have upwards of 60% of our patients receiving treatment through the Ayushman Bharat PMJ. We have several other supporters, CSR funding through private and several other ICS and a lot of other organizations. But we're particularly grateful to a scheme like Ayushman Bharat, which covers the entire population. If anyone's got an Ayushman Bharat card, even if they don't, the team, the organization has a wonderful team of social workers, the nursing staff members, they're all very empowered. So they're able to get all these documents in place and we're able to start treatment at the earliest. This is again, I'm a part of the Hematology Cancer Consortium. There's a lot of work that's been done on registries, on collating this data across the country on all kinds of blood cancers. Is it possible, if you can start transplants in a center, is it possible to start your own CAR-T manufacturing facility? Where there is a will, there will always be a way. And this is work from Professor Vikram Matthews and his team at CMC Vellore, where they show you the cost of manufacturing CAR-T in-house. And the results that have come out very recently are remarkable. And solutions are in plenty. There are wonderful friends across the world who publish a lot on how the cost can be brought down even further. And if you look at the success story of ImmunoAct, of Immunil, of partnering with Tata Memorial and now across the country, CAR-T has become a reality. And we do know that CAR-T can be given even on an outpatient basis. Do you need such strong barriers for infection control for CAR-T? Yes, but maybe not as much as a haploidentical allogenic transplant. So is this more feasible in a region where there's difficult access to resources? I guess yes. I think I'm out of time, sir, so I'll quickly skip this slide. So should I? So the thing is, this is just a snapshot. I won't go every point. I won't go through every point. But this is just to tell you once again about the center where we are. So when you look at that yellow thing in between, in the map, sorry, it's Assam. And we are in the southernmost tip of Assam. And it is surrounded by Meghalaya, Manipur, Tripura, Mizoram, and Nagaland. So we do get patients from this entire region. And this is our wonderful team that's growing by the day. We hope one of the TYAcons will be organized at Kachar Cancer Hospital in the near future. Thank you.
Thank you, Dr. Nikita, and summarizing the importance of its local importance that you are practicing. And I think we should select a protocol which is simple. This is most important. Everybody in acute lymphoblastic leukemia is using BFM protocol, where patients have to come 2 times, 3 times, 4 times a week to the hospital, which is very difficult. So if you select a simple protocol, I think when you are treating in mass, those who can afford and those who want breast treatment, there are multiple options are there. Otherwise, we should make a simple protocol so the visits to the hospitals are less and less. And as you told, then some of the injection can be given at home also. Then we will able to treat more and more patients. And I think that we were also from GCR, we were part of that MCP 841 protocol.
Oh, sorry, sir, I didn't mention the institute.
That we were removed from
Oh,
protocol after
wonderful too.
because of the various logistic problem. So still I am using that HCP 41 protocol for patients who are coming from far off. So my young colleague will explain that you have to stay here and you have to stay in Ahmedabad, you have to. I explained them that you have to come just once in a week for 3 months and then once in a month only. And then they immediately accept the protocol, accept the treatment. So as you told, if you are practicing such as center and we want to treat patients in mass, then should be a simple treatment rather than very complicated protocol.
Thank you, sir.
You must congratulate her.
Yeah, also
Going
going to that.
to Assam, taking care of the patient and with a heart. Ayushman card and all other things are good, but one has to execute it the best possible way. And you are doing that.
Thank you, sir. Thank you, sir. So a lot of my teachers are here, including Hemant Malhotra, sir. So I'm very grateful to all of them for their upbringing. It's
So to add on to what Sandeep is saying, we used to have a protocol for ALL MCP 841, you remember?
That is
And
what I.
maybe the results for 70% like we presented, I don't know, not published. But 70% is not too bad, no? 60 to 70%. That's very little toxicity and much less follow-up at the hospital. So our country needs something like that.
like we have a patient now who said, he said, I'll be regular. The patient that I initially showed, who's presently on consolidation for CMLB lymphoid blast crisis. And yesterday he calls the nurse and he says, tell Nikita, I'm coming only after 3 weeks after Durga Puja. So what can we do? We cannot force him. We can't tell him to do anything. And
Thank you. You very much. Yeah, last question.
I am at the baseline of cancer control and I have traveled those areas extensively and traveling around and conducting workshops. So I'm aware of the situation, especially the distances and the other geographical challenges. So is there any way when you're working at one point, say at Chachan, that wherever there are other hospitals, do they under your guidance can continue the treatment at least some chemo protocols in different hospitals which are closer to the patient, even if it's not if there is a medical specialist?
no, Ritu madam, absolutely. Thank you for the question. So we do have, I did not talk about it in detail. We have satellite clinics also. We've set up several satellite clinics in the community. And we've also started a unit now in Tripura. And a lot of the neighboring, we have one in Manipur, in Jiribam, which is the border of Assam and Manipur. But one thing is absolutely, like there are two groups of patients. There is one group that will go out to several centers. If they can go to Guwahati and they have money, they want to go there. We don't stop them from going. So some of them come with outside protocols and are very insistent that I would like to continue this. And we continued for them. We're in touch with a lot of their doctors as well. And we send them back for their follow-ups. There are some who do not have money to go back again. And we're very happy to share our protocols or to I mean, Dr. Ravikandan's vision is to take cancer care to homes. And he keeps talking about this. So of course, that's the goal, to take it everywhere.
Thank you very much, Dr. Nikita. We will now be having Dr. Vikram Gota from Mumbai, who will be joining us virtually. He is going to talk about pharmacology in adolescent and young adults cancer therapy. Because obviously, like we said, when you choose protocols, toxicity, and how the body will be treated plays a very, very important role, not only in the outcome, but even in the compliance. So we will have Dr. Vikram Gota from Mumbai joining us. So are you there?
Yeah, I'm here. Can you hear me?
Yes, sir.
Yeah. So do I have permission to share my screen? Yes. No, I think you'll have to enable me to share screen, please. Can you please enable screen share for me?
Yes, sir, you can share the screen.
Okay.
Dr. Vikram, you can realign your camera.
Yeah. All right. So first of all, very good morning to all of you. And I'm sorry I could not make it in person for various reasons. But I am really thankful to Colonel Chitalkar for giving me the stage to talk about the pharmacology of cancer therapy in IA patients. But disclaimer. I mean, I might have missed the memo. I mean, I did not realize that this is going to be the hematology track. So my presentation includes both hematology and solid tumors. But just that perhaps I did not realize that I'll be speaking in the hematology track. So please bear with me. Although I'd like to stay focused on hematology, to whatever extent I can. Okay, so in the next 15 minutes or so, I'll be talking about the pharmacology of cancer therapy in IA patients, and I'll be talking about the gap in IA therapies, the statistics, hybrid model of IA chemotherapy, and then a little bit about targeted therapies and immune checkpoint inhibitors, and the main issues in the treatment of this subset of patients in terms of long-term survival and fertility issues. So typically, IA is described as a population in the age group of 15 to 39. So they have a very complex disease biology, maybe sometimes very different from the pediatric biology, and also perhaps different from the adult biology also. So I mean, generally, a lot of things goes into the consideration of treatment protocols for this age group of patients. But what is typically exists in terms of consensus is that pediatric type protocols should generally be used for diseases such as leukemias and sarcomas, and adult type protocols should be used for breast cancer and colon cancer. Okay, so it is unique from this cancer diagnosed in other age groups because of important distributions in cancer types, intrinsic and extrinsic risk factors associated with this age group. The tumor biology is definitely different, and so is the prognosis and survivorship. So one of the important gap in terms of the IA patients is, of course, we have to address the survival issues because they are living longer and longer, as the statistics would indicate, and therefore, the survivorship programs becomes very, very important, and strategies to mitigate toxicities, especially late toxicities, will become very, very important. And this age group has a slightly lower participation in clinical trials, as also the the previous speaker also spoke about, their access to certain treatments such as bone marrow transplantation and so on and so forth. And consequently, there is lack of age appropriate treatment protocols. And some of the other maladies that kind of plague other age groups, such as delayed diagnosis and limited access to sophisticated care, also apply to IA group. But importantly, financial hardships are can be one of the more unique features of this group, because many of them will be kind of bread earners for their families especially in the third and fourth decade of their life. So a lot of things depend on their ability to kind of earn, and therefore being away from work, and those issues may actually cause a lot of issues in terms of follow-up and treatment. And of course, there are a unique set of psychological treatments associated with the age group itself, and also a slightly disease, a different social burden that is present on this age group of patients. So, if you look at the statistics of eye cancer, cancers in as of 2020, you can see that in the second decade, it is mostly the thyroid cancer and the lymphomas, and the lymphomas tend to kind of decrease as we go into the third and fourth decade of life, and then there will be the onset of breast cancer, in the third and fourth decade, which is very characteristic. And soft tissue sarcomas also tend to decrease as we go from the second decade all the way to the fourth decade, as shown in the graph here. And this is the statistics from United States of America for 2020, which pretty much shows the same type of information that was present in the earlier graph, with thyroid topping the total disease burden. I mean, this is just crude numbers. So thyroid disease, topping the total disease burden, followed by various other cancers in different age groups. And you can see that the breast cancer kind of makes its appearance in the third decade, and soft tissue sarcomas kind of go down over as we go from move from second decade to the fourth decade. So now, we spoke about the type of treatment models that are required for this group of population, especially in terms of whether we should lean towards the pediatric or the adult type. So some of the foundational principles of treatment of IA is a hybrid model. So wherein we have to adopt an individualized treatment based on specific disease biology, clinical presentation, and patient characteristics. So there's a lot of individualization that may be required. And as I said earlier, the pediatric inspired protocols may work better in ALL, certain types of sarcomas, which are more intensive and prolonged in nature. But one must understand that those treatment protocols are also associated with a slightly higher risk of toxicities in older IA patients as compared to the pediatric age group, which generally are more resilient and tend to kind of tolerate these treatments better. So if you go by the cancer types and the chemotherapy, and if I have to stay focused on hematological malignancy, so for ALL, these are the drugs which are commonly used. And as I said, for pH negative ALL, it should be more pediatric inspired regimen, and targeted therapies should be used in pH positive ALL. For Hodgkin's, of course, there are several options available, including ABVD, BCOP, and so on. But the choice between adult and pediatric protocols is individualized based on efficacy and long-term toxicity. So this is where the individual patient's presentation, becomes very important in terms of how well preserved they are, and what is their whether they have any predisposing risk factors for toxicity. And based on that, we may have to choose the right treatment. And as we go down to some of the solid tumors, like for example, thyroid cancer is typically, chemotherapy doesn't have much of a role, and more the thyroid cancer is moving towards targeted therapy, targeting BRAF, MEK, and RET. And if you look at melanoma, it is mostly immunotherapy. So this is a very interesting graph showing the trend of cancer incidence in the IA age group from 1975 to 2017, which is over a four-decade period. And you can see that the incidence has almost increased by 50%. Okay, from let's say 17 per 100,000 to about 25 per 100,000. So there's almost a 50% increase in incidence, and that is true for across all age groups. I mean, be it the second decade, third decade, or the fourth decade. And because of the advancements in treatment, you can also see that the mortality per 100,000 is decreasing across all age groups. And so what this graph does is there is almost a three to fourfold increase in survival in this patient subgroup, which means that we should be thinking more and more about the problems associated with long-term survival and mitigation of late toxicities and so on and so forth. So if you have to move beyond traditional chemotherapy, like for example, if you look at ALL for Ph positive, the TKIs such as imatinib, dasatinib, and nilotinib are approved. And for acute myeloid leukemia, there are drugs to target FLT3 mutations and IDH and BCL2 mutations as well. And these are approved targets for the treatment of acute lymphoblastic leukemia. Acute myeloid leukemia, sorry. And for Hodgkin's lymphoma, we have the antibody drug conjugates in the form of brentuximab vedotin, which targets the anti-CD30. And for relapsed refractory cases, even PD-1 inhibitors such as Pembro and Nivoc are also considered. And these are approved in specific lines, and they're also kind of subject matter for research in the future as well. But there are, of course, long-term risk factors associated with some of the chemotherapy that are used in this age group, such as doxorubicin, cardiomyopathy, heart failure, increased cardiovascular disease risk, bleomycin associated with pulmonary fibrosis, lung scarring, and so on. Cisplatin, renal impairment associated with cisplatin, neuropathy with vincristine, and then primary ovarian insufficiency or infertility associated with alkylating agents and risk of second malignancies. And there are certain risk factors also associated, mostly which is related to the cumulative dose of the drug. For if you look at drugs like doxorubicin, bleomycin, cisplatin, and so there's generally a ceiling beyond which you are likely to expect toxicity. And specific risk factors for drugs like doxorubicin include history of chest radiation, or it could be exposure to high risk oxygen in case of bleomycin, because that can lead to more and more free radicals being formed, and these free radicals can be responsible for bleomycin induced lung injury. And for alkylating agent, there are of course high dose therapy as in bone marrow transplantation, and female sex are associated with this one. So one of the things that we could consider is, of course, identifying the propensity for this risk to develop, and then maybe go for dose adjustments or some mitigating strategies. And in that regard, here at Tata Memorial Center, we are working a lot on developing, let's say, radioprotective drugs or chemoprotective agents, and we are working on organoselenium compound, which may actually prevent, pneumonitis or pulmonary fibrosis. In the context of bleomycin, and that drug will be going for phase 1 clinical testing very, very soon. Because we are in the process of submitting that protocol to the DCGI. And in fact, it was initially developed for the prevention of pneumonitis associated with the chest radiotherapy. But more and more, we have preclinical evidence to believe that the same drug can be useful for the mitigation of pulmonary fibrosis associated with bleomycin as well, from what you can see in the rat mouse data. So these are some of the strategies that we may have to adopt in order to ensure that we minimize the toxicities in patients going forward, especially because they tend to live longer. With the current advancements in targeted therapies and immune checkpoint inhibitors and so on and so forth. Okay, and of course, there are. So one thing I forgot to mention, when I was talking about ALL, is, asparaginase is one of the most important drugs for the treatment of ALL. And from our own group and also from TMC Kolkata and several other groups across the globe, there are several reports which indicate the poor quality of asparaginase, and and not being able to kind of meet the required exposure. Like for example, the 100 units per liter exposure that is required at trough. Many brands are not able to kind of achieve those kind of concentration activity, aspiration activity in the blood. And many brands are also having a lot of host protein contamination, which may be responsible for higher immunogenicity and so on and so forth. So these are some of the issues that are very unique to our country, and not just the IA group, but the entire spectrum of patients, from pediatric all the way to adults, are kind of are targets of such inferior drugs. So we have to develop strategies, for those situations, as well as to, what should one do if the asparaginase exposure is less than what is necessary. So should we increase the dose, or should we increase the frequency of administration? So one of the things that the Kolkata group has done, and I think quite successfully, is that the native asparaginase, they have increased the frequency of administration from every third day to second day, and they seem to be having better outcomes with asparaginase treatment. So these are some of the adjustments that one may have to do in the context of the drug quality issues also that are unique to our population. So the key takeaways from my talk would be that treatment of FIA is not a one-size-fits-all approach. So we have to kind of individualize treatment based on the biology of the disease, and also based on the patient who is presenting with the disease, certain whatever unique features. Assessing the patient for potential toxicities, and taking steps to kind of mitigate them. And then a more intensive pediatric inspired regimen would be definitely appropriate for some cancers such as ALL and some select sarcomas, and but they're also likely to be more toxic in the long run. And therefore, it requires comprehensive multidisciplinary care, essentially to address the unique biology, psychology, and socioeconomic challenges associated with this group of patients. And the therapeutic focus is rapidly evolving. As I said, chemotherapy is taking a backseat in many of the indications, and then it is more and more getting replaced with targeted therapies, immunotherapies, and maybe CAR T cell therapies, as the case may be. So which is kind of which occurs well for this age group, and which is likely to enhance the outcomes even more going forward. And increased lifetime risk of chronic diseases, infertility, and secondary malignancies definitely exist. And one should be cognizant of these problems, and it should be associated with appropriate counseling of patients, and use of suitable alternatives wherever applicable. So with this, I come to the end of my talk, and I would like to thank the organizers for this opportunity. And if there are any questions, I'll try to answer.
Thank you, Dr. For summarizing the pharmacology in IA patients. We can allow only one question if there are. I think there are no questions, so we will move ahead. And now from malignant cases, now we'll go to the benign part, and we'll discuss emicizumab in hemophilia patients, hemophilia A patients. And I will invite Dr. Pavlin for giving a talk.
Yes, sir. અહીંયા છે ને આનાથી જ થઈ જશે મેડમ ને પારોલ ભટ્ટ ઉપર અહીંયા અચ્છા તમારા સ્લાઇડ આવી છે નેક્સ્ટ કરજો નેક્સ્ટ પ્લીઝ
Good morning, all. Thank you very much, organizing committee, for having me here. This is really from cancer to the bleeding disorder, moving from the change topic. This hemophilia, it is a X recessive bleeding disorder transmitted from parents to the children. Mainly son is affected. 50% chances of effect of the carrying the hemophilia to the son, and the daughter become the carrier. And now we are moving forward. There is 360-degree treatment changes. We evolved in the treatment of the hemophilia, but still we are lacking about the diagnosis of hemophilia. In India, there is still 33% diagnostic rate, whereas in US and UK and Australia, there is 100% diagnostic uh, rate. So still we have to move forward for the more and more diagnosis of the hemophilia. But there is a treatment is really revolutionized, and the patient become a normal, they live like a normal life. So this emicizumab has given an excellent result to the treatment in making the patient normal life. So we'll have a few slides. Hello, it's not changing. It's from here. So this is my disclosure. As I already mentioned, there is a revolution in the treatment from the blood component to the recombinant factor towards the monoclonal antibody like emicizumab and concizumab and the gene therapy. So we move forward too much in the treatment part. But the IV injections, there is limitations because they have to come very frequently, and IV access is very difficult in pediatric age group. So there is a revolution in the another form, that is a concizumab, that is emicizumab, and the monoclonal antibody has been evolved, that is mainly the emicizumab. It is how it acts. It mainly the bridge between the activated factor 9 and factor 9 in the thrombus formation. And there is factor 8 deficiency in hemophilia A, is patient is not been required the replacement of this therapy. So in that case, it is directly very rapidly acting, and it restored the coagulation by bridging the activation of the factor 9 and the factor 10. And it is used subcutaneously, long half-life, that is 1 month, maintain steady state in the plasma, providing sustainable protection in the bleeds, and it is not expected to induce or produce any inhibitors. When we replace the factor 8, it can initially, after 50 exposure, there are chances of the inhibitor development, and that require the factor 7. So these are the benefits of this molecule. So it you can say in another way, it helps in the mainly the activation of the factor 9 and the factor 10 to make a thrombus formation very rapidly. So some clinical trial help us to understand how it been beneficial to the patient, those who are suffering from hemophilia A. So mainly it has been indicated in hemophilia A when there is a factor 8 deficiency with and without inhibitors. In all age group, it has been indicated, especially from the age group less than 1 year, that is in infants. This is the only drug which is available for treatment of hemophilia. So because it is why unique in the treatment of the hemophilia, because the PK value will remain constant after more than 45 microgram per ml, even after if it is given once weekly, even it given twice weekly, or even if it is given once monthly. So in all phases, you can see it maintains the trough level in the blood that helps the person to prevent any spontaneous and traumatic bleeds. So this is a trough value which remain in any dose the similar, and every time it is more than 45 microgram per ml. So drug is available in form of all these doses. Main important, it can be used subcutaneously, no preservation is required, and the temperature is not much important to keep it. It can be kept at 2 to 8 in the freeze, normal freeze, and it is available in the strength of 1.5 mg per kg once weekly, can be given 3 mg per kg every 2 weekly, and 6 mg per kg 4 weekly. And it is available into 30 milligram per ml, 150 milligram per ml, 150 and 150 milligram per ml. So important of this dose is that only we have to keep in mind 2 ml cannot, more than 2 ml cannot be injected at a time. There is a combination of 2 vials should not be there. It should be adjusted. So we are keeping our dose in such a way that we bring the 2 or 4 patients together, and we can adjust the dose at simultaneously. So the half open vial cannot be kept for the second dose. So various studies help us to understand how this drug giving rise to the bleed free in the patient, those who are suffering from hemophilia A. These are the Heaven 1 to 7 study, Homo-AMI study, and Census studies, which includes all the patients, those who are having hemophilia, including both more than age more than 12 years, less than 12 years, those who are having inhibitors for factor 8, less than without inhibitors, and including those patients who are less than 1 years of age, and all the doses has been covered. That is, some patient given 1.5 mg, some patient weekly, then twice weekly and monthly. So all the doses has been checked. All the categories of the hemophilia has been included in Heaven 1 to 7 studies, and HO-EMI and Census studies also include the both adult and pediatric patients. So as I mentioned, it is included both the patient, those who are having inhibitors and those who are not having inhibitors. And all the doses has been checked. So what are the endpoint for these studies? The aim is meant to describe the long-term efficacy and safety of the emicizumab, especially in Heaven study 1 to 4, and mainly to see is there any treated bleeds are there or not, or all other bleeds are secondary point, like the spontaneous bleeding, or there is joint bleed, or target joint health has been checked, and the adverse reaction has been checked. So the results are very promising, and it is really in practical world when we are using, we are also getting the same result. So in this study, you can see that actually when the patient of hemophilia we get, our goal is not to get the ABR or annualized bleeding rate to 0, but it should be up to 3 can be also considered. But in that 1 to 3 bleeds per year can also be considered as a normal. So there it reduces the joint deformity. So in this study, you can see 95% patients are treated bleeds. Even 95% patients are having treated spontaneous bleed, and joint bleeds also the same. But you can see very important in this slide is that both the categories like 0 bleed as well as less than 3 bleeds, 100% achievement with the emicizumab in Heaven 7 1 to 4 Heaven study. And important is that as the duration is increases from the months to the years, that is from 6 months to the years, then patient will have a more and more benefit. So in another graph also we can see as the duration of the treatment increases, the benefit will be the more. So whenever we ask the patient, when we counsel to get them ready to get this injection, this is very important to teach them or to counsel that as the duration of the treatment increases, you will be benefited more and more. In that, there is the ABR will be also reduced, and there is a joint health will also increase. And another one is that the target joint resolution, that is healing of the target joint, is very, very unique effect of this drug that will help by 95% target joints will be healed after the chronic treatment. And this is been very promising for those who are already been damaged when this drug was not available, and from pediatric age group, those who are has already on the replacement therapy by the factors. These are the promise in the form of that the patient joints become normal. So overall, the adverse reaction also been checked, and there is no serious adverse reaction has been found. However, the number you can see is 144 patient develop a serious adverse reaction, but the serious adverse reaction in this study, they were included not as serious anaphylaxis or hypersensitivity. Systemic hypersensitivity. This is simply just like a cough or something like abdominal pain or vomiting. So there is no serious side effect has been found, especially there is no thromboembolic any side effects has been found in this patient. So overall, Heaven 1 to 4 studies conclusion is that there is a long-term follow-up indicate that patient with hemophilia treated with Hemlibra continue to experience improvement in control of the bleeding and the target joint resolution. There is a mean ABR reduced over a time with Hemlibra prophylaxis, and according to the proportion of the participants with the 0 bleed as well. And the Hemlibra maintained the low bleeding rate in a broad spectrum of the patient with the hemophilia, and there is no development of inhibitors, as well as there is a potentially the patient is having same effect those who are not having joint involvement and those who are started taking at the adult age. And over 90% of the patient target joint has a 0 spontaneous and traumatic bleeds, and 95% of the all target joints become resolved. That is, the healing of the joint will be done with this drug. So it is a well tolerated. Overall safety concern is not an issue, and it is follow up as consistent with the report is a primary analysis. So heaven 1 to 4 conclusion will help us to decide the line of treatment. But these are the international studies. Some question is always come that what are the national data that help us to decide the line of treatment in our patient, because genetics will change. So this is a very important Indian study that help us to again decide the line of treatment in hemophilia A. And here the patient has been decided. It's very important. Then all age group patients are included, all inhibitors and without inhibitor patients are included, and the criteria has been checked about the ABR, then joint health as well as the quality of life is also been checked. So it is the study for 24 weeks in the Indian patient. And all these criteria, as I mentioned, but very importantly, it has been included into mild, moderate, and severe. All category of hemophilic patients are been included in these studies, and the joint health has been calculated as well as the quality of life has been. So these are the various score they have calculated. And promising result we got is the patient's joint health has improved in form of both, that is HHS and FISH score has been improved a lot in both the ways. The FISH score will improved and the HHS score has also been improved. The patient become independent, and previously they were required the support because of the joints involvement. And of course there is a, you can see the previously before starting the emicizumab, there is a annualized bleeding rate was very high and the joint health was not that good. And after the starting, we can see it like this annualized bleeding rate ABR reduced to 1.95, that is less than 1, and the joint health improve like anything. There is no spontaneous bleeding, no traumatic bleeding, it reaches the 0. And of course, because there is no bleeding and there is no fear of getting the bleeding, because there is no spontaneous and traumatic bleed, which is no micro bleeds are going in the joint. There is simple, there is no pain in the joint. And then there, of course, there is always the improvement in the quality of life. So these also show that is both the score, like is European 5D, 5L score as well as VAS score of the quality of life is improved drastically in the both the in the patient, those who are both age group less than 12 years and more than 12 years. So these results conclude that the based on this Indian study that emicizumab significantly reduce the bleeding, enhance the joint health, and improve the quality of life in patients who are living with the hemophilia A. And it is associated with because of this, there is a high adherence to the prophylaxis and suggested that feasibility of the treatment, and especially it is in the resource constrained country like India. Still we are having a difficulty in getting factors sometimes, and we are more and more patients are add on. So this is really very important finding in the Indian perspective. Another study has been done for an Indian patient in the pediatric age group. They also found that this is the any ABR has been reduced or not, or whether there is any joint health improvement is there or not. So of course there is a, you can see that is a very small in graph, there is blue line, that is bleeding after emicizumab prophylaxis reaches up to the baseline. Previously it is very high. So it is a pediatric age group also getting a benefit, and this is very important at the pediatric age group because of the sub-Q injection, and there is a no bleeds, and there will no absence from the school, and there is a always there is academic, there is a benefit for the students, and psychologically always affect the age group, because if the one day left from the school, there are lots of homework getting together, and there is always a pressure on the children. So this is how it helps the quality of person. So of course, there is a 97.8% reduction in the ABR, as well as there is a overall health improvement in the person pre and post. And you can see that after the prophylaxis, the target joint 100% joints in the pediatric age group, because there is no joint damage previously happened. There is 100% joint in reduction, 100% reduction with the joint bleeds in the those patients who are already put on the emicizumab in the pediatric age group. So these Indian data is also going to be very useful when we use it in such patient, and that will help us definitely to improve the overall health of the patient when they become adult. So when we see about the S, because it is a monoclonal antibody, when we look about the cost effectiveness, of course, there is a requirement, the indirect cost and direct cost, both will be reduced because there is less frequent hospitalization and there is a less other emergency treatment requirement, like including factor 7 replacement and all other, and the less development of the inhibitors. So inhibitor treatment also been require not in special category. So all these costs will be less when we put the patient on the emicizumab. It is a long term, it benefited. So overall, when we think about the treatment of any bleeding disorder with the hemophilia, we have to see that all these criteria is to be fulfilled, and which can be fulfilled with the emicizumab, that improve the quality of life, reduce the healthcare burden both by direct and indirect cost of the patient, and long term cost savings is of course is the concern for the all, both the hospital as well as the patient as well, to coming to the hospital, getting leave from the job, that all will affect the sometime. So this all and increase the productivity, there's in form of the increase there is quality of life. So all these key value will be addressed by the emicizumab when we start as early as in the life. So that is why, because of this unique potentiality of this drug, and there is 360-degree change in the treatment protocol of the hemophilia. World Federation of Hemophilia has included in the guideline of this drug. And because previously it has been on-demand treatment was going on, but the WFH has promoted that only the regular replacement in form of prophylaxis is the treatment to prevent the joint involvement and the disability-free hemophilic patient. And that is why only prophylaxis has been indicated in all the patients, those who are mild, moderate, and severe. On-demand is not been promoted, just to prevent the disability and to make the patient disability free. And that is why the consensus has been passed for the emicizumab, that patient with hemophilia having inhibitors, those patients with hemophilia with inhibitor, Hemlibra should be used in a regular prophylaxis. For patient with hemophilia with a persistent inhibitor who failed to ITR, also been given a Hemlibra. And the patient without inhibitors also, there is the WFH recommend that the Hemlibra can be used for the regular replacement. So it has been included in the guideline, and it should be used very thoroughly. All the patients, those who are indicated and those who are having hemophilia A. So this is our international team working for the hemophilic patients' benefit and keeping them disability free. And this is our national team working for the hemophilia. This is our team working at Sola Civil Hospital in medicine department exclusively for the hemophilia. We have a 24/7 hemophilia daycare center, and we are treating patient every day. More than 50 patients are visiting our for regular replacement. And this is what our patients support with us, and we are giving the result with the support of the pharma patients and our staff. All together, a teamwork, we are giving excellent result to our patient. The patient, those who are coming previously on stretcher, they are standing, supporting with us. So these are our hemophilia data at the medicine department at Sola. That is mainly, you can see all the patients are on the regular replacement therapy, including all mild, moderate, and severe. And we have in Ahmedabad, there are 350 adult patients are registered under the hemophilic center. 242 are coming to the Sola hospital because of the highway connectivity and easy availability. We kept our hemophilia daycare center ground floor near the trauma casualty. Within a one step, they can reach to our center and can see the most of the patient on prophylaxis. And very wonder of this slide is you can see the requirement of the factor 7 in last 1 year is very less, only 1. So that gives a result that how it is important to give the regular replacement therapy. Thank you very much for patient hearing.
We all agree that emicizumab has changed the life of hemophilia patients, particularly with inhibitors, and that totally the life has changed with this drug. And I think Gujarat government is providing it free for
Free
most of the patients or with inhibitors. It is providing free
Yes.
for all the patients.
It is available free of cost, both factor 8, factor 9 and the emicizumab, that is free of cost, and it is available round the clock.
Provided with to the patients with inhibitors only and to the pediatric patient.
Now it is being used for both the patient, but the request for the all the hematologists only to help us to increase the diagnosis of the hemophilic patient more and more. We have a more program on the awareness about the diagnosis of. Still, we are lacking about only 33% rate of the diagnostic rate right now.
So madam, one question, there are incidents of development of antibodies against the molecule.
For emicizumab, there is no chances of development of the inhibitors. And
Protein, how can you say that there are no chances?
however, this study shows there is a no monitoring is not required. Clinically, also we are using since last 2 years, and there is no chances of development of the inhibitors against the this thing, because it is a very low dose we are using, and however, there are no data suggest there is any chance of development of inhibitors.
What will happen to the gene therapies for hemophilia now, which are very.
Yes. We are stepping in the gene therapy, but still it is not been approved from the government. However, 5 patients has been studied in the gene therapy, and they have excellent result. They become near normal, because there is a normal production of the factor started, factor 8. But the important thing, if it is very costly, it costing 25 crores once in a time. Number one, it is not included into PMJ. Number two. And number 3, it is still required more safety protocol, because once it fails, again we have to go to back to the factor therapy. So that is cost is the main constraint right now, but it is the future. Right.
Comment on the group analysis of lot of us have used it and we have also used
Yes,
it.
sir. Absolutely. See, these are the clinical trials, but important is when you treat the patient, your clinical feature, because normally we are not supposed to check the level of the emicizumab in the blood, but the clinical features help us to say that patient is maintaining normal. So chromogenic assay about the emicizumab is not required clinically only. In that case, in our practice, in clinically, we are using very low dose, because as it is very costly, as well as the more and more patient will get the benefit. We are using at our center in adult 1.5 mg per kg monthly. And we are looking the patient. Some of them are been on 2 mg per kg per monthly, but it is very convenient for them to come to monthly for sub-Q injection. So that can be per person to person, individualized we can do. But yes, however, it is a monoclonal antibody and it is a very costly drug. We can start with the low dose. However, they already been mentioned in the study that both have a PK value will be the same. Like if we give 1.5 mg, the low dose is also same effective. So better is to give the low dose. So we have a very good experience with the low dose.
Thank you very much, madam. We'll end the session here.
Thank
Already behind the time.
Thank you. Thank you.
Thank you, sir.
Thank you, ma'am. Thank you, Dr. Sandeep Shah, Dr. Anupa Joshipura, for your valuable time. Now I would like to invite the chairperson, Dr. Hemant Meghnani, Dr. Jalpa Soni. And the speaker for this is Dr. Hemant Malhotra, and his topic is on hope beyond the relapse and reoccurrence, cellular therapies on leukemia and lymphoma. Thank you.
Thanks.
So honorable chairpersons, my good morning to both of you and all of you. Like my pleasure and privilege to be here. And I'm going to be talking a little bit today about relapse and recurrent lymphomas and leukemias and focus on cellular therapies. And grateful to the organizers for this opportunity, particularly these 3 gentlemen shown on the slide. My very dear friend Colonel Chitalkar, also my very dear friend Dr. Bhavesh and Dr. Meklani. So this is what I intend to do, a few slides on introduction, then why immunotherapy and focusing on the T cells is important in relapsed refractory disease. Then few words about a BALL relapse, CAR T cells, BiTEs and ADCs. DLBCL, CAR T cells, bispecifics, antibody drug conjugates. Spend a few minutes on telling you the data about the Indian CAR. So I'm not talking about the Maruti 800, but I'm talking about the chimeric antigen receptor T cell, which is being manufactured in our country now. And then I'll conclude. So Prakash has given me 25 minutes, if I'm not wrong. Maybe 1 second per number of gray hairs I have. So I appreciate that. But we'll try and finish in on time. So let's talk about ALL first. And since the time when some of us, like Colonel Chitalkar and myself, started oncology, the improvement in ALL treatment has been phenomenal. So this is one of the best centers in the world. And if you see the box which I have made, treatment of more than 1,000 patients of ALL between 2000 and 2020 in these 2 decades. The survival is more than 90%. So you cannot have a more curable cancer than ALL. But this is the best center of the world. The ground reality, if you trickle down to India and if you trickle down to other low middle income countries, is that here in our country, in each of our cities, we are still able to cure about 3/4 of the patients. So 70 to 80% patients in our settings, resource limited, money limited, more infections, we are still able to cure 3/4 of our patients. But relapse remains a problem. About 15 to 20% of ALL patients who achieve a complete remission will have relapse. And this has been estimated to be about 10% out of all childhood malignancy. And once there is relapse, the outcomes are not very good. Whatever you do, whether you do intensive chemotherapy, whichever protocol you use, or you use one of the fancier, much more expensive treatment, the outcomes are not very good. But with the availability of CAR T cells, with the availability of antibody drug conjugates, with the availability of bispecific T cell engagers, we are slowly improving the event-free survival and the overall survival. Most of the relapses are in the bone marrow, the medullary relapses, about 60%. About 1 in 5 patients can have isolated CNS relapse. And if you look at isolated testicular relapse, usually happens late. Late relapse is beyond 3 years of treatment in about 50% of patients. And if you look at CNS relapse, it usually happens early in about 40% of patients and intermediate in another 40%. Late CNS relapse is unusual. So there are several prognostic factors which we consider when we plan the treatment of a patient of ALL who has relapsed. And the most important one is the length of the first complete remission. So the sooner the patient relapses, the more resistant disease the patient has, the more resistant clones he or she has, and the prognosis is worse. It generally believed that only extramedullary relapse with a normal marrow, their prognosis is a little better, and patients with T cell ALL who relapse, they do much worse than B cell ALL, and that is probably because we don't have a cellular therapy or we have a less effective cellular therapy for T cell ALLs as of just now. So there are several risk stratification strategies which are used. I wouldn't go into the details. You have the BFM group, you have the COG or the Children's Oncology Group of North America, you have the Cancer Children's Study Group in the UK. They have all devised their own risk categories. And why are they important? Because if you categorize them by risk, the patients, you can predict their event-free survival and overall survival. The most popular chemo regimes, I'm not going to spend much time on this, go through this very quickly, are the various BFM regimes. And you can see that with the current BFM regimes, for patients who are good relapse risk, the prognosis is not bad. But however, for the patients with intermediate and low risk scores, the prognosis is still not good, and a lot of work needs to be done. In addition to the BFM, there are several other protocols, which again, I will not go into the details because my focus today is going to be on cellular therapy. Of course, there is a debate between chemotherapy in second complete remission and transplants. And there are several trials which focus and favor the transplant. There are several trials which focus and favor chemotherapy. Again, not spending too much time on this. But in the third CR, there is uniform agreement that a transplant will benefit the patient. Several new drugs on the horizon, some of them available to us, clofarabine, neuro-oncology. This again is available in India, though it is quite expensive. They have made small inroads in the treatment of relapsed refractory ALL. So now we shift to the focus of the day, cellular therapies, the bispecifics, and the antibody drug conjugates. So all of these, by and large, act by making our T cells more effective. And what is needed for T cell activation and T cell effectiveness? There has to be recognition of the MHC, there has to be activation of the T cells, persistence of these cells, and some memory phenomena, so that as soon as the leukemic cell rears up, the T cells, circulating T cells, can recognize these leukemia cells and attack them and remove them from the body. And why is the T cell not able to do this? This is primarily because of T cell exhaustion. And this is supposed to be due to loss of antigen presentation, suppression of the T cell population by various cytokines, which the tumor cell releases, and the T cell checkpoint dysregulation. So now we have mechanisms and ways and means to overcome these mechanisms of T cell exhaustion, so that you can re-energize the T cells and make them active again to detect the cancer cells and to remove the cancer cells from the body. So these are the strategies which we use. Target immune checkpoints to prevent immunosuppression, promote tumor cell phagocytosis, improve the malignant cell interaction with CAR T cells, and activate the T cells and the NK cells using bispecific antibodies. So let's come to the use of CAR T cells in BALL. And this is one of the first patients who was treated with CAR T cells, UPEN, at the UPEN. She was 5 years old, relapsed after 4 lines of treatment, including stem cell transplantation. The patient's name is Emily Whitehead, and she's now 30 years old, and she's been declared cure of her leukemia, and the first cure of the CAR T cells, providing us the proof of concept that these therapies can be curative, at least in a few patients. So this is the CAR T cells approved for B cells in the United States. 2 products, the Kite product and the Novartis product. I've never been able to speak out the names, so you can read the names for yourself. And some of us agree with that. And this is the pivotal trial which got the approval of the Kite product, the Zuma 3 trial, and for the Novartis product, the Elena trial. And we have long-term results. About 40 to 50% patients are in event-free survival after several years of post-treatment. Several issues and problems with CAR T cells, like you have to select the patient very carefully, because usually the patient has cytopenias and you worsen them with CAR T cells. You have infections, you have low lymphocyte counts, and the consequent consequences. Some of these patients are post-allogenic transplant with the associated immunosuppression. Some of them have some degree of graft versus host disease already. some of them have been exposed to the newer drugs like blinatumomab and some other molecules, which again complicates administration of the CAR T cells. But there is 3-year data now, and there is 5-year data now that CAR T cells are effective and can produce a 5-year event-free survival in close to half to 2/3 of the patients in which they are used. So there is absolutely no doubt that this is a huge advance in the treatment of relapse refractory B-cell ALL. But patient selection is the key to success. There are a few of us. Chirag is here. He's a hands-on user of CAR T cells in quite a number of patients. You can expect a 40% event-free survival. You can reduce the number of patients requiring allogeneic transplant, but there are several questions which remain. Which patient and when to send for CAR T cells? Can you use upfront in refractory disease for patients who have persistent MRD, patients who are not in remission? What about the other molecules, say antibody drug conjugates or the BiTEs? Should they be used upfront? Should they be used after CAR T cells? That again is a question which is still being debated. And then if you do a CAR T cell, then is allotransplant a must? Or should you wait for the patient to become MRD positive and then do allotransplant? That again is a question which is still being debated. So let's now move to the BiTEs and the ADCs in the ALL. I'll just give you a snapshot of the molecules which are available, not going to the details, doses, and toxicities. So blinatumomab is again a game changer in the field. It's a bispecific T-cell engager, and this is the pivotal study, blinatumomab for MRD positive adults with pre-B-ALL. And here you can see the key points. ALL in hematological remission after chemotherapy, almost 3/4 of them achieved MRD negativity with blinatumomab. And complete MRD responses after blinatumomab was related to significantly improved overall survival. And then a recent paper from a poster from the ASH, in which the blinatumomab was used as consolidation, and this also improved the overall survival in newly diagnosed adults with BALL. The other molecule which is making waves is inotuzumab, and this is available in our country also. This is an antibody drug conjugate targeting the CD22 molecule, which most of the pre-BALLs express, and it can be used as induction therapy. And this is one particular study, the initial one study, in which the CR rates in a poor prognostic subset was 100%, MRD negativity was 90%, and the 3-year event-free survival was 55%, which is again very impressive in this particular subset of patients. What about a chemo-free combination? So people are now using inotuzumab in induction. This is the Allianz study, and using blinatumomab in consolidation. And event-free survival of 75%. Again, a small study, only 33 patients, but very exciting study. And I'm sure that this is going to move into phase 2, phase 3, and we're going to see some very exciting results in the future. So, ladies and gentlemen, in relapse BALL, the paradigms are shifting. In addition to just chemo and the various chemo regimes, for the fit patient, we are now thinking of consolidating, and for the patient who is MRD positive with blina plus transplant or a CAR T cell. And for the maintenance, maybe low dose inotuzumab might be the best way to prevent relapse. For the patient who is unfit, inotuzumab is a good option. And for the patients who are MRD negative, I mean, you can think of continuing Blina with chemo and keep the CAR T in reserve and with our standard maintenance. So the paradigm is changing very rapidly. And for the 20 odd percent of patients of ALL who relapse, we might have some really effective treatments in the near future. What about high-grade large cell B-cell lymphomas? Let's talk about the CAR T cells first. These are the 4 products which have been approved. Again, difficult to spell out the names, but the US FDA has approved these 4 products. Primarily, we have these 3 products which are used and available. We have the Zuma 7 study, we have the UPenn study, and we have the Transform study, on the basis of which these molecules or these cellular therapies have been approved. And there are lots and lots of publications. I don't think I can go through all of them, but they do produce disease control, event-free survival of 50% plus in most patients. We have bispecific T-cell engagers and antibody drug conjugates for the diffuse large B-cell lymphomas. Again, a whole plethora of literature is available. Glofitamab is the CD20 targeting BiTE, and the pivotal study, the median follow-up of 12 months, and you can see the CR rates, complete response rates of almost 40% in heavily pretreated patients, and objective response in more than half of the patients. So again, an extremely effective treatment for relapsed large cell lymphomas. So the question to most of the experts is, does the BiTE cure relapsed refractory lymphomas? Some of them answered this as yes. And the basis of this is this flattening of the curve, no further relapses after a certain period of time, after 2-3 years. And this is what is giving us hope that we might be curing a small percentage of patients of large cell lymphomas who have relapsed. Now, which treatment to use first? I think our hematology colleagues are still debating that, whether to use BiTEs first, or whether to use CAR T cells first. So that race is on. CAR T cells have a 40 to 50% durability, while BiTEs have a relatively shorter period of time. But some studies are very compelling. BiTEs is off the shelf. You order it today, it is available for you tomorrow for your patients. CAR T cells, you have to collect the T cells, send them for CAR T manufacture, takes 3 to 4 weeks. And that could be a critical period between life and death. But the efficacy after T cells and no toxicity of conditioning regimes are again a point in favor of the BiTEs. However, the advantages of CAR T cell is durability and a single infusion, one and done. And it has the longest long-term data. So again, you can take your picks, but I don't know whether my hematology colleagues will agree or not. The world is tilting towards the strategy in which you use the CAR T cell first, and if there is a suboptimal outcome, then you shift on to the BiTE, not the other way around. There's a little bit of extra benefit if you use this strategy. So again, as for relapsed ALL, the strategies or the algorithms for the second-line treatment of large B-cell lymphomas is changing and evolving, and we are incorporating CAR T-cell therapy early, and we are involving the use of antibody drug conjugates and the BiTEs in the second-line paradigm. And I have no doubt in my mind that for high-risk large B-cell lymphomas, we are not very far from the time where you will use it as the first line in really high risk patients. So this is something which I'm really excited about, and each one of you should be excited about. Spend a few minutes on this with your permission. The Indian story of the Indian CAR T cells, and I'll show you some phase 1, phase 2 data from the Immunoact team. They are, would like to also tell you that there are other CARs also, but this is the, should we say, industry leader, and spend some time on this. So phase 1, phase 1/2b, and a phase 2 study was done in both cohorts. The relapse B-cell leukemia cohort and the relapse DLBCL cohort. And this was the consort diagram of the study. There were about 64 patients in 17 leukemias, 47 lymphomas, and 15 relapse ALLs were infused. 42 lymphomas were given the CAR T, and 50 plus patients are evaluable for toxicity and efficacy. And you can see that all of them were high-grade lymphomas, median age of 43, and number of median lines of therapy were 2. Some of them were post-transplant also. For the lymphomas, bulky disease was present in about a quarter, and extranodal sites were present in about, again, a quarter, and more than 2 sites in about 1/3 of the patients. For the leukemia, the average blast cell was 60%, so most of the patients were in florid relapse, and they were high risk. So here are the response rates for you. This is the leukemia cohort. And almost 3/4 of the patients had a response at day 28. And this the leukemia cohort, again, 70% plus patients had overall response or complete response. And some snapshots of a patient of lymphoma pre-therapy and post-therapy. Blast cell percentage reduction in ALL other than one patient was seen in all the patients. And for the lymphoma cohort, the overall response rates, this is the Indian product, 68%, and compared to the 3 products US FDA approved, 50%, 83%, and 54%. So pretty much matching with the already available best in the world products. In the leukemia cohort, the overall response rates for the Indian product, 73% versus 82 and 65 of the 2 available US FDA approved products. Again, very much matching. So the toxicity signals, grade 1 to toxicity, CRS in 2/3 of the patients. However, grade 3 CRS, please note this, only 5% of patients. ICANS, 0%. So this is one of the huge advantages. And when you ask the manufacturers, why is there difference in the toxicity? They come up with the answer that this Indian CAR is a humanized CAR. So both the cytokine release syndrome and the ICANS, the neurotoxicity is much less. However, because the B cell suppression is much more profound, the rates of hypogammaglobulinemia are quite high. Almost 1 in 3 patients will have hypogammaglobulinemia. So here on your left side is the lymphoma cohort. And if you compare the CRS, and the top the 3 bars are the international product, and the bottom blue bar is the Indian product, 67% here. So maybe a little less than the other products. If you compare all grade CRS, but if you compare more than 3 or more than 3 grade CRS, it is 0% in the Indian product. And here is the major advantage. In the leukemia cohort, the severe CRS is only 20%. And if you will do a similar comparison for the neurotoxicity, 0% in the lymphoma cohort and 0% high-grade ICANS in the leukemia cohort. So that is a massive advantage if you are intending to use this product. So this is just a summary of the adverse events which I've already showed you. ICU admissions, 7% in the Indian product versus significantly more in the foreign product as per published literature. This is the comparison between the Indian product and the foreign products. IVIG support is in about 40% of patients. Absolute neutropenia incidence, again, very well categorized. Absolute platelet count, again, very well categorized. Hypogammaglobulinemia, I already told you. So the summary of the Indian product, the Indian study, it's an effective agent. And we know that it has now been approved by the Indian DCGI for use in relapsed B-cell ALL and in relapsed large cell lymphomas. Very recently in the ASH 2025, there was an update on the ALL cohort. And we finally have a publication in this year's Lancet Hematology. For those of who you are interested in the nitty-gritty of the trial, you can, I have this publication, the full text, you can ask me for it. Just look at the snapshot of the cost of the foreign products for 3.9 crores, 3.1 crores, 3.1 crores. In our product, if you include the bridging chemotherapy and the post-procedure supportive care, about 50 lakhs, so half a crore. Significant cost advantage for our Indian patients. And this is the team. For those of you who don't know, this is Dr. Rahul Purwan. He is the person in the IIT team who was instrumental in designing the product, doing the clinical studies, and now setting up a commercial manufacturing unit for the product. These are the two gentlemen who did the trial, Dr. Gaurav Narula, who did the acute leukemia trial, and Dr. Hansmukh Jain, who did the lymphoma trial. So if I were to summarize my talk, the paradigm of immunotherapy in hematolymphoid disorders is changing rapidly. We have several interventions now available in the relapse refractory setting. And in this very poor subset of patients where only 1 or 2 out of 10 of our patients were surviving, it is now going up to 40–50%. And I have no doubt in that how our high-risk BALL patients and the high-risk DLBCL patient, these interventions will move to the first line. CAR T cells versus bispecifics remains a question, both in relapsed DLBCL as well as relapsed myelomas, whether to use CAR first or to use bispecifics first. But the world is leaning towards CAR followed by bispecifics versus the other way around, but there might be differences of opinion there. For the BALLs, BiTEs and ADCs are moving towards frontline therapy in combination with chemotherapy. And we are talking about chemo-free regimes now, also in the near future. So ladies and gentlemen, with that, many thanks for this patient hearing. And I'd like to invite you to Jaipur next month for this ISO-ISMPO conference. Some of you have received invitations, and those of you who have not and are interested in coming, please let me know, or please let Rajesh know, who is our event manager for the event. Thank you very much.
Thank you, sir, for such an elaborative discussion on history of ALL, moving from the history to the current treatment and how rapidly we are moving in cellular therapy, in targeted therapies, bites, and also a very comprehensive update of the aggressive B-cell lymphomas. As chairpersons, we don't have much to comment. I'll open for questions from if anyone from the.
So if I can't answer any questions, I will recruit Chirag to do that. Yes, Nikita.
Very nice presentation. So what do you see as the difference in terms of feasibility, cost, affordability, access, everything? Do you think these bites will be preferred over CAR-T based on the data that there is?
So I think I did mention that during the talk. There are some advantages of the bites. The most important advantage is it is available off the shelf. You decide today, the patient can, go to the pharmacy, or your pharmacy can arrange the drug tomorrow and start. With the CAR T cells, at least 3 to 4 weeks are required. Sometimes for critically sick patients, this is the difference between life and death. So you have to give some bridging therapy. Bridging therapy has its costs and its toxicities. But CAR T cells is one and done. You give one dose, that's it. With the bites or the ADCs, you have to keep giving them again and again. There is no finite duration. Some people are now talking of 12 cycles of some bites, but it's as of just now. It goes on and on till there is disease control or till there is toxicity. So advantages and disadvantages of both. You have to tailor it to your patient. If you feel that the relapse is not critical, the patient is going to be alive and kicking after 3 or 4 weeks, then maybe CAR. If the disease burden is a little less, then maybe CAR. But if the disease burden is massive, if the need for initiating treatment is imperative, then maybe a bite or a ADC. Chirag, agreed?
Excellent presentation.
Thank
Question is, when we send a patient for CAR T, typically you should not have more than a few percent blast, or preferably no blast. Should have given the bridging chemotherapy, like a hyperciveta or whatever. And lastly, you should not have CNS, right? I mean,
No. So all these three things are not contraindications anymore. In the phase 2 study of the Indian CAR, almost all the patients were in frank relapse. The median blast cell count was 60. 60% blasts were there. So you have to send the sample at that particular time for T cell collection and the CAR T formation. And the 3 weeks which you have to start some form of second line, third line, fourth line treatment, so that you get to a point where you have minimal possible disease before you give the CAR, and then you have the best response.
we work in smaller cities in India. The issue is, you give some bridging therapy, and then when he reaches the CAR T center, he needs lymphodepleting therapy again. What kind of sequencing are you?
Yes, so you have to give treatment to reduce the disease burden. And before you infuse the CAR, you have to use a lymphodepletion. So you have to use a fludarabine cyclophosphamide 3-day regime. So of course, the chemotoxicity is there during the second, third, fourth line, and during the bridging also, and that contributes to the post-CAR neutropenia and thrombocytopenia. Yeah.
Is there any difference between the management of Ph positive and Ph negative relapse in terms of CAR T cell?
No, so you are just selecting the T cells. You are just targeting this is a CD19 CAR. So it doesn't make any difference. Chirag, would you disagree? Doesn't make any difference.
Maintenance. Yeah.
Right. Right. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you, Dr. Hemant Meghnani and Dr. Jilpa Soni. Now we are having a case-based panel discussion, for which I would like to invite moderator Dr. Nikita Mehra and the panelists
Dr. Jyoti Bajaj, Dr. Hemant Malhotra, Dr. Chirag Shah, Dr. Manthan Kathrotia, and Dr. Ankit Jitani.
A very good morning. So I'm actually doing this panel discussion on behalf of my colleague, Professor Lingaraj Naik, who I think he's informed the organizing team. So, and I'm very sorry, I have to join a meeting at my institute at 11:45. I requested them for a grace time. We will jump straight into the panel discussion and like to invite all the panelists. And I don't know how much we have left to discuss. So I think you've covered everything so nicely that I mean, Lingaraj, I'm sure many of you know Lingaraj, or most of you. He's very, I mean, he's very savvy with all his clinical trial knowledge. He's very clear. You wake him up at 3 a.m. and ask him a question, he'll tell you 4.3%, 4.3 months. I mean, he's excellent. And not just hematology.
Slides which are in
So, so the disclaimer I have is I cannot present his entire slide set because they're very rich in beautiful data he has. I think it would be nice to kind of understand some, Lingaraj has put down some very nice questions. And I would really like to understand what the panelists, I mean, your approach and things like that. And I'm really sorry. I know there are pathologists here, and of course, I know Malhotra sir. You spoke about Chirag sir, but I don't know who the pathologist is here, and I'm really sorry, madam. I'm really sorry about this. So I will quickly. So he has two cases, and the first case is a 16-year-old boy who presented. Of course, we're looking at AYA. And as everyone knows, the cutoffs for pediatric adult in different hospitals is different. So here at Tata Memorial, I think the cutoff is 14 years. So the adult hematolymphoid group starts treating patients 14 years and above. So here is a 16-year-old boy who presented with neck node enlargement for 2 weeks, was evaluated, and biopsy was a PET-guided biopsy showed a DLBCL GCB subtype. PET-CT revealed a stage 4 disease. There was a liver lesion. The LDH is elevated. It's 800. Bone marrow and CSF uninvolved, and all the other parameters and organ functions are normal. So I just like to ask all our esteemed panelists, for a 16-year-old, what would you normally do? Do you have a separate? So I have 3-4 questions. One is at the institute, is it what are the cutoffs for pediatric adult, or is it the same group that is treating both? Of course, practices vary across the country, and everything is acceptable so long as the patient is benefiting. So I want to know, for a 16-year-old, one is what is the institutional practice? And the second question to each of the panelists is, how would you approach this? I mean, would you want to give an adult protocol to someone with a high risk DLBCL, liver involvement, raised LDH, the IPI must be high, who's 16 years of age? So you want to treat the patient with an adult protocol or a pediatric protocol? The mic is.
You have to specify who you wish to address the question to first.
So you have taught us everything. So it'd be nice to. No, it'd be nice to start with your perspective.
I thought you were going to say that enough, so we don't want to label.
Taught us over the years.
I would be happy to treat this patient. If this patient was 6 years old, if that one was not there, then I would be more than happy to send the patient to my pediatric hematologist oncologist, which I fortunately have on my team. can you not give this stage 4 natural lymphoma patient also? Then I would be happy to give this patient dose adjusted RECOG.
Thank you, sir.
So we don't have a very specific cutoff like in the institutions. But I think as Dr. Malhotra said, it's younger the person, we would be more kind of giving to pediatric, and now we have active pediatric hematologists, so most of these patients will be treated by them. Otherwise, whether to R-CHOP or those adjusted RECOG, I'm not sure if there is any specific data on that, unless this is a double hit or triple hit, then I would do those adjusted RECOG. But I'm sure that there will be variations, and my pediatric colleague would most likely give the LNP protocol to this patient.
So I have another question. So there is some data, I think it's from Data Memorial on rituximab in the pediatric age group, and how it may not be, I've not read the entire paper, but essentially, how safe is it in this age group? Like say less than 12 years, 14 years, and in this patient who's 16, would you be very comfortable giving rituximab or?
Would be at this age group, what we treat would be very comfortable.
Okay.
I don't know if these people treat more pediatric patients.
So I feel that until the vaccinations and all are over, that is probably a point in time when we will be a bit skeptical on rituximab. But at this stage, I don't think there is much of a concern.
And that cutoff you're saying
It's
is
very tricky. See,
no, the vaccination cutoff.
so
like you said.
most of the vaccines are probably over by 2. Boosters come at 5. So below 5, we get a bit jittery in treating pediatric, and where the pediatric hemophilies.
Very interesting. That's
Yeah, so I agree, like sir told, we should look at the double hit, triple hit status of the patient, and in my experience, patients having liver lesions do badly. Generally, they either don't respond well or they relapse earlier. So, looking at the aggressive of the disease, we might upgrade the protocol to aggressive, but otherwise, I'm comfortable.
So I think the cutoff which we spoke about, the teaching institution practices more of an age-specific cutoff. So the case from where I graduated, they had an 18-year of the cutoff. But then the biological age and the pathological, there is a very gray area. When a 16-year-old could be as high in terms of being as good as an adult. So that is a very gray area. As sir said, 6 years definitely, but absolutely. So many places have different cutoffs. So the whole point is probably pediatric patients are able to take in more chemotherapy. They have less comorbidities. So if we go by the adult approach, we try to undertreat them because we are more concerned about the toxicities. In pediatric, the tolerance is better. So as sir said, probably pediatric colleague would choose the pediatric-based regimens. Adult would be more comfortable in the adult patient.
What about CNS prophylaxis? If this patient had, say, the CNS IPI is high, would you be okay? What do you do for CNS prophylaxis
All
in
those
this
things
age
come
group?
into the picture. Like if we go with the BFM type of protocol, the CNS prophylactic drugs are already a part of it. In R-CHOP, giving methotrexate to an adult is tricky in terms of tolerance. At whatever point of the regimen we place them, it is difficult to administer. And that is a fact we all understand. We end up doing just the ITs, but that we know is not enough in TNBCLs. So I guess that is the answer.
Okay.
Even IT we don't do, because I think that also is not clear, and there was a very good paper in Blood just about a year or so ago, where this CNS prophylaxis in adults at least is probably not helpful.
Thank you, sir. Madam, a question for you. So for all the lymphoma patients, that is high grade, say DLBCL, across age groups, would you want a fish? Would you want to look at double hit, triple hit?
Double hit and triple hit is very uncommon in pediatric age group.
Yes.
So generally in adults, we go ahead with the Hans algorithm, first to see for GCD and non-GCD type, then we do IHC for BCL2 and MIC. In fact, we start with MIC, if it shows more than 40% expression and BCL2 more than 50, and if it is of GCB type, then we advise for FISH studies for double hit cancer.
What about in this 16-year-old? Would you?
Ma'am, we'll try to look for expression on IL-6. If that is suggestive, only then. Otherwise, we don't.
Thank you. Should I move on to the next case or? Also, a very quick question on PMBCL. Say it was the same child, child meaning a young adult, 16-year-old. How would you treat the patient? What chemotherapy would you give? Are you happy with Dunleavy's protocol, or would you?
I think with PMBCL, we all will agree that TYAcon has made life a bit easier. In pediatrics, we would like to avoid radiotherapy as much as possible. Use R-CHOP, radiation definitely comes in. So with TYAcon, that long-term toxicity risk is taken care of. So I think everybody will agree to this that TYAcon is a better option.
Thank you. So this is the case number 2. This is a 17-year-old female patient who presented with significant weight loss. She's lost 10 kgs in the last 6 months and dry cough for 2 months. So on evaluation, she has a 6 centimeter mediastinal mass, which is less than 1/3 of the diameter, so mediastinal diameter. Bilateral cervical lymph nodes, a right axillary lymph node, and the biopsy shows a nodular sclerosis, Hodgkin's lymphoma. The ESR is 40 and organ functions are unremarkable. So this is an early stage 2B, unfavorable, 4-nodal area and high ESR, NS Hodgkin's lymphoma. So the question is, this is a 17-year-old girl. What is, just wanting to understand what you practice with regard to the regimen that you would give and your repeat PET-CT strategy.
So, just had a debate last week on treating upfront unfavorable risk patients in our ongoing conference. So I debated on nivolumab versus Dr. Amit Khurana debating on brentuximab. So because of unfavorable risk, we know that 9q amplifications are always there to make them relapse severe. Sometimes they do and get difficult to treat later on. So nivolumab, adding nivolumab upfront is what I would like to do. And because that has, the data is set short term, but whatever we do in our practice, I see that they maintain long-term remissions compared to, and the toxicity is much less.
And you're comfortable with nivolumab, sorry, at this age, 17?
Yeah, the trial, because it included
Yes.
patients and we have used also, they don't have any issues, and upfront using it doesn't require any caution regarding proceeding for transplant or anything. And the other advantage was that the radiation requirement was much less than 1.
What dose of nivolumab, sir, would you?
Dose 3 mg per kg for pediatric patient or the flat 241. Weight is more.
Okay.
Yeah.
Okay.
Day 1 day.
And you don't do an interim PET in that?
Interim PET, yes.
Interim PET. Okay.
Interim PET, but till now the trial doesn't have the advice of changing the treatment based on interim PET. Yeah, better to look after these cycles like we do for EBV, but continue the treatment. Some Indian studies are coming up. I think DMH and Cellular are going to do a study on low dose nivolumab upfront, where they are going to try the reduction in treatment based on interim PET.
There are already some, as you said, I think some published data. Dr. Gaurav Narula has also published a retrospective study. Dr. Prashant Ganeshan also, I think, is leading.
So basically, 17 is again a very tricky age. They will look like an adult. Obviously, we will be more concerned about the fertility and the long-term cardiac toxicities, those aspects. So EVBD, risk adapted therapy would definitely cut down the risk of exposure to chemotherapy. And we will be skeptical in controlling the radiation dose that we deliver. So we have used OPA-COP stage group as well, apart from the risk which is being shown. Risk adapted omission of radiation was an option there. relatively good efficacy around EFS of 86-87%. With Nivo and brentuximab, again, the spectrum is changing. With brentuximab, I guess in pediatric, there are other combinations which can take care of omit dark arbithin, which is again causing fertility issues. So I think Toxo, Itopo, multiple combinations are available. Those combinations have more mature of a data compared to Nivo-based combination. So those are also an option with good EFS as well as. So it will be interesting to see how this data matures. OPACOP, PV-based combinations and Nivo, all these three are options.
Are you using a lot of brentuximab in and around this age group?
Not much, yes.
More nivolumab?
Both. I work in a center which is not very high in volume at the moment. So we have used all these combinations. Again, cost becomes a major issue. Limitation with brentuximab. So we have used more of Nivo, but at my training center we have used a lot of OPACOP, that with reasonably good results. Over in this pediatric age group. But 17 is a tricky age.
Thank you. Thank you.
So 2-3 comments. The first is that before contemplating any chemo, this patient should be counted for fertility preservation, right? That would entail what weeks delay in initiating the treatment, but from the treating clinician point of view, that counseling is must, and then documentation of the patient's record is over. The second thing is that neuro-ALD in the small number of patients which we've used really effective regime, but the long-term follow-up is still relatively short. So, and of course, I would still do an interim PET to be sure that I'm on the right track. And one more regime which can be considered and which is making waves is there with the BRICAT regime, which would also be active in these types. One of the options to consider.
Thank you, sir.
So I think most of the points are covered. I would just again highlight the point of discussing the infertility issue and let the patient take the decision. Oocyte preservation is not a very simple thing. So lot of patients don't agree because when we talk about 3 weeks of delay in the whole process, but at least they should know. But more importantly, I also tell them that the overall incidence of infertility is very low. So what happens, when people come with all the reading, they say, oh, it's like everybody's going to get infertility or cardiovascular. Those numbers are about 2 to 5%, which is not very big. And when they understand this part, then they are relieved. So about the regimen, I am the ABVD person. So I would stick to ABVD times 2 PET, and then based on the PET, I think the data for Nivo and BV addition is more convincing for 3 and 4 stage. This is 2B. So I would not use up my armamentarium in the first line, but I'm sure there will be many ways to do this. So
thank you, sir. Madam, a question for you. So this is, so we're talking about a 17-year-old with a mediastinal mass. What are the close differentials around this?
Refractory mediastinal B-cell lymphoma, which is a B-cell lymphoma. It also has CD30, but then we have the B markers, CD79, 19, 20, CD23. So that's a close differential for Hodgkin's lymphoma in mediastinal. Then you have DLBCL also.
What about NLPHLs and things like that?
NLPHL is we can, but it's generally uncommon. Classic Hodgkin is more common.
And not usually mediastinal. Thank you. Are there any other, is there anything else that anyone would like to add? So thank you for the wonderful discussion, and it was so nice because everyone had such different ways of approaching the same patient, but ultimately the goals are identical. And also thank you so much for bringing up the points on survivorship. So I think TY con at its very core is all about, and I spoke about this a little earlier, is all about survivorship and patient advocacy. So thank you so much for beautifully bringing that out as well. And once again, I'd like to thank my friend Lingaraj for giving me this opportunity to moderate on his behalf. Thank you. Thank you.
Thank you, ma'am, and all the panelists. Now we are going to start session 2, which is neuro-oncology in AYA. I would like to invite the chairperson, Dr. Maitrik Mehta, Dr. Deepak Patel, Dr. Prashant Kumbhaj, and Dr. Sandeep Jain. And the speaker, Dr. Devang Bhavsar, and his topic is on AYA tumors of the brain. Thank you.
Yes, good morning. Thank you. Thank you. So we are here to discuss on the very big burning issue, what we have seen in the field of hematology. The game changer things has happened. So many new molecules, so many driver mutations you are seeing, and so many advancement in the histopathology to the molecular diagnosis to the treatment point of view. Still at this junction, where we are missing is neuro-oncology, where we are not able to see the much change in the last couple of decades. I will say the last couple of decades, still we are struggling to improve the cure, to give the good quality, and at the same time, the outcomes, we are not seeing the good, big change. So whatever the diagnosis was there in the low-grade glioma 20 years back, or whatever the today's more or less, Deepak Bhai is the highest experience among our group, and he has seen that Dr. Deepak Patel has done the almost since last 4 decades is doing the neuro-oncology surgical practice. And what the change we have seen is our small things. So when we are talking about AYA and in that subset, I will say that it is a big basket. It is not the simple entity. There are the more than 100 distinct types of the primary brain tumor has been identified. Each and everything has some different molecular structures. Each and every tumor has some different behaviors. And whatever the things you do, whatever the brain tumor can have the lasting and the life altering the physical, cognitive, and psychological impact. It is a big trauma when you are talking in the young age group, starting from 15 to 39. There are the big impact, even the patient's quality of life. At the same time, the whatever the outcomes are there, they are having the some cognitive effect, or they may be the some psychological impact also is seen. While we are not able to change the survival, so what we are able to do right now, this is very famous slides from the Canada. They are call it as a canon, or they are having the big AYA group, that neuro-oncology clinic, how to establish the neuro-oncology clinic. So that part you can see the who is the important part. Whatever the things are seen in the blue line, like pediatric neuro-oncologist, by a neurosurgeon, or some genetic expert, or the neuroradiologist. Nowadays, in every town, there are so many neuroradiologists you are able to see. Even the dedicated neuropathologists you are able to see in each and every corner. But whatever the missing is the yellow line in our day-to-day practice. Still, we are working at the sporadically. Suppose in Ahmedabad city, if you take, there are at least the 10 to 15 institutions are there, those who are attending the neuro-oncology practice. But still we are not united, or we are not getting any single dedicated neuropsychologists, those who can look after this AYA practice, or those who can give the good uh, counseling, and they can give the good reassurance to the patient, and their compliance for the treatment may increase. So these are the yellow lines are missing. So let me help of this all these types of the organization, what I can say that TYAcon or the what AIA groups are working, if they can create the some protocol or they can provide these types of the platform and they train the people. After the training, they can just assign the job or something, they can do it. That is the biggest achievement what we can do from this our organization. So there are the what are they? I was searching for the data from the Indian Globocon or the whatever our surveys or our ICMR website. I was not able to find out the how much incidence was there in neuro-oncology in 2022 or 23 or 24 or beyond that. So still we don't have that type of the data bank also is very ready or handy to give us a complete answer. So roughly we have able to see the around odd number of 30 to 50,000 new neuro-oncology cases or brain tumor cases are seen. But as far as the National Brain Tumors Society is there, and they have the clear cut given, there are the at least in across the North America, there are the more than 1 million are they are living with the brain tumor. They are almost 94,000. They are just telling that they are going to diagnose in 23. They are the big number. What we are able to see in India may not be reported or may not have came to the some reporting level they have not achieved. But what is unfortunate thing is 35.7% is relative survival. I'm talking all age group. I'm talking from the infant to the geriatric. I'm talking all together in the gliomas together and with the benign condition also. So this is the things we are not able to change, and that is the unfortunate part. These are the different subset. If you see the age group of 15 to 19, majority of the tumors, they might be having the pituitary adenoma or maybe glioma. But in the below age or above 15 or above the 20, they are the mixed combination. There may be the few low-grade glioma or maybe the some infiltrating glioma. There are the high-grade glioma with the good number of the benign conditions are there in this particular age group starting from 15 to 39. Pituitary adenoma, AV malformation, these all are the big challenge to our day-to-day practice. So what we have seen the change in the last, I will say the 20 years. If I will approach to my neurosurgeon in 2010 or 2000, he will say the DND, do not disturb. That is the neurology, neurosurgical fundamentals were there across the globe. Deep-seated tumor, eloquent area, very highly vascular tumor, no biopsy, only CT, or if occasionally get the MRI and you get treated. Whatever the biology was there, we were not able to know it. But nowadays, with the advanced surgical technique, we are able to achieve the maximum safe resection. That is the biggest achievement in the. So what is that achievement? I will request at the end of the my talk, Deepak Bhai to talk on this particular subject. Very good intraoperative, sorry, very good intraoperative imaging are available. So many institutions they are having the MR guided the navigations are now coming up. Fluorescence guided surgery is very commonly done nowadays. Thank you. Apart from that, the endoscopic. Suppose you want to approach to the fourth ventricle or the third ventricular tumor, very rarely you were able to see or you are able to see the certain. But with the help of the endoscopic minimum invasive surgery, now we are able to achieve goal number one to get the tissue confirmation. From the era of the no tissue or no biopsy or limited tissue material, now we can have the good material is available. So with the help of and the whatever the eloquent area you are treating, we are having to have the very good facility in-house across the Ahmedabad city. You can do the awake craniotomy and we can do the brain mapping also. With the same time, how this thing has happened with the good quality of MRI, with the good navigation through the or whatever the MRI techniques has been changed, and that help us a lot as far as we are managing the neuro-oncology and day to day whatever the issues are there. So apart from neuro-oncology, surgical approach has changed. At the same time, the simultaneously the few other modalities, they are also not left behind. What we were trained in the 2000 to 2010, whatever our radiation techniques was there. From that days onwards, now we are having the very good in-house CT MRI based linear accelerator. We are able to give the very precise dose to the target at the same time, whatever the late sequelae we are expecting, that part we can cut down. The very good understanding of our historical data, very good data mining has been done from each and every low-grade tumor to the high-grade tumor. So what are the areas should be treated and what are the areas should not be treated? That knowledge has been now become very mature. So with that help, we are able to give the good quality of life. We are able to give the good disease control also. At the same time, we are able to provide them the best out of the base treatment with the suppose these types of the irregular meningioma, very diffuse meningioma. If I have to plan on this conventional simulation, I cannot do anything. Even with the CT scan, I cannot do. But once I have the MRI based planning, I can give you the very crystal clear view of what I have to treat and what I don't have to treat. In spite of sitting in the very complex area, we can able to. And the previous era was there, we are shooting in the dark. We were shooting in the dark. We don't know whether we have the brain mets. You give either the whole brain radiotherapy and whatever the sequelae are there, you have to accept. Nowadays, you can have at least minimum 3, 4. I have treated up to the 5 small mets at the single sitting with the stereotactic radiosurgery. So that is the biggest achievement what we have achieved in the last 10 to 20 years. With the help of the stereotaxy, with the help of the navigation system, we are able to deliver the very precise dose, and with the same time, we are able to cure the disease and control the disease, and we are able to give the good quality of life. So stereotaxy with the all different gadgets are available in the different institution across the India. And as far as second, my speaker will be apart from Deepak Bhai, Dr. Maitrik will talk about the cyber knife. So when we are talking about the leukemia, so there was the prophylactic cranial artery and this all the whole brain radiotherapy. So whatever the mature data are coming up, so by sparing the hippocampal, you can definitely give the good quality of the life, good disease control. At the same time, the neurocognitive aspect has been not been affected in spite of the giving the a therapeutic dose to the target. So that gives a maximum CNS control as far as the high risk, the leukemia, those who are needed the neuro radiation for the brain also. So that part is a very important thing what we are able to find it out. So cyber knife is available within in the city. I will request Dr. Maitrik to say the few his experience because he has a very good experience at the institute at the Gujarat Cancer and Research Institute. He has they are doing it day to day. So I will request him to say some more about the cyber knife, his experience. But with the invention of this availability of the proton across the India, now the two centers are having this proton, and in the near future there are so many new. They will definitely come. So what are the main advantages? These types of the proton and the cyber knife facilities by using it at the appropriate time at the appropriate candidate if you are using, you are achieving the goal, but at the same time, you are reducing plenty of the side effects that are the long-term expected, that the endocrine dysfunction, some are saying that the visual pathway or the whatever the hearing or auditory apparatus, whatever are going to disturb, you can definitely cut down, and that can give a good outcome also. So now with the neuro and the surgical things, till the today there are only and only drugs were available with, so only I was saying that only and only temozolomide or the some other effective drugs are very limited. Apart from the some hematological primary CNS lymphoma or the solid tumors in the brain, starting from the ependymoma, medulloblastoma, or the CNS tumor. Now with the good understanding of the molecular pathology, sorry, with the with the good understanding of the molecular pathology, so many targeted medicines, they are going to be available. And they are the only going to be a game changer in the next 20 years. If I am not wrong, my all medical oncologists can correct me. So there are the big hope as far as your understanding with this tumor is going to increase. So some IDH mutations, you have the very good molecules are available. Some are having the PRAP inhibitors are there. Some are having the CDK inhibitors are there. Still the immunotherapy, they are not widely used or there are the no much trials are going on. But still we are expecting that so new horizons is going to improve by biggest defeating blood-brain barrier and we are able to achieve our goal. So there the days are not far away, but keeping that hope alive, what we have seen. Now going into the very deep dive, whatever the efforts we are doing combined, starting from the biopsy, starting from the neuropathology, analysis, still they are having the good guidelines now converting. So if you see the WHO has changed its guideline, whatever the staging portion, they are having the low-grade glioma. So they have also clearly mentioned, these are the tumors. Those who are IDH mutation is seen or not seen, they should be differentiated. So those who tumor are grade 3 and 4, definitely they are not going to do well in spite of the treatment. But these are the more and more molecules or the pathways will be isolated and we will be able to treat. And the plenty of the works is going on. Not only the single few institution across the all the centers across the world, they are the right now going in the so treatment guidelines for the childhood cancers. They have the what are the difference in the childhood and the AYA low grade glioma. Childhood low grade glioma have the very limited chances to undergo the high grade. They are not having very high chances to undergo the conversion into the high grade. Compare with AIA or whatever we are talking between the 15 to 39, there are chances of transformation. So they may be the low grade at the initial time and they may be convert into the high grade at the end of the day. So these are the things are very peculiar in this glioma cases. How they have impacted, ISC has impacted the CNS prognosis and the treatment. So we have all together, whenever we send the biopsy, so there are the three things we will do. Our histopathologists nowadays, with the help of the immunohistochemistry, they will do the IDH mutation, they will do the Ki67, they will do the ATRAX, and they will do the, if required, 1p19q the co-deletion, they will be also be able to do. But with this help of this molecular knowledge, and with the help of the long series, we are able to come to know that these are the tumors are not going to do well. So be aggressive and the be proper. Same biggest achievement what we have seen in the medulloblastoma. Medulloblastoma, either they are WNT activated, either they are SSH activated, or group 3 maybe the WTN, non-WTN, and non-SHN. But they are have the mic oncogene overexpression is seen. So this subset is telling that no, these are not going to do well. Don't leave it. Do the aggressive treatment. And the same thing is there if I have group 4 and they are having the 90% to 80 to 90% survival. We have the standard of teaching is medulloblastoma. Either you put it in the standard risk or very high risk. Standard is less than 3 centimeter residual after the surgery. That things is going to be little bit obsolete, or maybe that may be the one of the factor to take the call. But these are the things are going to take care in the future. Same thing is we are working in the ependymoma also. Ependymoma now it has been divided in such a big basket. It is not only the posterior fossa tumor. It is not only the posterior fossa or the ventricular tumor. There are the subsets are there, and still the biggest challenge, there is no effective medications are available. So most important treatment is the surgery followed by adjuvant treatment. But still that is going on since last 30 years. So we are expecting so many new horizons there. They may going to change our guideline in the next couple of decades. If we come back after the 10, 15 years again in Ahmedabad, so we'll definitely have this, all the things will be there. These are the benign condition. That's are the big challenges. It is day to day, it is a big challenge. 30-year male, he come with the pituitary adenoma. He is at the crossroad where he has to work, where he has to earn, where he has to feed his kid, or whether he has to look after the parents also. So that subset of the cases, if I will take 25 to 40 years, they are having the, say, the fortunate to have the schwannoma, there may be the hearing loss or some maybe tingling or trigeminal or the facial irritation may be there. But these types of the meningioma and pituitary adenoma, they are having the big impact on the day to day, because the schwannoma nowadays, with the help of the imaging or with the help of the navigation or with the help of the microscope, they are able to do the complete re-excision. I'm not talking first excision, I'm talking re-excision also, with a very good outcome also. So, but these are the two, meningioma and pituitary adenoma, very less understood, very less work has been done, or whatever the behaviors are there. But still we are able to control. That is the achievement. We are able to control for the long term. That is the biggest achievement. But what after that? They have the biggest challenges as on today. So what are the things are happening? So there is some molecular message we are expecting in the couple of days, but whatever the molecular messages we have received till today from all the analysis or whatever our historical series or whatever our brain tumor societies, they have created this consensus and they are giving the very crystal clear, okay, each and every brain tumor is different. Don't take it lightly. Whenever they require, you do the require histopathological immunohistochemistry or the molecular study, and appropriate steps should be taken in each and every. So what is the life after that? This lady in the last, she was treated almost 15 years back. She has undergone the surgery. Even after that, she was having some residual tumor. It has keep on growing. So after that surgical and the radiation, she has a definite limping of the leg and the upper limb, but she has not lose the hope. She has not lose the hope. Then she have adapted the new games. So right now she is representing the India in the some international level. She is presenting the table tennis. But she needs the constant and she is a motivation for my patient also. Another gentleman, he is will be very, you will say it is a craniopharyngioma, right? Most probably Hemant might be knowing. Is a craniopharyngioma. He has undergone the surgery for 4 times. 2 times in Mumbai, 2 times he was in the out of country at that time. Now he is, after the 15 years of his journey, nobody is accepting this person is having the multiple metastases in the spine and the lung. Craniopharyngioma is going to metastasize. He was operated last in the Canada and he has undergone the some debulking was done. So he has lost the vision because of the cellular lesion in the craniopharyngioma. He has lost the vision. Still, he is not losing the hope. I have the few videos he has sent me few days back. Still, he is enjoying. He is back in India again, but for chemotherapy. Fortunate thing is there, only Pecli-Carbo is working so excellent for the lung. All the lesions, they disappear. All the lesions, when they diagnose, when he has undergone the investigations at the Canada, it was around 20 lesions were there. Biggest one was the 2 centimeter. Multiple spine mets were there. That upper eyelid, that the tumor was there, that was also radiated on the left side. But these are the journey. What I will say, they are the very, in during your practice, those who are between 15 to 30, they are going to affect you a lot. They are going to be getting more attention from your side as a treating doctor also, and they are definitely handled, should be taken care very nicely, but they do very well. What I mean to say, they do very well whatever the efforts you will put, and that part will the most satisfaction at the end of the day. I will again thank you to the TYAcon organizer at this successful meeting. Now I will request Deepak Bhai to say the few words is on the young age group.
Thank you, Dr. Bhavsa, for an elaborate talk. But we have already mentioned the all modalities of the treatment that we are using for maximum safe resection of primary brain tumors or recurrences. We are also using real-time ultrasonography nowadays to go for the correction, which navigation and many times fails. So with that and with microscope and or fluorescent dye, we are able to access tumors from any part of the brain or spinal cord. So thank you for your nice.
Thank you, sir. Actually, at GCRI, Bhavsa sir, Nima sir, Das sir, Mahesh sir, and Surya sir, were the pioneers in developing radiation treatment in neuro-oncology. Actually, X-Knife came into GCRI in 2000, and sir was also in active participation with the stereotactic radiosurgery. CyberKnife is an updated version of X-Knife with the robotic treatment, and nowadays we are treating lots of patients with Pharmacology, as sir told us, benign tumors, itomatous malformation, pituitary tumors. GCRI has been now in the pioneering of stereotactic radiosurgery in the updated form as a CyberKnife, and it has got very sub-millimeter accuracy. As sir told for one patient, we have also got the one patient who treated 15 years back of pilocytic astrocytoma, and now patient has developed CSF cytopositive. So for any kind of oncology treatment, what we are seeing that long-term follow-up in our setup is much more mandatory to have an actual data that what we can do for our patients and what is the molecular markers for those patients.
Finally, sir, your comment for any medical oncological update in the type of pediatric tumors, especially oral metronomic therapy.
What was the metronomic targeted therapy and immunotherapy history? And we are now, we still don't know who are the patients that will respond, but T-track and those which are positive definitely work so well with travel in environment. Basically, they are very small subset, but wherever it is there, they work very well.
He told me that Beckley carboid craniopharyngioma and
It's miracle if you over. It was biopsy confirmed. I was not ready to digest it. Yeah, we have the one Dr. Senthil is there. Me and Senthil start to try to work on the CAR T cell therapy. If you can say the one or few words from that side, or now we have tried to.
Yeah, immunotherapy is again one of the more dendritic cell-based immunotherapy. That is again one promising thing for the brain cancers. And I think one of the approved products in US, first one Provence was there, but yeah, we pick up very well. But yeah, the dendritic cell-based therapy, I think stage 4 cancers that is one of the options that we should really look into that, where all other modes of therapy are not available. And the CAR T for the CNS are even most of the malignant solid cancer still it is a very challenge because there's no one cancer antigen like CD19 that we are targeting for the lymphoma. There's nothing that we can specifically that is expressed only in solid tumors. You identify something that is highly expressed in solid particular type of cancer, solid cancer, but it is also expressed in somewhere else. So off-target toxicities are again a big challenge. But localized delivery, a lot of trials are going on the CAR T, but yeah, still we are not.
So there are some TMS basic works. They are so much excited, and they may come up in the next couple of years in CAR T cell in Lymphoma. Anything?
Thank you.
Yeah.
Thank you very much.
Any questions?
Next topic.
Thank you. Thank you.
We invite Dr. Nantis for his talk on molecular pathology of AYA brain tumors. Dr. Nantis.
Thank you, sir. Sorry, I submitted it, but they have not uploaded it here. I directly run it from my pen drive. Which one? This one? Mine. This is mine. It's okay. No problem. Sorry for this technical glitch. And I'm extremely thankful to the entire organizing team for giving me this opportunity to be part of this program and represent our department and our institute. I will keep the timer just in case if I overshoot. Yes. So we had a very good session on immuno-oncology and now into neuro-oncology, a very good pre-talk and introduction by sir. And just to introduce, to start with our topic is, before going to the molecular profile, just to mention that this category of adolescent young patients form big chunk of CNS tumors. Of course, it is one of the commonest cause for mortality and morbidity. And as we will go through, there's a lot of cancers which overlap, both pediatric and adulthood. And they form a unique population, as sir very clearly mentioned about the aftercare also, which can affect their future and other things. And very uniquely, it also possess a unique molecular pathology, molecular profile, which causes a very broad spectrum of behavioral characteristics and also post-therapy complications. And of course, as sir clearly mentioned, there is a need for multidisciplinary approach for all these things, right from the time of diagnosis, later on the planning the therapy and post-therapical management. But what I want to convey, as sir very clearly mentioned, that our role as a pathologist doesn't stop at the level of diagnosis. It goes beyond, where we have to offer information which can provide biological future of the tumor, that is with regard to the prognosis and prediction. And I will not go into the details of it. If you see the classification WHO in a very broad way, it comprises of tissues of particular cell origin, and that's how it's classified into various categories. We'll not go into the details of this because of the time constraint, but 4 categories we have to concentrate from a AYA point of view. That is gliomas, which form the big chunk of this. Next comes embryonic. Then the other, as I very clearly mentioned, the cellular tumors, which includes the pituitary, craniopharyngium, and others. And not to forget the association with the genetic predisposition tumors. Now, if you take up this a very nice graph, this category generally, if you want to classify broadly age-wise, pediatric, middle age, and elderly is the general convention. But if you actually carefully see, there is a niche here where that AYA constitutes, which doesn't belong. It is in such a spot where a lot of pediatric tumors overlap and adult tumors overlap. The only exception would be the most elderly. Only that category is relatively exempted, but still that also can occur. So as I mentioned, gliomas form a major chunk of the tumors occurring in AYA. To add, embryo tumors come into picture, cellular tumors come into picture, and sir very clearly mentioned the germ cell, another notorious group, and of course some benign tumors, schwannoma, meningioma, and other. What is important here is, as sir very clearly mentioned, so far it was basically morphology, but it was realized that morphology was not enough, but it was only giving a diagnosis, but that too it was differential. It was not very straightforward. So we had to use histochemistry, immunohistochemistry, then went into molecular to give a precise diagnosis and at the same time give prognostic and predictive information. Now just take one case and I will tell you the approach. And during the approach itself, I will explain the molecular profile and also the classification. Everything is covered in this approach and algorithm. So if you take up this one simple case, again, teenage with a right periodoxipital lesion, quite heterogeneous, contrast enhancing with some cystic change, necrosis like that. Radiologically, you can make out that it is high grade, but what is important here is morphologically, you can also consider that it is high grade and glial in nature. But a lot of tumors will overlap these days with morphology alone. So that is enough. That is not enough to, even for diagnosis also. And also, if you have to give more information with regard to the prognosis and prediction, we have to subject it to further workup. The approach will be like this. First, we have to confirm that it is glial in nature. So we'll do family markers, that is lineage markers. We do use GFAP and specialized glial marker, oligonucleotide transcription factor. Then P53 will support. Next, whether we'll recognize whether it is diffuse or circumscribed. If it is diffuse, we'll try to, I mean, even in generally circumcised tumors will not become high grade, but generally we'll grade it whether it is diffuse or circumcised, going by mitosis and by proliferation marker. And if there is necrosis and microscopic proliferation, it will generally jump into grade 4. These are the morphological terminologies which we use. But that is not enough here. We have to go for the actual workup. Sorry for that animation issue. Okay. So after we do the basic diagnostic workup, after we determine diffuse, the first thing in an AYA, I'm talking from a wavelength of AYA tumor approach. What we do is first we'll take up adult glioma workup. So we know that middle-aged gliomas will usually be IDH mutant. So that we do. If it is positive, either it will be oligodendroglioma or astrocytoma, which depends on ATRX expression. ATX's mutation. If it is mutated, that is lost, it will be astrocytoma. Then we go for grading 2 or 3. If microscopic proliferation necrosis is there, directly it will jump into grade 4. However, lower grade astrocytomas, especially grade 3, which is actually not a low grade, can show homozygous deletion of CDKN2A2B, then it will directly jump into grade 4 without morphological evidence. That means to say molecular grade 4. Now, I am telling from grade 3 only one grade 3 we subject this because we have done a internal study where none of the grade 2 tumors showed CDKN2A2B homozygous. It's mainly the grade 3, that too very small percentage. That's why we excluded. But if you see WHO, they recommend for all astrocytomas grade 2 and 3 to be subjected to CDKN2A, but which is not enough. Now, if there is no ATRX loss and P53 mutation, it will be oligodendroglioma. You have to support it with 1p92 co-deletion. Of course, if morphologically everything is clear, you can skip this in a resource constraint situation. Of course, you grade it, but only 2 and 3 exists. Now, if IDH is negative, this is only on immunohistochemistry. It may have canonical, that is rare IDH mutations, which we may have to consider. But before that, in the AYA situation, what we do in the lab, trying to minimize the molecular workup, we'll do histochemistry. If it is hemispheric, we'll go for H3G3 34 markers, H3G 34 markers, which are RNB. And if it is positive, it will become a diffuse hemispheric glioma, molecularly grade 4, without even showing histological grade 4 features. Now, all these things, if it is there, whether it is IDH mutant or it is histonic mutation, in the AYA, we generally recommend to do MSI instability markers. Okay, that is basically constitutive mismatch repair defects. The pattern can be different depending on 4 important immunomarkers, that is MSH2, 6, MLH1, PMS2. If it is lost, then we will consider it as something belonging to CVMRD spectrum, that is MSI instability markers, and that they will recommend for add that information for further management and treatment. Now, with the same IDH negative tumor, if it is occurring in the midline structures, thalamus, brainstem, spinal cord, like this, we will directly subject to first H3ME3. That is a trimethylated epigenetic phenomenon, which will be, if it is lost, that means the silencing of the tumor growth is lost. That means that it starts growing faster, which could be due to an histone mutation like this, or EZ4 expression, or EGFR mutation. All these 3 things are categorized as diffuse midline glioma, H3K27 altered. So this is another category where molecularly jumps into grade 4 without showing even morphological features of grade 4. This is the overall approach to an AYA tumor, which comprises both adult type of approach on the left side and right side will be a pediatric type of high-grade gliomas approach. All these things on the right side will constitute pediatric diffuse high-grade glioma. And suppose if everything is negative, whether IDH and even histone are negative, then probably we may be having other non-IDH drivers or non-histonic drivers. Important in this AYA category is BRAF, which could either indicate epidural GBM or an aggressive PXA or PXA-like high-grade gliomas. Suppose if this is also negative, then we generally subject it for very rare mutations, and then we have to go for the study of rarer mutations by all the entire spectrum of molecular profile. Generally, we recommend a tumor NGS, and which could now be supported by RNA-seq and other meta-analysis, of course, supported by the upcoming methylation array. And that will be called as diffuse high-grade glioma, H3 wild type, IDH wild type, because it's negative for all the things and it is showing some rarer mutations. This is the overall approach for that, and many of these non-IDH, non-histone markers may show rarer mutations like this, NMIC, PDH4, and EGFR like that. And of course, rarely we have come across some of the tumors which has a molecular profile of a IDH wild type glioblastoma, not to forget even the elderly also. That means to say this particular category of AYA belong to such, can possess such tumors which can even span across pediatric to up to the elderly also. And they will consider this. And last, and few things about circumstantial lemmas, because pilocytic is the one which takes a very apparent pleomorphic xanthosarcoma. So even circumstantial tumors we has to be considered when you are dealing with a AYA tumor. And in that, the most important dominated by pilocytic, and next comes pleomorphic xanthosarcoma. This PXA is a notorious thing because though it appears circumscribed, it can show very high-grade features with infiltration mimicking almost a glioblastoma. And we all know that pilocytic carcinoma dominated by this BRAF fusion, and in a small percentage can have BRAF V600E point mutation. So what is important here, if it is fusion, it is generally will be a posterior fossa, young age children, and they will be having very good prognosis. BRAF point mutation can have bad prognosis. Generally they'll be supratentorial. So this group to remember. And most important now is this particular tumor, which is showing a lot of pleomorphism, means variation, very aggressive kind of appearance. Generally, it is not that aggressive compared to other high-grade gliomas, but it is capable of behaving aggressively sometimes. That is this pleomorphic xanthosarcoma, known for its BRAF mutation combination of CDK and TYA2B homozygous deletion, and one of the best example for MAPA disorder pathway. And next is some rare tumors, which is also unique for AYA, is this astroblastoma with this MN1 alteration. And now the new tumor which has been added in the USN WHO is the H-gap, that is high-grade astrocytoma with pilot features. That is something like pilocytic asthma, which has become high-grade, something similar to that, but not exactly that, which is also best, which shows MAPK pathway derangement. So next we'll take up this case. A young age, pediatric you can take, or adolescent, and which low grade. You can see that the cells are less, but still infiltrating. So these tumors are generally known to be low grade, but associated with epilepsy and other things. And the category are this one, according to WHO. They can show MAPK or non-MAPK descent. Non-MAPK is actually MIB and MIBL1. And they are known for being generally superficial, cortical, subcortical, temporal, like that. And this category you should remember, because this can trouble us in diagnosis, because this will come in the differential diagnosis of intermediate grade tumor and trouble a lot. And this can show IDH rarely, but most of the times can show BRAF. Or if BRAF is negative, then we have to go for MAPK alteration or non-MAPK alteration like this. And let's not even, this group is very important. If you take up all these things, I have a few examples. Like if you take up plenty, that is polymorphous low-grade neuropathic tumor, can mimic oligodendroglioma, because it will have oligodendroglioma-like features, calcification, everything. So which is a very mimicker of oligodendroglioma. Then comes angiocentric glioma, which is around the blood vessels, can mimic other polymorphous tumors. And all these things were very challenging histologically. And if we err in that, it will totally misguide the therapy. Now, this is very popular because the perivascular arrangement you can see. So this tumor, you can easily appreciate a very rosettes here, and EMA dot-like positivity. This will histologically be an ependymoma. Will not depend too much. Earlier, we were not depending too much on ISC. Only for diagnosis, we used to stop, but now we have to go beyond that. What is that beyond is because of these 10 tumors which has been subclassified for ependymomas based on three things. That is, one, location. Second is the molecular profile, and going with further support with surrogate markers. Now, if you see, one suprarenal ependymoma can show two unique fusion defects. One is the zepta fusion, which will indicate that it is generally having higher proliferation and aggressive nature. And that is relatively common in AYA group, that we should remember. And when it comes to posterior fossa group, PFA category is aggressive, but AYA set generally shows PFA-B group, and that we have we depend on is H3K20 H3K27 loss. And the suprarenal tumors, we do some special tumors, special markers, which I'll show in the next slide. So let's summarize in this way, too much time is short, that you categorize ependymoma based on two important elements. One is location, another one is the molecular profile. One location is supratentorial, in that we have to remember this zepta fusion because it shows aggressive nature. Fortunately, you don't have to subject it for any of the high profile molecular testing. We can manage with immunohistochemistry, that is a surrogate marker L1-CAM, which is important to recognize because they are known to be aggressive. The next category is posterior fossa ependymomas, which could be A or B. A is again aggressive, but fortunately, in this category, AYA group, it is not that common. Of course, young age, it is very common, that is children. PFA-B, which is recognized based on H3ME3 retention, and on PFA is H3ME3 loss, which we do that combination, that IHC is available. So that is one. And lastly, about spinal cord, myxopapillary ependymoma, which is considered as very much benign, is now capable of showing recurrence and even metastasis. This is common with AYA. And this is the one, at least we should remember about this category because of its aggressive nature and poorer prognosis. And other two are safer diagnosis, that is posterior fossa B and myxopapillary ependymoma. Lastly, just one word, I will not take much time. On adenotumors is totally dominated by medulloblastoma. Earlier it was purely histological, now it is no more histological. It is genetically defined based on pathways. We have to recognize the pathway, metabolical and both mutational molecularly. One is wingless, sonic hedgehog, and with or without p53 mutation. Another is the non-Wnt, non-SHH, which has again two categories. This is very important to do because of two important things. From a AYA point of view, Wnt, which is known to have very good prognosis, is important to be recognized. And they can show this beta-catenin CTNB mutation. Other one is the group 4, which shows ISCO chromosome 17 one. And but nevertheless, even medulloblastoma, sorry for this, how to remove? Sorry. Okay, not a problem. This Wnt has got subcategories. This to minimize. No, no, no. Yeah, wait. Yeah, just to mention that medulloblastoma understanding also has gone ahead. Wnt has got subtypes. All of them have got subtypes. Alpha, beta. In that, beta is the one which is common in AYA, which got very good prognosis. Among SHH, delta is the one which is relatively common in AYA. That is also having very good prognosis. But the other two are notorious. That is G3 and G4 not that good with regard to prognosis. All of them have specific molecular markers. One for Wnt, we use monosomy 6. SHH, we use this NMIC and patch 1. And SMO also, SUFU and like G3, CMIC, G4 isochromosome and NMIC like that. So just to indicate that, to mention that for this also surrogate markers are available. One problem with surrogate markers is it's not always 100% sure true. If it is negative, it will not rule out. If it is only indicating in positive and confirming that, then it's fine. But if there is any equivality, we have to depend on higher profile, high throughput molecular studies. Just one, I will, before I end, I just want to mention that AYA group is neither typical of adult gliomas, not typical of pediatric gliomas. Both can occur, or it can occur with unique molecular profile and the same histology. So, and a lot of target therapies are available now, some of them, especially these category BRAF, mTOR, MMEC and other things. But again, to re-stress that what we offer from a pathology point of view is an integrated diagnosis combination of both phenotype, genotype, which will guide the therapy. But one thing to mention that genotype alone, if you depend, can be a misleader. It has its own limitations. So everything should be as its own role and place. Everything should be combined. But one thing is, many times you directly jump on genotype. It is like building the whole foundation with an old building without the foundation. So there will be a lot of misleaders. So basic foundation histology, then you can build on it. Or even if you don't build on that, first foundation is good, then you can always guide it. That means to say, if you go the other way, there will be miscommunication and misinformation, which will not be correlated function or validated on histology. There may be wrong therapy. So see to it that everything is integrated and all the information is available. Anything deficient, you can always seek for it. That's it. Thank you.
Thank you, Dr. Mali, for your excellent overview for molecular pathology and TYA brain tumor. One question from my side. So, in any TYA brain cancer session, we should order comprehensive NGS panel or selective NGS panel?
I think we can go in a step by step order. So NGS comes into picture. Of course, if I see the utility of NGS, most of them comes for AYA and pediatric on the adult. Somehow it's solvable. But we don't directly go into NGS. It's usually in a step by step. First, immunohistochemistry. If it is solving straightforward ones, we stop at that level. Then we go for a little higher level molecular profile, managing at the level of sequencing, that is targeted sequencing and FISH. If that is not solvable, only we go to NGS, because NGS information is too wide. Sometimes it will be misleading. And only when we are not able to solve, only we go up to that. So it constitutes around 10 to 20% of cases only, not major.
Any particular situation where you will recommend NGS before
That I will tell you a very good question. Actually, this we faced, especially in sometimes small stereotype biopsy will come. Very small, extremely small. There we don't want to exhaust the tissue by a full panel of IHC profile. And we do very basic, very crucial ones. Let's take midline gliomas, we do midline markers. If it is negative, we don't want to do further IHCs because it will exhaust the tissue and not available for anything. That's the time where we take an early decision of this thing, and depending on the affordability of the patient also. We go by case rather than a generic rule.
Let's say when we find out that the IHC is showing negative result for IHC mutation, so we should find out by NGS.
No, we can go by targeted sequencing, that is DNA sequencing, but it is in an adult. But in a child, if it is negative, then we may have to do other IHC markers to really look for it.
Actually, neuro-oncology from long time we have seen that mainly this molecular classification has changed from low grade to high grade or high grade to. In clinical practice, what we have seen from last lots of years that even from radiation point of view, those is not big change.
Very true.
And as far as the main treatment is surgery, followed by if there is surgical action followed by radiation. On almost 50% patients we are getting a GBA for primary grade tumor. So even in GCI we had straight up CMA discussion about it. The radiation dose and the survival has not been changed in brain tumors. The classification is changing.
Right. Actually, there are two catch in that. Very correctly said. If you see WHO, it's primarily driven by pathologists. That is one danger is there. Second thing is when it comes to the translation part of it, most of them are Western data. So, and they are trying a lot of trials and giving even the marginal change in 3 months or whatever 5 months, they're indicating that it's poor prognosis. That is the message they are giving. So that is coming into as a grade, that is changing the grade. I'm just mentioning it is how it is. So some things are coming in paper, but in fact it is still not translated because the difference is less. The availability of information is some of them based on some rare tumors also they are indicating that. And few cases, just because the cohort, if it is small, some of the studies where cohort is small, but they followed up extensively. And for the changes itself, for those changes of small cohort, they're indicating a major change in the classification. That has its own limitations. Still, it has a lot of revision is required. But I am sure there are two things here. One is pathology-driven classification. Second is little Western data is influencing that. And one more to add this is the problem with DNA methylation profile. It is totally driven by some of the centers. The information given is actually putting a lot of weight on the WHO classification. If DNA methylation profiling is indicating that it is high grade, they're putting into the classification. But at the translation level, it is still not making a big difference. Histologically, it is still low grade. But DNA methylation profile is telling, or the other way also. So that is causing this confusion between the nomenclature of the classification and the practice of radiation. That the limitation is.
Thank you. Yes, sir.
Sure.
Thank you for a wonderful talk. Is there indications that the genetic profiling of Indian brain tumors may be different from what we see in the literature from the West?
Yeah, one thing is the data like that is less from India. It is usually a single-centric thing. So if somebody takes a kind of forms a registry and tries to correlate, I would say that I've just, it's a kind of extrapolation. Say there will be definitely diversity and such that there may be some differences. There will be differences. There will be some amount of resemblance to the Western data, but I think it will go beyond that. So we cannot completely depend on Western data is my personal opinion. There will be some additional genetic information, that is for sure. Because we are seeing some kind of response also difference in the response that can highlight. And also some of the morphological differences, the way they, whatever the Western data give, this is the IHC profile of the scene, but we are seeing a lot of differences in that. It is not exactly similar.
Thank you. One more question. On the basis of molecular pathology or the basis of mutations, we can say that this tumor is sensitive for this targeted therapy or this.
Yeah, especially.
But on if we talk about radiation, how we can say this mutation or this molecular pathology is sensitive for radiation?
Yeah, this is again by interaction with the radiation oncology and other things. The best example, there are some which will fit into the box very well, especially the oligos, which have got 1p19q and IDH. They are very good fitters. Germinomas, they are very good fitters. Some of them still hold good, but still they are tradition only. Only few tumors have adding up. But the amount of information which is coming that they are recommending in that the one which fits into the box are only very small, 5%, 10% like that. Some are in the border zone, which you have to, since they are falling in the border zone, you can consider that. With regard to inhibitors, the BRAF, some of those are doing very well, BRAF, my understanding. But there is a large chunk which is still not fitting into the box. Just because small percentage have responded, we are putting the entire group into that category. Still, there is small percentage may respond, but we don't know where to take a chance.
Thank you. Thank you very much.
Thank you, Dr. Nandit. And for the next talk, I will invite Dr. Oration
This virtual is virtual. We will do later on. Next again. वो announce करो.
और next one, I will invite Dr.
There is no announcement.
So now we'll have a poster presentation. So I request all the participants to come this side.
Okay. Next, Anushka.
Thank you, Dr. Maitrik Mehta, Dr. Deepak Patel, Dr. Prashant Kumbhaj, and Dr. Sandeep Jain. I would like to invite the chairpersons, Dr. Akash Patel and Dr. J.P. Nima, and the speaker, Dr. Neelam Singh, for the topic Immuno or Cellular Therapy of CNS Tumors.
Yes, please. Yes,
Shall we start? Yes. Good afternoon, everyone. So we had some really lovely talks. So going ahead, I'm going to be talking on the role of immunotherapy and cellular therapy in CNS tumors. So as we see the data from the Globocon 2020, and here as we see the incidence of glioblastoma, the brain tumors, has subsequently increased, and it's 2.66 per 11,000 per year. With GBMs and astrocytomas, it's around 0.45 per 100,000 per year, and it's in the oligodendroglioma, it's around 0.29. So this kind of tells us that how important it is for us to really look ahead and what are the other modalities and therapies that we can do to improve the survival in brain tumors. So here talking about the pivotal trial that came long back in 2005 by the Stoop et al., and where it showed that in both the cohorts, the MGMT unmethylated and the methylated, where we saw a median progression-free survival of almost 5.3 months, and in the unmethylated cohort and in the methylated cohort around 10.3 months of benefit with addition of post-surgery addition of CTRT. So what are the expectations and preferences that we see in management of brain tumors? So the thing that we really look at is the symptom control, the prolongation of life, and the larger thing that we really look at is basically is improvement of the overall survival. So what are the various treatment options that we have? So looking at the NCCN 2025 guidelines, so if you look at this, so as per the post-surgery, what are the options of adjuvant treatment that we have? So there's obviously the preferred treatment that we have is the RT with concurrent temozolomide in the patients who have a good performance status, and the other options as we can see here as well. So I would be essentially focusing on the management of recurrent and progressive glioblastomas, the brain tumors, and you can see the preferred options like bevacizumab, there's temozolomide, lomustine, there's PCV, and apart from that, there's also biomarker-based treatment also that's even coming up in the management of brain tumors. As we can see on the other side, we also have treatments based on the NTRK gene fusions, the FGFR alterations, the BRAF alterations, and also that we also have a drug now for targeting the H3K27M mutation. So this slide, basically, I'm trying to show the response rates that we see with the various agents that we use for the management of relapsed brain tumors like temozolomide, where we're seeing a response rates of almost nearing 45%. And when even with the combination of lomustine and bevacizumab, where we see a progression-free survival of nearing around 4.2 months, and the other agents as well. So I'd like to highlight upon a few studies in which they used immunotherapy for the management of brain tumors. So talking about the Checkmate 143 trial, where we can see that there was no overall survival benefit that was seen, irrespective of even with an addition of a single PD-1 inhibitors, but still comparing between the nivolumab and the bevacizumab, there was no significant overall survival that was seen with the addition of immunotherapy. The other two studies are like the Checkmate 498 and the Checkmate 548, where they tried combining nivolumab with RT, and then in one arm, and the other arm there was RT with the temozolomide, and followed by the maintenance. The Checkmate 458, where they tried combining nivolumab with RT and temozolomide, and in this trial as well, if we see, somehow with there was no significant overall survival benefit that was seen with the use of these agents. So there was another study, there was a randomized phase 2 study in which they used pembrolizumab for the recurrent glioblastomas, and here as well we see an OS benefit of around 13.7 months, but again it's a confirmatory study is awaited, and we really need more robust data to comment on that. Even talking on this, where they had come, there were two arms in which there was a combination of lomustine, bevacizumab, and lomustine alone. And here as well, as we see, there was an around a median OS of 8.6 months. But yes, it was there's not some durable responses that we actually saw even with the combination of bevacizumab with lomustine. So this is another one study in which there was a they used regorafenib in recurrent glioblastoma, and here we see median OS benefit of around 7.9 months. And similarly, there's another study in which they use targeted therapy, matched genomic alterations in patients with recurrent IDH wild type glioblastoma. So in this also we you could see some OS benefit that was seen. So which are the set of patients in whom we can consider the option of cellular therapy? And I'd also like to show some data and what are the types of adoptive T-cell therapies that we have. So going ahead with the case discussion, so there's a 26-year-old gentleman with no comorbids. He was diagnosed as a case of right frontal GBM, IDH wild type, and this was his NGS report with an MSI low and a PDL1 negative. So he kind of received and exhausted all the standard lines of treatment, and then he progressed in December 2024. So what are the further lines of treatment that we can consider for this patient? So now, we'd like to discuss about the types of various adoptive T-cell therapies that we have. So I would like to particularly talk about the CAR-T and the TCR therapy, because TIL is something that becomes really difficult in brain tumors, because it's not easy to take a biopsy from the brain tumors and then send it for further expansion. So focusing on CAR-T and the TCR therapy. So CAR-T is something that in which we basically do harvesting first. So basically the peripheral blood mononuclear cells are taken, and then that is followed up by identifying the target antigen. So what are the various target antigens that we are looking at? And we do have some data for managing the brain tumors that I'll be talking in my subsequent slides as well. And then that is followed up by identifying the antigen, and that is followed up by the, generally in brain tumors, we do not do lymphodepletion therapy, but then there's CAR-T manufacturing, there's bridging therapy, and then subsequently that is followed up by the CAR-T infusion. There are various protocols as well, depending upon which antigen comes positive. The CAR-T infusion, the dose also varies. Then going ahead with the TCR therapy, we also have some very, very upcoming data for the T-cell receptor therapy in management of gliomas. So there's a big challenge that we face in the TCR therapy, that it is HLA restricted. So there is there's a specific HLA typing, there's an HLA 0201 that has to be present for a patient for which we'll be able to do a TCR therapy. So this is, and these are some of the options, and along with that, there's also some data that's coming up for the allogenic gamma delta therapy that also I'll be talking in the subsequent slides. So as I was talking, so these are some various antigens that we can see that can come positive for various brain tumors. So there's one is the EGFR V3, there's interleukin 13R alpha 2, there's HER2/neu and B7H3. So what's an EGFR V3, so it's expressed in about 30% of newly diagnosed GBM cases. And in patients surviving a year or longer, the expression of EGFR V3 is thought to be a negative prognostic indicator regardless of other factors such as extent of resection and age. So this is one of the very preliminary studies that had used a single dose of peripherally infused EGFR V3 directed CAR-T. Direct cells mediates antigen loss and induces an adaptive resistance in patients with recurrent glioblastoma. So as I spoke, so this is the entire procedure what we do. So that is leukophoresis, and that is followed up by manufacturing of the CAR-T, and then there's a bridging therapy, and then we subsequently give the CAR-T infusion. So it's basically, you can see it's day +1, there's day +3, day +7, day +10. So it was given in 6 sittings at the CAR-T infusion that was done. And we can see there was an OS benefit of around 8.2 months that was seen with the use of this particular CAR-T. There's one more study similarly. There's a very small case series in which they had given an intraverticular CAR V3. It was basically a T-cell engager antibody molecule that was used in the management of recurrent glioblastoma. So here also we can see that there was subsequent reduction in the tumor mass that was seen. But yes, we also need some more robust data to, give an exact to talk that how much it really works, because as we gradually saw that the levels of the EGFR CAR-V3 that was given, subsequently it was reducing in the blood. So we need a more longer follow-up data to exactly talk about how much it does really benefit. This is one of the pilot trial of adoptive transfer of CAR-T targeting EGFR V3 in patients with GBM. So here also there was a median PFS of around 1.3 months that was seen with a single outlier of around 12.5 months. And there was a median OS of around 6.9 months that was seen in this group of patients. Talking about the second antigen, that's the interleukin 13 R alpha 2. So this is one of the initial studies that had showed the bioactivity and the safety of interleukin 13 alpha 2 redirected CAR-T CD8 T cells in patients with recurrent glioblastoma. So here as well, you can see the similar protocol was given, and then they had given 5 weekly infusions, and then a restaging MRI was done, and we can see that a good amount of necrotic volume and a good response that was seen subsequently. We can see up till 129 days and up till 84 days that subsequent there was increase in the necrotic volume at the tumor site that was noted. So this is also one of the trials in which there was a loco-regional delivery of the interleukin 13 alpha 2 that was done in a recurrent high-grade glioma. And here as well, if we see, there was a good response that was seen, and most of the patients that were used in this trial were post almost third recurrence. So I'd like to talk about one of our cases that we treated. So it was a 36-year-old male. Similarly, he had progressed on all the standard lines of treatment. And when we did his antigen testing, he was tested positive for interleukin 13 R alpha 2, and we gave him a interleukin 13 R alpha 2 CAR-T on day 0, day 7, and day 14 with a dose range of around 2200 10 to the power 6 million cells. So this is the subsequent MRI that was done. So we could see that there was subsequently there was a good response that was seen even post CAR-T, post 3 months, and even now the patient continues to have a stable disease. So there's another antigen in which we combine basically EGFR with the interleukin 13 R alpha 2. So this is also one of the studies in which there was an intrathecal bivalent CAR-T cell targeting EGFR interleukin 2. Both was used. It was a phase 1 trial in which we can see there was a gradual reduction and enhancement in tumor size that was seen subsequently, though somehow it did not meet the criteria of overall response rates. But yes, obviously we do need more longer follow-up and more data to talk about that. There's one of the other antigens that generally comes positive is a HER2 new. So in this study, as we see, it was again a phase 1 study in which around 1 into 10 to the power 6 to 1 into 10 to the power 8 million cells were infused without any severe side effects, and 50% of the patients had around objective response. So there's another target antigen that we have as well is a GD2. So this article basically talks on intravenous and the intracranial GD2 CAR T cells for the H3K27 positive diffuse midline gliomas. And and here as well, we can see there was a median OS benefit of around 20.9 months that was seen in all the patients. This is one of the patients that we had treated. He was again a 22-year-old gentleman with a diffuse midline glioma, S3K27 altered, progressed on various lines, and then his GD2 came out to be positive. So we gave him a GD2 targeting CAR T. And then again, he was given one infusion of around 310 to the power 6 cells per kg. In this image, we can see that this patient as well responded well. This is the image that was taken post 2 months of the CAR T, and even now the patient is continuing to have a stable disease. So the last antigen that I would like to talk about, the B7H3. We got a recent data in the ASCO 2025 where we got a phase 1 data of B7H3 CAR T that was administered intracranially in the recurrent glioblastoma. So there's this Ommaya reservoir that is actually placed for the intraventricular CAR T. And then in this, basically, they had given 6 infusions that was given over a monthly 6 infusion that was given. And we can see then there was a median OS benefit of around 13.5 months that was seen with this. This is another one abstract that came in the ASCO 2025. For the allogenic CAR T, that's the gamma delta T cells in the newly diagnosed GBM patients receiving the maintenance temozolomide. And here, as you can see in the different subsets, all the patients had stable disease with a PFS of ranging almost nearing between 11.9 months, 22.2 months. So this table basically summarizes all the studies and all the antigens and what are the results that we have with all the data that we have with the particular antigens. So yes, as we also spoke, that still with all of it, there are a lot of challenges that's there for the CAR T in glioma. So yes, the first thing is the immune privilege of the brain. There's an immunosuppressive tumor microenvironment, the checkpoint inhibition. There's a hypoxic tumor environment, the tumor heterogeneity that's on and the T cell exhaustion, and obviously the on shelf and the off shelf. That is something that is really challenging. So yes, there's a lot of data that is coming up. So we have to wait for more data to come up, and then maybe we'll be able to have a clarity on how these CAR T cells are working. So yeah, it's a long way to go. And with this, I would like to thank you all for the patient hearing.
Thank you so much. Thank you. Thank you, madam.
Thank you, sir.
Sir, for the from the Mumbai, talking.
Thank you so much, sir, for joining us on stage. Now, I would like to invite our chairpersons, Dr. Bharat Parekh, sir, and Dr. Sirish Arulkar, sir, for our next session, Immunotherapy, New SOC in SCLC.
15 minutes and
15 minutes.
मैडम इंट्रो पे पहले ये करना जरूरी है
या तो आप ना सीधा एक काम करो
कर लेता हूँ ये वाला ओपन करते हैं.
Next session will be on small cell lung cancer, specifically the extensive stage. For that, I invite Dr. Chirag Shah, Senior Consultant Medical Oncologist from Apollo Ahmedabad, to give his talk on the extensive stage small cells, specifically focusing on the role of immunotherapy And then this will be followed by a panel discussion moderated by Dr. Abhishek Thakur.
Good morning. Thank the organizers for this opportunity and to talk about this very interesting new molecule. Small cell lung cancer has been a very difficult cancer, and that too the when we are talking about extensive stage. So I have a lot to cover, so I will quickly go through these slides, but mainly the idea that now we can do more than chemotherapy alone. So small cell lung cancer, very simple staging, limited and extensive stage. 15% of the total lung cancer are small cell lung cancer. This is from the North Indian data, I think from AIMS. Now, the median OS, what is important is to so the median OS is less than 1 year for extensive stage small cell lung cancer. This is the most important part of the what we have been doing for small cell. And now there are addition of the checkpoint inhibitors, the immunotherapy. The two important trials have been the Empower with atezolizumab and Caspian with the durvalumab. And this is their trial design where they were compared against carboplatin etoposide with primary endpoint of overall survival, which is an important relevant endpoint. And as you can see here, without going into much detail, but essentially think that there is a benefit in PFS and OS with statistically significant p values. This again showing the exact numbers here, the with a hazard ratio of 0.7 in atezo and the Caspian 0.73. So if you can see the difference, the median does not seem very big. Of course, only 2 months change in the additional overall survival 2 or 2.7. For those who are treating small cell lung cancer, this is the first time in since the 40-50 years there is something that has done this. So coming to serplulimab, which is a PD-1 receptor inhibitor with a differentiated mode of action, where it has been compared with pembro and nivo, at least at the laboratory level, where it shows a better PD-1 internalization. So there is a different mechanism of action. It's based on the mechanism, as you can see here. So the the other ones do not block the PDL2 pathway, only the PDL1, the existing molecules, whereas serplulimab blocks both PDL1 and L2. So that is the advantage from the mechanism point of view. The drug has been approved by DCGI in June 2025 for first-line small cell lung cancer, and it is also approved by the European Commission for the same extensive stage small cell lung cancer. So the pivotal trial showed this is the design standard carboplatin etoposide placebo controlled trial. And 2:1 randomization. So fairly large trial for a small cell lung cancer. I must congratulate the investigators actually to get so many patients on this trial. And this was followed by either serplulimab versus placebo maintenance. So the baseline characteristics are fairly well matched by whether they're Asian, smoking status. They have also looked at the total lesion burden, disease burden, and with prior anti-cancer therapy, PD-L1 expression more than 1 or less than 1. And by both TPS and CPS, and brain metastasis and liver metastasis, and it is well matched. So now in the trial, the Asian patients were 67%, which so there is a much larger number of Asian patients compared to all the other studies that we normally see. These are some slides showing now comparison. Of course, this is a cross-trial comparison, but just to understand that how the other trials have only about 15% of Asian patients, whereas here it is 68%. Although when we say Asian, this was not India, but mainly China. The baseline characteristics by PD-L1, by TPS and CPS are percentage coming different, but they looked at it both ways. Although now in lung, I think most people follow TPS, but the investigators chose to look at it both ways. And you can see that by TPS, 83% are negative, by CPS, 46% are negative. But otherwise, brain mets and liver mets wise, they are well matched. And coming to the results, the hazard ratio for overall survival is significant. And so the hazard ratio for overall survival is 0.63. And if you remember the previous two studies, the Empower and Caspian, the delta for OS was 2 months and 2.7 months. Here it is 4.5 months. So at least in the cross-trial comparison, this data certainly seems better. And a 4-year overall survival of 21%, which is a very significant number for a extensive stage small cell lung cancer. And this compared to the chemotherapy is 3 times. Now they also looked at subgroups, whether there was any subgroups which did better. And essentially in all the subgroups, it seems to be better than chemotherapy. So there is no specific subgroup where it would not be indicated, including the PD-L1 expressions, whether it is less than 1% or more than 1%, and whether it is TPS or CPS, and the metastasis and performance status, everything. So this is the first PD-1 inhibitor which achieves positive results in international phase 3 clinical trial for extensive stage small cell lung cancer. At median follow-up of 12.3 months, the median PFS is 5.7 months versus 4.3 months with a hazard ratio of 0.48. So very significant hazard ratio for PFS also. The overall response and duration of response. The confirmed overall response was 68% versus 58% in the placebo group. And the complete response rate was 9 patients versus 0 patients. And the partial response was also higher. And the median duration of response was 6.8 versus 4.2 months. So once again, with significant hazard ratio, and although these numbers may look very small to people who don't treat small cell lung cancer, but for many of such advanced cancers, this is significant. the safety data. So essentially, both arms have same grade 3 or more adverse events. Except you can say that the IR related events are as expected higher, although they are not very big, but the uh, immune related adverse events, which we are used to now with use of other checkpoint inhibitors frequently. But overall, it seems that the adverse events are fairly comparable. So, serplulimab plus chemotherapy has achieved a 3-year overall survival rate of 24.6%, bringing extended survival benefits to the extensive stage small cell lung cancer. And the cross-trial comparison of overall survival gain, again highlighting 4.7 months versus with the atezo 2 months and durvalumab 2.4 months. So there have been network meta-analysis also using different methodologies to see, compared to the other available checkpoint inhibitors, what would be the benefit of the available agents. And in that, in practically all the network meta-analysis, serplulimab has been ranked as first for overall survival compared to the other available agents. A lot of people follow the ESMO MCBS guideline to understand the impact vis-a-vis the cost and other factors. And so the magnitude of clinical benefit scale, it highlights those statements which substantially improve the duration of survival and or the quality of life of patients with cancer, and aims to distinguish them from trials demonstrating more limited and sometimes even marginal benefits. So based on this exercise, ESMO has given the highest level benefit score to serplulimab, as in the substantial benefit compared to the other available agents. And this again is shown as to how they grade based on the hazard ratio and the gain in survival, the median survival, as well as the long-term survival. So I think this is again showing the same thing what we've seen, that serplulimab combined with chemotherapy offers the greatest benefit for patients with extensive stage small cell lung cancer. You can see that the median survival gain is 4.7 months, 15.8 versus 11.1. And the 2-year overall survival rate is 31% versus 18%, a gain of 13%, and a hazard ratio of 0.61 compared to the atezo-based treatment, where it is 12.3 versus 10.3, and the with durvalumab it is 12.9 versus 10.5, and the 2-year OS rate gain is 5.2% and 9% compared to 13% here. So in conclusion, first line extensive stage small cell lung cancer, now the standard of care is not chemotherapy alone, not just cisplatin or carboplatin etoposide, but with addition of IO and one of the 3 checkpoint inhibitors, which offer modest but clinically meaningful survival benefits. And for some patients, it could lead to significantly long-term disease control, although a larger number would still not be benefiting a lot. But some, until we have ways to identify who are the patients benefiting. These are the trial designs. So serplulimab has a unique mechanism of action, including high PD-1 binding affinity, PD-1 receptor endocytosis, and preservation of CD28 signaling, which potentially explains its enhanced T-cell activation. Serplulimab, the first anti-PD-1 agent approved for extensive stage small cell lung cancer, showed significant improvements in overall survival and progression-free survival in the pivotal Astrum 005 trial with a manageable safety profile. Serplulimab has the highest ESMO MCBS score of 4 for extensive stage small cell lung cancer, indicating substantial clinical benefit. Serplulimab represents a new treatment option for extensive stage small cell lung cancer. I think I'll stop here. Thank you.
Excellent review of the newer molecule now available in India. And I think we will be having hands-on experience and much more confidence after its utilization. And in the next panel discussion, we will be utilizing the skills of Dr. Abhijit Thakur to bring out the Indian questions and relevant data.
Permission of myself, Dr. Chirag. So, we treated a patient with first line cystic over. Patient comes to me for a second line progression. Can I use Serplu? Any second line yet? Any data on that? Not second line.
In second line, probably first line it is in combination with chemotherapy, but second line it can be utilized as a monotherapy, but data will be available. So I request Abhijit to invite his panelists.
Yeah, so thank you to, first of all, Pankaj sir, and for the organizing secretaries and the conference. It's very heartwarming to see sir again in between all of us and conferencing. So I think I'll invite the panelists as we have a very short span of time. 15 minutes is too small. Dr. Akash Patel, Dr. Rohit, Dr. Yesha, Dr. Pushpendra, Dr. Siddharth Lat. So there is an Akash Patel and an Akash Shah, Dr. Prutha Patel, Dr. Asif Sheikh. I think everybody knows that they are supposed to be on the panel. Yes, Akash is there. Self-explanatory. I don't think we should be inviting them. Presentation. Yeah, please. So I think Dr. Chirag has already basically alluded to the data. And I think since we are in a very quick fire discussion, these all standard questions can be omitted when we get to the point. And the yeah, done. The point being, yeah, there are a few points. So let us start with Akash. Biomarkers in small cell. I think we'll forget the previous discussions, staging, how do you stage? Those are all pretty old questions. So biomarkers for small cell?
Is not for first line, but I don't do.
Okay. So we are basically extensive stage small cell. We are not looking at small limited stage. This is extensive stage. So role of biomarkers?
As per guidelines, no, but I've seen few clinicians actually they treat like non-small cell lung cancer and they do NGS and but otherwise it's not required as per guideline. No biomarker.
Akash, Asif, Rohit, anybody wants to add anything?
No, sir, I agree.
So, yeah, please.
Currently, I think only that SCLC1 has some prognostic impact on management, but obviously it's not a targetable sort of a mutation. There's a prognostic marker that really helps. PDFM per se is there. It's positive in small cell lung cancer, but that's not being correlated with the survival.
Anybody wants to add anything new to that? Asif, Pushpendra, Siddharth?
So for first line, absolutely no. In second line also, when we don't have standard of care, then only.
All right. So for the lack of time, there are biomarkers which are coming up in the form of drugs, which are ADCs, and it will be of use in the future. And you're absolutely right. As of today,
So I have 23 minutes. Amazing. From 15. So, so as of today, you're all right. So the biomarker of interest is none. And we are still, it's a hardcore old solid tumor metastatic, which we treat in our traditional form. And the next question would be again, I would just, these are questions which are of no use. We'll go to the point because the point of discussion is immunotherapy, right? So again, we'll start with Akash, your standard of care.
Plus platinum.
Okay.
Plus
So the other Akash, number of cycles, which platinum? You have a hard choice or it is
no,
okay?
sir, I am comfortable with both unless until the patient's other comorbidities. Otherwise, cisplatin, carboplatin with etoposide, those are the backbone of the chemotherapy agent. I can use for 4 to 6 cycles, depending on the burden of the disease. And I will also add with the immunotherapy with this platinum-based chemotherapy.
We'll come to that. So Pushpendra, 4 or 6 or 2 maximum response, or you keep giving it?
Minimum 4, sir. Depending on the tolerance. Tolerating well, no side effects, up to 6. In presence of IO, may limit up to 4 because most of the trial, older trial like the IM Power 133 and Caspian have 4.
So I suppose you could answer the other questions also because you were a radiation oncologist as well. So what is the role of radiation in an extensive stage? And then Siddharth and our other panelists can add in an extensive stage.
So that was from the small trial where what they have shown is ki if there is a limited extra thoracic burden and after systemic therapy, if there is an excellent response, and that was before the immuno era. So if you can give 13-10, that has added some survival.
All right. Anybody
In the
want?
presence of IO, we don't know.
You want to contradict or add anything or subtract?
Thoracic irradiation, again, if there is excellent response, but coming to the brain mets and the PCI, role of PCI. So the initial EORTC trial did mention some benefit of the PCI, but they had not done any baseline brain imaging. So eventually it was seen that when we do baseline imaging, more than 70% of the patients in extensive stage already have brain mets. In those cases, when they do not have brain mets, there was no additional use of adding the toxicity of PCI. Rather, only MRI-based surveillance was a better option, which when we are dealing with the compliant patient.
I agree. So Asif, maybe you can elaborate this slide. So this is the entire journey of extensive stage small cell, and we stand today at something new, maybe not very exciting, but still encouraging.
It started with tumosite cisplatin, then it was found that carboplatin was non-inferior, so people said carboplatin with better tolerability, and then come TYAcon, and then some trials of PD-1 inhibitors, nivolumab, pembrolizumab, but it was not that successful. Then PD-L1 inhibitors came into the picture, itolizumab and durvalumab. That was positive trials, and now we have another PD-1 antagonist which is better, and trial is also positive.
Since we have come to the discussion of PD-1 and PD-L1, I think we were discussing yesterday also. It's a very interesting one. Maybe somebody can tell me if there is a difference between a PD-1 and a PD-L1, not theoretically, response-wise, treatment-wise, side effect-wise. Anybody? And I'll ask some of the seniors if they can find out a real difference. Okay. Yeah. Anybody from the panelists? Then we'll ask Pankaj sir.
So I want to add, right?
Please.
In PD-1 antagonist, there is also a role of co-stimulator of one inhibitory molecules. So if we down-regulate both, then it can be more effective. In PD-L1, it is simple. We are inhibiting PD-L1. We are not inhibiting the other co-stimulatory or inhibitory pathways. As
Correct. So that is one difference, and that is one reason why the molecule you are discussing since last half an hour is supposed to be a little bit better than the others. But then let's forget the mechanism of action. The mechanism of action is
no difference for side effects for me.
Anybody? Sir? Yeah, please.
Theoretically seen that PD-1 given with chemotherapy can act as a benefit. Survival outcomes can be better. In terms of toxicity, also theoretically it has been seen that PD-1 inhibitors have a higher amount of toxicity in some cases, and this is what we are seeing in most of the trials. When we see cross-trial comparison toxicity profile, there is an increased toxicity. There is data, and then anti-PD-1 can these secondary responses can be increased, so downstream pathways can be more effective in anti-PD-1.
Let's ask sir. Sir,
I usually go to the research, whatever they teach. All this going too much detail on the molecular aspect. I will there.
no, sir. I'm asking about your experience, whether you find any difference.
I was probably fortunately first person because one of my classmates came with the small cells CLL with metastatic brain disease. As a metastatic brain disease was symptomatic. Whatever you have discussed, but I have to give you radiation. And along with that, the person. Unfortunately, he is scheduled for second cycle today or on Monday, and he is just.
Okay. So I think Siddharth Asif rightly pointed out there is a small difference in the way they act because one is a receptor, one is a protein, one needs co-stimulatory molecules, which this drug is doing better. And Siddharth rightly said, although we don't find any difference, but technically from the meta-analysis that has been published recently, PD-1 is slightly more toxic, but better than PDL-1. You can go through that. I haven't brought it here by myself, but then PD-1 is supposed to be a little better than a PDL-1, effectiveness wise also, and side effect wise also, it is worse, as you said. But that was a surprise for me also that PD-1 are better than PDL-1 because I thought they are all the same effectively. So go through it, now you will get it. But then there is a difference. And it is a meta-analysis. It's not just a random trial which has said that PD-1 is better than a PDL-1. So you can read through it.
Unfortunately, we don't have any data, comparative data to immunotherapy drugs.
They will never be compared.
They have never been compared and we are compelled to prescribe something.
So, but then, sir, there is enough data to suggest that, and as it is, so the recent 2 or 3 drugs which have come, they are PD-1s. If you see the literature that they are publishing in most of these conferences or lectures, they seem to be a little bit better to our amazement. You see the HRs, they are better than the previous drugs which we have been using since long. So I was amazed why these 3 are showing a better HR than the others, which are our traditional 10-year-old drugs. And that is why I was looking through that if there is anything to lie back. So if there is any data, we can rely on. Sorry? So, yeah.
Trials of P1 cancer have also been done for SCLC, but they failed. So we have to assume that only the difference in the mechanism of action is the one that is in play.
So in this PDL-1, anti-PDL-1 did better than a PD-1. The PD-1 which you are describing right now is doing well. So this debate can continue, this controversy can continue, but then there is technically, as these 3 guys told you, there is a difference. If you read through it, you will find that there is a small, but there is some difference between the 2 drugs, effectiveness wise, mechanism wise, side effect wise, everything wise. Because why I am telling you that is in a clinical practice, we just tend to use them arbitrarily according to the guidelines. We can interchange, we can interuse, we can do anything we want. So let us, I think Akash. So as of today, you have a small cell extensive stage. So what are your options after the cis-ito and carbo-ito or with the cis-ito and carbo-ito? Let's keep the after for that later on, but with the cis and carbo, your options?
Sir, TLAB we have atezolizumab and durvalumab to combine with the circulating and etoposide based chemotherapy. But now we have another option also, that is sertlulimab, and it has also the excellent result in terms of the delta, that is almost double in terms of the difference in median OS.
Exactly. So Rohit, you want to add anything? to these two HRs? You're just audible, you can speak.
No, by and large, they almost land up at the same level, sir. But one more thing I wanted to just talk about the thoracic radiation part, right? I think in the day of immunotherapy, it's better not to use it because obviously you're going to irradiate the lung. And
So all the previous discussion was outdated. That is why I skipped it so fast.
No. Yeah, correct. So the thing is, I think by and large, the hazards ratio is almost similar. Different patient populations probably did contribute to the different hazards ratio that we see because this has predominantly an Asian subset of population. That is why we see a certain difference in the HR.
So important thing is you keep the HR in mind. It is 0.7, 0.73 as Akash told you, the delta is about 2.5 months. So you are looking at now Heteronifly, which is your anti-PD-1 mAb against extensive small cell. I think the data was presented by Chirag Bhai. I hope you have gone through the data. As Asif was telling you, the difference is in the mechanism with which it acts, and you can read through it, but there is the difference, and that difference has probably contributed to the effectiveness. And there is a difference. If you go through the PD-1 both comparison, you will realize that there is a difference in the way they act, although we don't tend to read through it and compare them equally. And that is why this molecule is doing, or anti-PD-1s do a slightly better job than your PD-L1s. For this, you can see the HR is 0.63, the delta is 4.5. Although somebody might say not a great difference, but for a disease like small cell where you had nothing, so something is better than nothing. So it's at least giving you some improvement. And what is important is always, as is the case with immunotherapy, Pushpendra. Yes, exactly. So you are looking at those 10 guys who are going to ultimately benefit from this out of the 100, right?
1 out of 4 at 4 years.
Exactly. So that is what you need to tell the patients, that 1 out of the, or maybe 1 out of 10 or 2 out of 10 might live out and benefit from that immunotherapy. The rest would be palliation. So this is the ultimately what was presented. I think the last data 4-year OS is 21.9, which is quite amazing. So I think that the other two had a 5-year of 10% or less. So this thing, Heteronifly is giving a 4-year OS of 21.9. So as you said, out of 10 or out of 5, 1 is surviving. Out of 10, 2 are surviving at the end of 4 or 5 years, which is for a disease like small cell, quite good. It's amazing actually, because non-small also, we have landed up at the same place as of today.
Sir, we don't have any like effective option second line also. No, that is.
So that makes it more important that you give the patients benefit if they can afford it. So this is affordable also. If they can, they should be receiving it in the first line because this is their only chance. Although then there might be a disagreement to that also, because small cell has, what's new is that small cell has, anybody has gone through small cell. Now probably in the future you will have subsets of small cell where some of them respond to immunotherapy, the others don't. So this might lead to subcategorization. So that is a topic for the future. What is important is overall, if you see the trial, you can see here that there are more number of Asian patients, right? There were no, so this is one slide which will tell you everything that there were in the Heteronifly trial. You can see there were a good number of patients. It's not a small trial. So you had about more than 500 patients, 585 patients. About 70% were Indians. Performance status, probably you won't mind more of ECOG 1. Brain mets, 13% patients were there, which were few in the other trials. But then important thing is there were more number of Asian patients, probably comparable to us, maybe. And so the trial data can be taken a little bit more effectively, as most patients would try to, basically most people would try to bring out something out of the trial. But I think the trial is well done. The data looks to be effective and the drug seems to be effective. Ultimately, it's very recent. So all of us need to gain experience with the drug as we had with the other drugs since last 10 years. But then the difference, I'm trying to point out the differences between your traditional immunotherapies and the ones which we are using right now. And again, although cross-trial comparison should not be done, so you can see the duration of response, the response rates, the OS rate at 4 years. So seems to be at least comparable, maybe even a little bit better than the others. So if you don't put it better, at least it seems to be very, very comparable. to the other durvalumab, your Tecentrix, and all Tisli and toripalimab. So an effective immunotherapy for extensive stage small cell. Again, so I think we already discussed this. So PD versus PDL1. So that is why I was asking you, Rohit, you look into what you're using or just the NCCN guidelines and then you start.
Obviously, the data which provides the most effective survival is finally what works in a human being is what's the most important. Whether it's PD1, PDL1, I think what works, what the data has proven, I think that's something that's most important.
Asif, your experience with the previous immunotherapies and the newer one, heteronifly. Any personal experience with the effects and the side effects?
I have started using in two patients, but it is very recent, so I need to wait.
You need to wait. What about the previous ones? The Etizo and the Durva?
In small cell, whatever we'll do, small cell is a very bad disease. So approximately 5-10% patients will be there after 1 year.
Anybody has had great experience with small cell?
I think so. I've started using about a year back. I think they're reasonably doing well compared to what it used to be in the chemo.
How many have lived beyond 2 years?
I mean, 1 year back, so they're still not yet crossed that time point since we started adding immunotherapy with chemo.
In our institute, we were using durvalumab. Surprisingly, I don't know why most people go for Atizo, but we got very good responses in some patients with durvalumab. In fact, there was one patient who defaulted after taking a few cycles for 6 months. And then he came back and his disease was still well controlled and it was stable disease. And we restarted with durvalumab and he did very well. Means he survived for more than 1.5
I'll ask you the same question again. How many have survived beyond 2 years?
I would say,
if you can count and tell me. So even I have been using since long, but trial apart, clinically, there are very few who make it very long. That is what I can tell you. So this data is amazing. All the data which comes to us is amazing, but clinically you tend to see very few patients beyond 2 years. So if you are saying it responds very well, then you should tell me how many of them are living beyond 2 years. Then I agree to you.
Can we stop after 2 minutes, please?
Yeah, please, sir. We are almost done. These slides were already shown to you. And I don't think we use this. And all of these slides for squamous, non-squamous, all of these slides have probably been shown to you by Dr. Chirag. I'll just tell you, you can see the updated PFS, even in the squamous and the non-squamous, the drug overall in lung cancer is doing equally effectively as compared to your other immunotherapies. And this is the conclusion for the non-small cell lung cancer, which is quite impressive. If you compare with all the other MABs you have or the immunos you have, again, the HR seems to be very impressive and comparable to the Pembros and the Nivos of today. And lastly, if I have to just show you one slide, these are all the current indications that the drug has or the indications which they are working on. Probably most of the indications have been covered with the drug, and most of the indications is the data seems to be encouraging and probably an effective drug for us if the cost is a concern for majority of our patients. So you could use it in a broader sense in most of your patients. If you are a fan of immunotherapy and you know what you are dealing with, a PD1 or a PDL1. If you want, I can conclude with that, sir. Yeah.
One minute, please. Right, momento આપવાના છે.
I thought you were going to ask me a question. So, okay, I am being given this. I thought somebody is going to ask a question. You said 1 minute.
Group photograph, please.
अरे कोई बात नहीं यार, क्या फर्क पड़ेगा, रोज ही फोटो निकल दो. क्या फोटोजेनिक कितने इतना फोटोजेनिक है मुझे. Thanks, sir, yes.
1 minute, please circulate it.
हो जाएगा
बोलने वाला कौन है?
हाँ थोड़ा सा ऊपर करो थोड़ा सा नहीं थोड़ा सा ऊपर करो बस मैं कर लूंगी
Thank you so much for making this panel discussion interesting. Now, for our next session, that is Dr. G.S. Bhattacharya, Oration and Felicitation, I would like to invite our chairpersons, Dr. Purna Kurkure ma'am, Dr. Hemant Malhotra sir, and Dr. Pankaj Shah to invite our orator, Dr. Shifat Banawali sir.
सर आपका ये फोटो सबका है 96 का धन्यवाद सर धन्यवाद
This is of 96, 97. He was my registrar. Mic check कर लीजिए. कोई बात नहीं. अरे कुछ बहुत अच्छा.
Welcome to this very important session of Dr. G.S. Bhattacharya Oration.
Voice.
Good afternoon and welcome to this very important session of Dr. G.S. Bhattacharya Oration, which we introduced in TYA conferences since 2022. It was a very sad story that we lost Dr. G.S. Bhattacharya in May 2021 during COVID period. And in his memory, we introduced this oration which Dr. Banawali is going to give today. I request Dr. Malhotra to introduce this concept of Dr. Bhattacharya Oration and say a few words about Dr. Bhattacharya because he was very close to him throughout his professional life.
Thank you, ma'am. It's a great privilege for me sitting on the dais with my teachers and waiting for another teacher to deliver the oration. And the oration in the name of my dearest friend, Dr. G.S. Bhattacharya. So G.S., as we used to know him in college, when I met him, I think in 1992, at the Hemophilia ceremony in Calcutta. He used to be even more obvious than what he was to do also. He used to have big curly hair and he used to be a train speaker. So, that was, my wife and I, we were having dinner at the Chinese joint. And he just walked in. Walking was not the right word, but he breezed in. I think some of you who know him would understand the objective. So then he saw me, we were speaking on the same hematology section in the department. He saw me, he came and said hello, and he sat down for a bit. And then he picked up his carry-on and left. So when we had finished our lunch, I went for the bill. They said, "Aapka bill ho gaya." I know, what do you mean ho gaya? He was a mote wale sahab, I told they gave bill. So that is, my first interaction. I mean, he got to be my, my best friend and my soulmate and my sounding board. But I was not happy with the way he died during peak COVID. I myself was positive at that time, otherwise, somewhat I would have gone for the funeral. And the funerals which happened during the COVID time, you don't have a place to go, and his wife couldn't meet him when he was in the ICU when he died. Not a good way to die, but he was a original thinker, like one of the very few people who I know who used to think out of the box. He used to come up with so many ideas. 9 out of those 10 ideas would be absolute nonsense, but one of those 10 ideas would be brilliant. And some of the papers which were published in 5, 10 years after he, vomited out those ideas to me, we used to talk for a good half hour every day. Those ideas, those very ideas, that precise concept would make it into a trial, somebody else would cover it and would publish it. But he would, kind of not take it from speaking to doing it on the ground, but he was a true genius. The year after he died, we decided that our young people should not forget this brilliant medical oncologist who was there with us. He was also one of the founding members of the TYAcon. So we started this Oration. And I'm happy that this Oration is very successful. So very, very eminent people have delivered this Oration. And continuing that tradition, we had chosen Dr. Banavali to deliver this Oration. And I think each one of you know Dr. Banavali. There is one person who I would like to be like, that would be Dr. Banavali. He was my teacher, he is my teacher, and he is certainly at least my idol. Right? Over to you, sir. Okay.
Online introduction is cancer. Then I would like to say something about Dr. Banavali. If there is no online introduction, I have known Dr. Banavali in all his throughout his oncology journey, starting from being a resident in the department to fellow at St. Jude, where I visited him and I saw how popular he was there even. He's coming back, despite all the positivity and the offer that he had from St. Jude, that he can stay back and he will be a faculty. Still his commitment to come back and his dedication to his philanthropic or whatever his Guruji's work at and Derwent. From that day onwards, he has never ever committed anything on third Saturday of every month because he goes to Derwent. And that is though he's so committed to academics, but his commitment to this personal cause is so high that he would never commit anyone on third Saturday. Am I right? Third Saturday.
Third Saturday.
Which he goes to Delhi. So his commitment, whatever he takes on, is brilliant, and he is committed to this cause of low cost treatment, and I'm sure he's going to teach us a lot after the very enlightening but costly treatment of immunotherapy.
Two sentences for me. First is Bhattacharya. Whatever the conferences I have attended so far on oncology, his presence was always vibrant. He has to comment something, he has to come with a new idea. And he was a gem of a person as far as the oncology community is concerned. Regarding Sripad, he is a man of both. When I read something about metronomic long back, and Bharat is here, we were talking and practicing small dose, and all those things. Sripad came out with the whole conference on the metronomic treatment in cancer care. So probably in India, you are the pioneer
of talking something which is low cost, which is effective, and which has a science behind it. It was just not like giving a homeopathic drug, but he knows that what is the science behind it and all those things. Indian community is thankful to you for talking about all this metronomic and lots of oncologists across the country, those who are from smaller places, they're still enjoying what you are preaching. And I'm sure that what is going to talk about his efforts of making cancer care accessible and affordable, you are the right person to talk about it. And still the birth of the oncology association and community, every one of us are talking about how to make our cancer care. Thank you.
Thank you, sir. So thank you, Dr. Kurkure, Dr. Pankaj Shah, as well as Dr. Hemant for those kind words. But really, I'm blessed to have these three people here on the chair because I've been working with them for years and I've learned from them so many things. So, this I always start with you need teachers also, but you need spiritual teachers also because, nurturing the knowledge, the mind is one thing, nurturing soul is also very important. And thanks to my gurus, I've been shown at least the right path, and whatever work I'm doing, I've been guided by them. Definitely, I've been guided by excellent teachers also. And, both I started my work with Dr. M.B. Agarwal at the Sion Hospital, where we learned hematology, benign hematology, and then came to Tata Hospital and worked with Dr. Advani, as well as Dr. Kurkure was there. So the whole group there. So it's been really good. And that's what I always tell, whatever you are, I think it depends on where you have learned, been trained, whom you have trained with. And I was really lucky to be trained at the best of places. In India, I worked at TMH, later TMC now, worked with people like MB Agarwal, Dr. Advani, Dr. Dinshaw, Dr. Badwe, who have really taught us so many things at the international level. I worked at the best of places. St. Jude's is considered the mecca of pediatric oncology. I worked there. I worked with Dr. Preisler before that, who is the father of AML therapy, and then worked with Dr. Pui, who is the father of ALL therapy. So worked with the best of peoples there. Dr. Vinay Jan is a philanthropist. He was responsible for paclitaxel, so he's earned a lot from paclitaxel, but he poured it back into the society. And then at grassroots level, I worked with Dr. Ian Magras at the INCTR, where we worked with the people who need help, the African countries and other low and middle income countries. And then definitely my work at the rural hospital of this thing. So what I learned over the years is that basically, that cancer is basically, it's very, dreadful disease, but the dread is not because you are, it kills you. I think many of our patients that are interacted with, one of the most important challenge I feel in oncology is not just finding cures, but making cancer treatment accessible and affordable to the population, because half the fear of cancer is because of the cost involved in it. And that's why for ages, I've been working with drug repurposing rather than drug discovery, which again is very important. We need new drugs, but there are so many effective drugs already which we are using. If you can repurpose them, we'll have many, many more effective therapies. So I'll start at TMH level. I'm going to discuss in three parts. One, what I did at TMH, then the state level, and then at the national level. So TMH, I was lucky. I did my adult oncology in Tata, internal medicine, and then adult oncology in Tata. But when I went there, and I worked for 3 years exclusively in the lab, but that time Dr. R.V. Preisler told me that before going back, do clinical. And then that's why I thought I've already done adult. That time there were very few trained pediatric oncologists in the country. So I shifted gears and then did my pediatric boards, and then did my pediatric oncology fellowship at St. Jude's Children's Hospital. And very importantly, actually, it's so distinct that I was born on the day St. Jude was formed. So I think I have that 1960, the same day. Actually, we both have the same day. So that's something which is inconsequential, but it's there. But this is the tagline which Danny Thomas, the founder of St. Jude's, actually used to use this: no child should die in the dawn of life. And everything there was free. Patients used to come from all over the world, but no treatment was basically, if they had insurance and all, it was there, but otherwise everything was free, which was very rare and important to me. And see the wards, actually, this is a pediatric ward, such colorful, such this thing, and then this is a pediatric room actually. And this is what it was. We worked in those surroundings, in that environment, and then we come here. This was the ward at TMH at that time, absolute gray colored, no this thing there. And really, it was something, a big change that it happened when you come back and work in such environment. And very importantly, many of our patients we could not treat, for curable cancer like childhood cancer, we couldn't treat because they couldn't afford, they couldn't stay, they had no, basically, very importantly, we have sent patients because they couldn't have arrange for blood and platelet donors. So that was really dreadful. And then, we thought that we should ask the, and LSAC, that's the wing which raises the funds in St. Jude. So I went to the management and asked for permission to start a foundation, but they told, that DA, we are under Department of Atomic Energy, and they give us a lot of grants. So I was told that DA is giving so much grant, they will not like it if we start raising fund from other places. So we were denied to have our own fundraising. But that's, the Santa Claus came in the picture, and actually Dr. Badwe, who became the director of TMC, and he was the first one who allowed us. We again went back and told him that I need to start the foundation so that we can do what they are doing in US. And he was the one who gave permission. And then I found two foundations actually. The first one is the Runner of Hope Initiative. This was along with my colleague Dr. Rohini Kevkar, who was a runner, and she got together all the running community, and then we still raise fund through that, Rohi. But the other one, which has become more important now for us, is the Impact Foundation. That's the Improving Pediatric Cancer Care and Treatment. This was founded along with my another friend, Dr. Brijesh Arora and Shalini Jatia. So we founded this. And our tagline was that, we cannot say that no child should die in the dawn of life, because we know we are not as good as what is happening there. But the tagline we use, that at least every child with cancer deserves at least one best chance of cancer. And again, the same principle, even if the child, the parents don't have 1 rupee in the pocket, we take care of entire treatment of that child. And this is what, so we learned with Jiva Foundation. I put it specifically because this was Dr. Vinay Jain who taught us first time that don't ask. We were asking for help to treat patients, but he told, no, don't ask for treatment, but these are the things you require before you start asking for money. So he gave us money to start social work, to employ social workers, data managers, infection prevention nurses, dietitians, psychologists, pharmacists, and managers. And you'll not believe, none of this comes under, post in any government hospital, or that matter private hospital. There are no posts for these people. And without this, now we know that we cannot run or not take care of most of our pediatric patients. And this is how we started. So with the impact, we had the holistic support strategy. So we started giving them financial support. We started arranging for accommodation for these children, the hygiene, prevention of infection, nutrition. We give nearly 250 people lunches and evening snacks every day free. We distribute that. We give them monthly rations. We arrange for the entire blood and platelet transfusion. I'll show you that data, the psychosocial support, education, and vocation. So a lot of things that we do. And very importantly, I'm proud to say that we are one of the few institutions in the country where everything is done absolutely free of cost for the pediatric patient, irrespective of whether they can afford or not. And our outcomes are, as you all know, are as good as those in the West. So this is what we did. So when we talked with the children at that time, when the patients used to come for the ACT clinic, which Madam has started and it's running well. So in the ACT clinic, when we used to talk with them about their experiences at TMH, and most of them told that we have very bad memories of Tata because the wards were like gray. We used to do all our procedures under local anesthesia. There was no fun actually in the hospital. So we changed all that. We made all this ward colorful. You can see the wards now. They're absolutely colorful. We have play areas there. In the OPDs, we have play areas. Every child, every day when they come to the OPD, gets some gift or the other. So every day, 365 days, we arrange for their birthday parties. We arrange for going for picnics, we arrange for crafts and this thing. And Hope is actually a program which we do every year in a big way. So a lot of fun, lot of enjoyment. And the main thing is that we want to give the children a lifetime of love and beautiful memories. And that's what we have been, thanks to many NGOs, many volunteers, many CSR donations, we can do that now at the hospital. Initially, we used to take care of only patients from Tata, but now, as you can see, basically we have lot of patients from others. So nearly the double the number of patients that we see now, and we have to take care. So we not only raise funds for children from TMH, but also the entire TMC, and that's what we do. So nearly 64 crores of rupees is raised every year, so that every child we can take care of. Still, this we need much more than this, but that's what we are doing now. But we hope that we can increase this further. But exactly what has happened was, you can see, if we started the foundation, nearly 20-25% of the children used to either refuse treatment or abandon the treatment, leave aside other things. But that has come down to less than 2% for last so many years now. So that's a very big achievement we feel that has helped us. This has not only improved the outcomes that we have seen both in solid tumors and in hematological malignancies, but overall it has helped the whole hospital also. Because after looking at our success, now nearly every DMG, we have disease management groups, and every DMG in the hospital now has started such type of activities, raising funds and helping children. And very importantly, like I told you, till we came in the picture, children and their parents had to arrange for the blood and platelet donation. So now through this, now the entire hospital, we arrange for that. And as you can see here in 2009, around only 11% was voluntary donation, but now it's more than 99%, nearly 100% of the donation now is voluntary, and nobody has to even think about arranging for a blood or platelet donation. So this is a big achievement for the children. And now in next few months, actually, we are going to move to the ECTREC campus, where a 14-story building is entirely for just the pediatric and adult hematology. But entire this thing is there, and there we thought, it was ECTREC, the Advanced Center for Treatment, Research and Education in Cancer. We have added another C there, so that it becomes now Advanced Center for Treatment, Research, Education in Childhood Cancer. So we are going to do in a much bigger way, so that any child with cancer who is diagnosed in the country will have a hotline there. And if they want to come, everything will be taken care of. So we hope this is Dr. Badwe's dream, and we hope that in the next few this thing will be able to do that. And this especially, it's an old picture, but I purposely put in there because we have 3-4 people which, one doctor, Dr. Brijesh Arora. I don't know how many of you know, but he was instrumental in starting many things. He was my right hand, left hand, everything. Then there's madam is there, so definitely she represented the whole pediatric department that time. And then Shalini Jatia, who is the officer in charge of our Impact Foundation. So a lot of good people here in this picture. So I specifically put, this is not the latest one, but I put this here because these are really was a group which was at the beginning of our journey. So that was at Tata. So we thought, we have done something for the pediatric patients, and whatever knowledge I had of St. Jude's, I could utilize that, and we have done that. And along with that, not only at Tata, now many of the other pediatric cancer units are also using that model. So that's something for the Tata. But then what at the state level, actually, I thought, so after I came back from US, I started going to this rural hospital, which is nearly 300 kilometers from Tata. It's in a very rural area. This, as you can see, this is exactly halfway between Mumbai and Goa. So this is the Valalkar hospital here. It's a very rural place, very backward financially. Lot of constraints were there, nutritional constraints were there, infrastructure constraints were there. So basically, this was the area where hardly anything medical, this thing was not available most of the time. But we started going there, and I was to go, like Madam told, on third. This is now 27th year that I'm going now, but I must have missed at least maybe 2 or 3 Saturdays in so many years, by God's grace, nothing mine. But we have been going there. Initially, there used to be very few patients, but now we have at any given time, if you go there, there are at least 100, 150 patients in the OPD and more than basically 70, 80 patients admitted. So a lot of work is there at present. And this was, initially I has to go on my own, but in 2003, actually, Tata Hospital took it as a rural outreach center, and at present, it's a rural outreach center of the Tata Memorial Center. So basically, that's you can see, Dr. Pankaj was asking this question, or who asked, I think. So this is Dr. Padwe again, young Dr. Padwe, myself, but this is of 2003. And we used to go there regularly. Madam used to also come regularly there. And this is what, so we have developed all the facilities there. The medical oncology is there, radiation oncology is there, surgical oncology is there. We have two radiation machines now, linear accelerator as well as cobalt. We have brachytherapy, so full radiation treatment is available. We have all the radiology equipment, CT, MRI, X-ray, mammography, and all the interventional radiology, the DSA machine is there. So all interventional radiology procedures are also done there. And even in the other thing, because as you all know, a right diagnosis is so important for oncology. So we also have a very good pathology lab there, including the immunohistochemistry. We have the molecular path there now. So two of our, principal investigators from Tata, actually, Dr. Ruta Mulerkar and Dr. Neelam Shirsat, who are such good molecular biologists, they are coming and working voluntarily there. So we have the next week, the sequencer there, everything. So the molecular path is there, all the radiology investigations are there. So it's a rural comprehensive cancer care center. And just recently, Dr. Sudeep Gupta, the director of TMC, inaugurated our cancer center for nuclear medicine. So not only PET scan, but also the basically the SPECT, everything is available under one roof. And that makes diagnosis easier and therefore outcomes also improve, I think, with that, and patients don't have to run around. And therefore, definitely, any good cancer center also requires a good transfusion medicine department. So we also have all the blood and the component therapy available there. But most importantly, I think this is one slide which I always like to show is basically, the and Dr. Kurkure is here. Actually, she is also very, very important here because everything, see, all these schemes start when the diagnosis is made. But if you don't have money for diagnosis, half the patient used to run away. But now through these various schemes, actually, including Dr. Arun Kurukure's scheme, we have Dr. Hila Madan Cancer Fund. So various funds are there. But because of those funds now, all the investigations, diagnosis, treatment of the patient, same like we do at TMH in pediatric, we are doing there. So for patient, everything is nearly free there. And that's really helped us so to retain the patients because they used to otherwise run away. And this is a clinic, so we very interestingly, we sometimes even have some people from outside who are interested in what we are doing because metronomic is something totally new to them. And a lot of things we have learned. I don't have time also to go through that. But one thing I learned was that we always call evidence-based medicine evidence, but evidence is what it has to be local, and that's how we created the evidence there. So metronomic therapy is generated because we had to use something. Cost was a big thing. This is before the schemes and all were available, so we had to do something that was cost effective. And even the infrastructure, there was no medical oncologist staying there. I had to go see the patient, do the treatment. MD people were there, but oncologists were not there. So we developed something that they could be taken care of by the local team there. They can go home. So this is just a few examples. Like these slides are running. They don't want me to show you that. But this is like cholangiocarcinoma, multicentric, and excellent. We name it and we have CA esophagus responding to our therapy. This is basically our CA bronchus. Another, this thing is there. So over it, we have a large series. We have published that. So exceedingly amazing results. And most of these patients, you see, this is as good as Mumbai. 5-year survival is around 50%, which is as good as any center there. And very importantly, this is my particularly, I like this because triple negative breast cancer, we have more than 90 to 93% survival. And this is consistent not for 1 or 2 years, but is going on for more than 5-7 years now. So exceedingly good data. And this is our scientific advisory committee. We were blessed to have Dr. Anil Kakodkar, Padma Vibhushan Anil Kakodkar as the chairman of the committee. We have Padma Bhushan Ramaswamy there. So a lot of good people who advise us and guide us there. So this is a very good SEC meeting that yesterday I was there, actually did that and came here today. And over the years we have got some awards also. But this is what, just to show, when we started it was a ground floor structure, not in one floor. And then in 2010 you see 3-floor structure. But see now, this is what it is. So this is the full medical college. And we have 150 new students and around 70-80 postgraduate students every year. And this is the hospital here, so this is the medical college. So over a large area, this is now nearly 70-100 acres. This increase from around 5-7 acres to begin with. And this is the hospital now, which is around 750-800 bedded hospital. And this has really helped us. And a lot of people from Tata has helped me over the years, because I used to just catch them and go. So every weekend we'll take a team, this time, for one division, sometimes of the other DMG. So we used to go there, and it has helped us to develop that. So lastly, coming to the national, this thing, what is this thing, what I did. So like I told, not now, thinking out of the box, Dr. Hemant told that this may be the paper when Hemant was, sorry, slides are running. But this was a patient of angioimmunoblastic lymphadenopathy who had failed COP chemotherapy. And if she was that time, we did not have grills on our ward. I don't know if you remember, 7th floor, 30 ward, and this patient was jumping from the ward boy just caught her. And when we look at the pathophysiology, this was, the helper suppressor T cell ratio, and basically the functioning of suppressor cell is decreased. And we used to use for the same physiology in autoimmune hemolytic anemia. We used to treat them with danazol. So I told sir, on a Tuesday grand rounds that we used to have, okay, why can't we use that? Everyone laughed at me, how can the patient has failed chemotherapy and you're talking about a drug which is this thing? But sir asked everyone, is there any other treatment here? There? So when they told no, they allowed me to use that. And this patient, patient went into remission within a short time. And we even published this. It was my first paper from Tata as a resident. But then we did a lot of work on MCP 841 protocol, basically, so that became a national protocol. So along with that, afterwards I modified it, and there was a modified 841 protocol, which again was used widely, extensively in the country. And then we have started, after Dr. Vaskar Shah came, along with him, we started the icicle protocol. So that is now running at present. So a lot of thing in childhood ALL. But this is my baby, actually. This is what I love to do even today, the metronomic therapy. And because it has a lot of advantages, compared to what we are using now and what our patients can afford, what, basically, again, looking at the pathophysiology of the disease. So there's a lot of science, like Dr. Pankaj Shah told. Actually, it's not like just combining 2 drugs or 3 drugs. Lot of reading is required to do, to do these combinations, to use this. But this is what we are doing now. And there are multiple examples. This is head and neck cancer, which, basically extensive disease, could not be operated or radiated. So, patient doing well for, and there are so many of such patients. Sorry, actually, the slides are running. But this is, we have at Tata, we have proton therapy also. So we believe in the cutting edge therapy. We have the CAR T cell we have developed. So all of these are expensive therapies. They are also important, but we know the reality check is always there. So along with the Audis and BMWs, we have patients walking on the roads. We have bullock carts being used. So we have to keep in mind that also and develop something for those people also. And that is why we have been doing that. Head and neck cancer being the commonest cancer in Tata and in Derwan. Actually, we started with head and neck cancer with double therapy, doublet. Then came the triplet that we have used, and then basically in other things also. So there we have repurposed celecoxib. In sarcomas we are using tamoxifen, actually. I can take a whole talk why tamoxifen, but tamoxifen was used, and we have published this also. We have used another drug, basically propranolol, as anti-angiogenic in sarcomas. And Medscape actually told this is first such thing that has come out in a long time, and they have actually endorsed this thing again recently. Just last month, you must have seen this. Another, Akhil Kapoor published a triple metronomic therapy, and there's a full talk on this, why it is important. So people are noticing it now. And very importantly, alone it may be this thing, but if you use along with the basically, the immunotherapies, it will work better. And again, we did that by using low dose immunotherapy again, which was very, very important. So we had very good people, Kumar Prabhash, Vijay Patil, Akhil Kapoor now. So we have good people who have taken it over. And if you see this low dose, and which has become not only nationally, internationally, people are now using low dose immunotherapy along with metronomic therapies. And it is there so many new trials coming out. So maybe we'll generate some more data. Dr. Hemant Malhotra was asking about evidence, that we have to create the evidence, but it is on the way. And so I'll end on some philosophical note. So this is, everyone, how many have seen Chennai Express? Most of you may have. But there's a dialogue in that which comes again and again, where Shah Rukh Khan says, don't underestimate the power of common man. So I always tell my students as well as my colleagues that metronomic is 10 rupees, 100, 200 rupees treatment, but don't underestimate its power, because sometimes it really works very well. And again, this is again Mahatma Gandhi's this thing, that you must be the change you wish to see in the world. So don't wait for anyone to help you out. We needed help. We couldn't tell the government to help, or Department of Atomic Energy to help, or TMC to help our patient. We started our own foundations, worked for it, but because of that, actually, we could create what we wanted to. So I think that's very important for young people here. That don't wait for anyone. If you want to change something, at least start yourself. And so, and this one, so another, many young people are here. So we wait, we think that we'll retire and then we'll start doing voluntary work and social service. I think don't wait for that. Actually, you have to start when you're young only, because that's the best time that you can give. So this is Muhammad Ali's this in service to others is the rent you pay for a room on earth. So do something which is not routinely that you have to do. Doing anything that is important that you have to do, as it's important also, but doing something more than what you're supposed to do, I think carries more significance. So please take up something that you can be of a one day a month, but do it consistently. Don't say that it's voluntary. Okay, I have a meeting, so I cannot go this weekend. I'll not come. Or next, this thing, there's a birthday party at home. You can't do that. It's very important to make sure that you do consistently do the work that you take to do. And this is my philosophy of life, that's one thing, that if you can help somebody, please help, but if you can't help somebody, at least don't harm somebody. And that's my philosophy. It has been at the hospital also, whether it's my students, my colleagues, try to help as much as possible. And we are in a position, I'm really thankful to Tata Hospital, because basically I've been at a place where without even telling, I can help so many people. And he's told it's doctor of poor people, because I treat 99.9% of my patients are poor patients, and we get opportunity to help. And that's because of the place that we are in. So I'm really thankful to Tata Hospital for all over the years, so much it has given me. And given me to earn punya without really working for it. And this is last, everything pay, everything is important. But this is one thing that we can die for. So much love that we get from our children, that all other things are immaterial. And I've got a lot of love from so many children over the years, that I think I've been paid 100 and 1,000 times, million times more than what I could earn through my pay. So thank you very much for listening, and thank you for the opportunity.
I would like to request Dr. Purna Kurkure, Dr. Hemant Malhotra, and Dr. Pankaj Shah to kindly come forward and honor Dr. Shripad Banawali, sir.
Very good, very good. Yeah. Thank you, sir. Thank you.
Quick transmission.
सोशल मीडिया पे जल्दी चला हाँ ऐसा करते हैं प्रकाश and भावेश में काम प्लीज no, it's like he said, even another light I would like to have. Nice. You should come about. Enter. Yeah, yes, sir. Yes, आप लोग कर लो ना ना सर yes sir thank you sir thank you there is a lunch break and after 30 minutes we will all come together yes
We will
Let
continue.
me tell you one more suggestion. As Dr. Banavi is doing this for many years on metronomic, all those oncologists working across the country, if we make some small registry of metronomic treatment experience, probably it will be a good gift to Dr. Banavi. And it will be good to have such data across the country. Actually, my desire is to have whatever the experience we have for the minimum 10 lakh treatment of immunotherapy. In the same way, we have experience of metronomic. Probably it will give us real insight. Thank you for being here. This is a place I'm getting myself involved after this retirement. And when you are going to have your lunch, that building is dedicated for bedridden senior citizens staying with their children in a small house. If they have a fracture, my parivar, that is our family, Sarvijar Parivar, will take care of them till they become ambulatory. So it is a in-house ambulatory rehab center for senior citizens. While you are taking soup or something, you can use the lift, go up. It is open to all of you. There are 2 days. Just visit it. Just visit it. And Banavi, you are doing good work. She is doing good work. He is doing good work. She is doing good work. And Hemant is already doing. So in our medical oncology community, there is some good gene in all of us to give back to the society. Thank you.
We will continue our session after lunch break. I will request to you all to come within 30 minutes.
आप लंच मांगे साहब ने ले जाए ऑनलाइन करना है तो वहाँ भी कर सकते भाई आपको ऑनलाइन भी रबर रम्मा कराई दो मेरे घर we go to my conference जापान पहला साहब ने लंच ले वाई दे बस उतना बहुत ताक ले सब करें मानो में हमारे यार को मैं जा चल सरस RS special like my two and Rajesh can go. Rajesh तैयार Rajesh गयो गयो बाजू सारे बोल के एक बैग तो थोड़ी साथी आ गए and one of the non-veg as a special arrangement बनाया है कोई nobody is okay sir I know that
Anjali, ladies always travel with a party bag. So there is never a problem. Yeah.
एजुकेशन वालों को मैंने दे दिया तो मैं आपको ईमेल कर हाँ बस लो मैं भी नारायण को बोल दूँगा बोल मैं तो काम करे वो मेल पे होती है तो नहीं
पोर्टल नहीं होगा मुझे एक काम करोगे मुझे तुमने टास्क किया इसमें मैंने पोर्टल पे भेज देता क्योंकि आप बता रहा हूँ तुम्हारा स्लाइड हाँ वो सारी यही से अपनी ओरेशन करके बैठे हैं लंच करेंगे मेरी हाई स्पीड में साइलेंस से बात हुई लाइट देंगे नहीं वो खुद ही शेयर करते हैं सर खुद ही शेयर करके मेरी साइलेंस से बात हो हाँ वो अभी
For them, at least someone's come twice. So it is also like, yes, yes, yes.
અરે કોઈનો ફોન કરવાનો નીચે તો કઈ છે નહીં ખાલી નું બટન ખોલી દીધું તો છે નહીં વાગે હા જોઈ લો જોઈ લો
Next time, right, back in.
I think it's nice that Oncoplastic is doing it. Definitely, our registration, but I they after registration as yeah, and you got allergy program. I like that. Yes, yes. Yes.
On the way છે. નામ બોલજો on the way છે.
Good afternoon, everyone. So we will again start with our session. And for that, I would like to invite our chairperson, Dr. Shona Nag ma'am. She is the director in the Department of Medical Oncology at Sayadri Group of Hospitals, Pune.
Good afternoon, everyone. It gives me great pleasure to invite Dr. Bhavesh Parekh, who is going to moderate our next panel. It's a case-based panel on HER2-positive breast cancer. And may I request him to call his panelists, please?
Yeah. I will call my panelists, Dr. Anaga Jope madam, Dr. Sefali Desai madam, Dr. Abhishek Jain, Dr. Akash Patel. I think Ekta Wala is on the way. So we had a panel of surgeon. Sona Nag madam is also a oncologist. Yes, Ekta Wala madam is already here. Please, madam. So we had a yes. So we had on the panel 3 breast cancer surgeons and 2 medical oncologists. अभिषेक थोड़ा सा चेयर ऐसा घुमा देना तो एकता के लिए जगह करनी पड़ेगी तेरे को। एकता वैसी है छोटी लेकिन थोड़ी जगह रखती है। सर्जन जनरली सैंडविच होते नहीं है और यहाँ पे हो गए हैं। मेडिकल ऑन्कोलॉजिस्ट जनरली आर वेरी सॉफ्ट रादर देन सर्जन। आकाश की मुंडी मुड़ रही है। So our topic is optimizing outcomes in HER2 positive early breast cancer. We are going to discuss early breast cancer. That's why the role of surgeon, and we are discussing that's in HER2 positive. So finally, I'm just case-based discussion. As Sona madam already told, Mrs. X, 40-year-old female, 2 children who are healthy and doing well with no remarkable history, hypertension and diabetes of this 40-year-old female, and having a strong family history of the breast cancer. So, Sefali madam, with just history, like 40 years and family history of breast cancer. Now, means whenever such type of patients when come to you or your physical examination shows 6 centimeter mass with skin involvement and axillary node, what's your first impression or what's your first take to how to investigate or how to manage?
Physical examination, bilateral mammography and sonography.
Correct.
And then for biopsy.
Correct.
Which would include the Pharmacology and the receptors.
Correct.
And Ki-67.
Correct. Correct. So bilateral phonomammography and this through-cut biopsy and ERPR HER2 new Ki-67. Abhishek, are you interested in PET CT scan? 6 centimeter tumor with axillary node positive.
It's a HER2 positive disease. I mean, even if it is ERPR is not there with us, in a T4B tumor, I would like to get a PET scan.
So Sefali madam might be interested in bilateral phonomammography plus X-ray chest and ultrasound abdomen. Pelvis.
Things done.
No, PET CT would be my preference rather than
These are the initial investigations. Once the biopsy is there, we know the ERPR reports, and then based on that, we will take further calls. So in such a big tumor, PET scan is always.
So if there is a 6 centimeter clinical findings and still the biopsy report is awaited, are you in that time during that time interested in PET CT scan?
We would wait for it.
Wait for the report.
Most of the time, it comes in 1 or 2 days. Not a big problem.
Ekta, your comment? A 40-year female with 6 centimeter mass with family history positive, and we had just done a clinical examination and biopsy, and the report is awaited.
For staging. So staging for malignancy. So once there is evidence of malignancy, then we can do PET scan for staging. So we'll definitely wait for biopsy and we'll plan PET scan.
Wait for biopsy and then go for PET CT scan. Sona madam?
Funny part is a lot of our patients come with the PET scan in their hands already.
That's what. Yeah, most of the times it's come even before biopsy also, at least with biopsy, or might be sometimes FNSE also.
Correct.
And then with PET scan from the whatever the peripheral or surgeon or whatever. So then what's again, because some biopsy report like in this particular patient is a ERPR negative and HER2 positive. If it is ERPR positive and HER2 negative.
Right.
But it was 6 centimeter tumor and not positive and 40 year with family history positive. My interest is whether PET CT is must in this type of patient.
Or you do is young. So along with the genetic testing, I think I would definitely advise a PET CT.
So one point is genetic testing. Anaga madam.
So any young patient now under the age of 65 getting breast cancer, you're especially 40 years old with family history, definitely germline mutation analysis for not just BRCA but all the possible panel. along with MLPA especially for me.
So, Sefali madam, this particular patient having a now BRCA positive, and she is interested from Google that I want to do bilateral mastectomy. Are you happy as a surgeon?
Yeah, definitely. I will counsel her, ask what she actually wants. And bilateral mastectomy would be not to start with. We need
That's
to
what
give,
to start with.
No, not to start with. We have to give a neoadjuvant.
So even BRCA positive, you are still interested in neoadjuvant chemotherapy. Okay. So this is the PET CT. Abhishek, PET CT scan. Your finding or your interpretation?
So it's a clear involvement of the skin, overlying skin. It's a T4B lesion and T4B N plus. So definitely, sir, HER2 positive disease T4B N plus. I would like to plan neoadjuvant treatment.
Okay. So finally, Akash, from your point of view, how do you define the patient at high risk of recurrence? What are the factors that you keep in mind?
First thing is the tumor size, then the skin involvement.
So 6 centimeter skin involvement.
Then lymph node involvement.
Lymph node involvement.
And the younger the age. And
You have cutoff age limit is 35 or 40?
40.
40? So this is patient is exactly at 40 years.
Yes,
So you consider high risk?
He is young, yes. And receptor status, that is ERPR and HER2.
Okay. Yes, Abhishek?
I would like to keep a cutoff of 50 years, I think, for
Young patient?
patient to be qualified as a
Qualified for a high risk?
young breast cancer. But 40.
सोना ने मैडम बाजू में ही बैठी है वो बोलते हैं मैं तो अभी भी यंग
So any pre-perimenopausal, I would still consider young because that's biologically young.
So 40 years with history of hysterectomy before 5 years.
Hysterectomy is not done and she's still in her menopausal, she's pre.
We had Dr. Bhavisi in our audience. Sir, such type of patients came, and if from the surgeon point of view, the bilateral oophorectomy is must because we feel that premenopausal patient should become a postmenopausal. Are you interested in doing bilateral oophorectomy in a breast cancer patients? Mike, please.
If her childbearing is over, the one function of ovary is already finished. But the second thing is, of course, now, as very rightly pointed out by all the panelists, the definition of young and old is completely changing. I also don't feel myself old. So, so obviously, the patients don't feel themselves old. So unless necessary, conservation of ovary is recommended. But life is most important. And in that case, at 40, it may be, depending on the condition of the patient, not very crucial to save them.
So again, if we are interested finally in bilateral oophorectomy, but same person does not have any child, and she also want before removing the ovary, want some ovum preserving. Is there any method?
We can certainly do that, but the biggest issue is that even if the patient tries naturally with IVF or whatever method, after the age of 40, per treatment success rate is almost 10 to 15% per cycle. So if you freeze their eggs, egg freezing will be more difficult because it requires time, stimulation, collection of eggs, number of eggs will be less, quality of eggs will be less, and resulting pregnancy also would be less. So you need to collect, ideally considered to be 35 eggs, which is not possible in a lady of 40 years, considering the lower success rate. So the another option would be to preserve ovarian tissue. And in that case, again, there is a risk of, by chance, there is metastasis, then that is one risk. And another risk is, or the problem is that ovarian tissue cryopreservation is still not very much standardized. It is practiced, live bones, child are born, but it is still not very commonly practiced. And that's where I would request all the oncologists sitting here that try to make it available to more and more patients because it is done successfully. Unfortunately, till the time acceptance, guidance, and from the consultants and from the patient is not there, that method is not going to be as successful as a standardized method.
Thank you. Thank you, sir.
Bhavesh, one question.
Yes, sir.
Published data from the Scandinavian countries says that even in metastatic disease, ovarian cryopreservation is safe because ovarian involvement they did not find in their nearly 200 patients Hardly any ovarian mass.
even in metastatic disease.
But T4B breast, what would you?
So, but this all comes. Yeah, please.
So definitely, we would restrain ourselves in advising a 40-year-old person with a T4B and aggressive disease about, further. But if there is no other option, this is the question. Yeah, if there is no children, it is a nullipara, etc. Then my question to Dr. Bhavishi sir is that wouldn't embryo preservation be a better option than have oocyte preservation if she is in a relationship?
For any married lady, embryo preservation is always there. There is absolutely no doubt about it. So because embryo is at an advanced stage of development, it is much more stable with breathing, and that's where there is no question at all that whether you should freeze embryo or eggs. But you know that in modern times, there is a strong demand of autonomy by the women also. So many times it happens that when the lady is nulliparous at 40, she might have married just at 39, 38 or something. They are still not sure whether their marriage is stable or not. They are not sure that because of the cancer, whether their marriage will be stable or not. If she doesn't have child, whether the marriage will survive or not. And all these situations, women want to freeze their eggs rather than embryos. Because embryos is a joint property and women cannot use it after a divorce or something like that. Whereas eggs is her own property and can use it with another partner also or becoming a single mother also. So that is where there is a difference. So it depends definitely on the case basis.
Thank you. Thank you. I think we are deviating some very important point,
So
but
this would come, this discussion would come in question only if the patient is ERPR positive.
why even
Most
like
of the time,
yeah HER2 એકતાની પાસે
context
તો
of
બધા
breast
HER2
cancer,
પોઝિટિવ જ આવે છે બધા સર્વાઈવ જ થાય છે so again only HER2 positive is not the only one factor. Might be 6 centimeter tumor or not positive. There are, so again my question is borderline risk. Is a disease patient is particular very high risk, but if it is a borderline risk, then
There is one more thing. You can use the ovary, get the eggs, get the pregnancy, remove the ovary. So you don't need to keep the
if
ovary
it's a
like
BRCA positive, then yes, definitely.
also.
If it's
Perfect.
BRCA positive, then definitely.
Perfect. So finally, it is a MDT approach or finally for neoadjuvant chemotherapy. I think my panelists all are agree for this particular patients, 6 centimeter tumor, 40 years, not positive, skin involvement, ERPR negative, HER2 positive, NSCT. Everyone? Ekta, what is your choice of NSCT?
TCHB definitely. Usually I think.
TCHP. Sona madam? Only TCH? Raipur mein TCHPB everyone gets.
So I'm in Pune.
Yes.
So my patients get either TCHP or they get 4AC or THP.
Correct. So still you think anthracycline direct, Ekta madam's answer is TCHP, but you are interested, might be I will give 4AC followed by 4 TCHP.
Very young, positive or positive.
Akash, anthracycline?
Sir, first of all, I would like to know about the BRCA status because we have discussed.
It's
already
negative.
about-
Negative.
Okay, BRCA negative, then both options are equivalent for me. AC followed by THP and TCHP also. But if it is BRCA positive, then I will be little bit inclined towards the TCH only regimen. Because what I think that in BRCA positivity, where the PARP inhibitors work, the platinum will get more response. With platinum-based chemotherapy will get more response. So even TCH will be better in those kind of patients.
But
in
at least dual anti-HER.
There is no data, sir, but I'm thinking about that.
Okay. Sona madam.
So it's percentage, first of all, of those positives are BRCA positives. Our data shows about 2.5%.
2.5%.
At the JEPAR 6-2 trial, which looked at the addition of platinum in BRCA positives, it looked at TNBC, but irrespective of the platinum, these patients had a very high PCR rate because BRCAs are in general chemosensitive.
Perfect.
You throw an alkylating agent, you throw anything, they will respond.
And then, sir, I think one important consideration here is if it's a locally advanced disease T4B N plus, then getting a dual HER2 blockade is one thing which I think should be considered.
So based on current guidelines, these
Because
patients
if it's
should.
a T1N0 HER2 positive, would you like to give a TCHP in such patients?
No.
I think no. Yeah. So if it's locally
Ekta
advanced, most
TCHP,
likely
but T1N0.
dual HER2
T1N0 and
blockade
HER2 positive.
Yeah.
I don't think it was seen with node positive.
So I think then in this patient, dual HER2 blockade, I think would
Perfect.
make more sense.
So based on current guidelines, these patients should be treated with neoadjuvant. Again, NCCN guidelines version 6, 2024, AGO guidelines 24, ESMO guidelines for early breast cancer, and St. Gallen's guidelines. Again, now the decision is there are two options. Again, begin neoadjuvant therapy, proceed straight to surgery, and follow with adjuvant therapy. I think everyone is agree. Even it was BRCA positive, negative, but at least we are going to give NSCT rather than straight. So not any surgeon is interested to do surgery in this. Any chance that patient I want to remove because it's a big tumor and I'm scared of giving chemotherapy. Are you still interested in surgery? Perfect. Perfect. So decision point 2, which neoadjuvant therapy? I think Ekta and even Sona madam told that TCHP in this particular patients might be in other setting, might be we can use TCH, but at least in this Phesgo plus chemotherapy, Herceptin plus chemotherapy, I think Ekta is interested in given dual rather than single. So finally, dual, that Neosphere study, and that study or that design is again, there are pertuzumab, trastuzumab, and chemotherapy, pertuzumab only with docetaxel, and finally Trifena also, where one panel is also mentioned about PCR rate, and again someone also told, or especially Sona madam told, that AC followed by dual anti-HER2 or all the 4 combination, but finally this combination is a very high PCR rates.
That's
Yes.
trial.
Yes.
Yeah, with the 6-cycle TCHP, the PCR rates were above 60%, but in hormone negative subset,
Correct.
the PCR rate was around 80%. So I
So
think
this particular patient is a hormone negative, ERPR negative.
based on this result.
Perfect. Perfect. So avoiding anthracycline is very important. So now final again, pertuzumab plus trastuzumab, that is dual anti-HER2, is recommended by international guidelines for neoadjuvant treatment for patients with high risk HER2 positive. So we are discussing now high risk HER2 positive and early breast cancer. The NCCN guidelines complete up to 1 year of HER2 targeted therapy with trastuzumab category 1 plus or minus pertuzumab. AGO guidelines, trastuzumab, adding pertuzumab in node positive and tumor more than 2 cm at presentation are recommended. ESMO guidelines, dual blockade can be considered in high risk patient, node positive, ER negative. Here again, ER negative for 1 year and starting before or after surgery. And finally, it was a St. Gallen's guideline, stage 2 or 3, HER2 positive. The panel is strongly endorsed the use of neoadjuvant chemotherapy combined with dual blockade, which yields higher rate of PCR compared to trastuzumab alone and lower risk of recurrence. So finally, we all are agrees, and these are the various trials, Neosphere trials, and again neoadjuvant followed by adjuvant. Again, various outcomes that finally told that definitely dual is very much or important. Finally, this is again real world single center experience we had in our panelist or chairperson, Dr. Sona Nag. This both slide is very important. Madam, can you just elaborate these two very important real world data of single center experience of HER2 positive breast cancer undergoing subcutaneous injection of Phesgo along with chemotherapy?
So this was a experience last year, and since then, I think this data reported 27 patients, but last year we analyzed it again, and we come up to 41 patients at that time.
Correct.
Almost over 50% were neoadjuvant, 2% were adjuvant, and the rest were in the metastatic setting. All patients received FESCO, and our pathological complete response rate was around 83%. But there could be a bias here because 60% of these patients were ER/PR negative and not ER/PR positive. And the metastatic, all 100% patients responded. They all had a partial response, and it was very well tolerated. A second part of the study was patient satisfaction. So we actually filled in questionnaires where we asked them, because one or two of them had received the IV formulation earlier.
Correct.
So most of them reported, almost 95% reported that they were much more comfortable with the subcutaneous experience. And the time was very short. It was easy to take, and they could do it as a, like a very, very minimal time wastage and convenient experience.
Perfect. Thank you, madam. So again, question to Akash. You had mentioned earlier about the plating. So again here, can we give docetaxel and plating with FESCO? So we are giving dual anti-HER2, and most of the also telling that white meat, sometimes in some subset we can avoid anthracyclines, but generally we are giving a single chemotherapy. Here the talk about docetaxel plus carboplatin with dual anti-HER2.
Yes, sir. So that is good regimen.
So why use not in every case? Sometimes we are using 4AC, 4/4 TCHP.
Sir, in majority, 95% of patients in my practice, I usually start with TCHP regimen or TCH regimen, not the anthracycline. If the patient is not affording, then initially or if they want time to get convinced about this costlier drugs, then I'll start with AC regimen.
So finally, this patient received neoadjuvant therapy, and that's 6 cycles of TCHP, that's subcutaneous FESCO, and excellent clinical response. Abhishek, this now PET CT, your tech call on surgery.
Yeah, so I think, sir, we plan a surgery, and most likely there's going to be a mastectomy or by radical mastectomy.
40 years old.
Since the skin was involved, sir.
Okay.
So
Anaga madam, any chance of
so it's a
reconstruction?
for breast conservation surgery. One thing is very clear that we never do a BCS in any case of T14.
आप BCS नहीं करोगे, लेकिन आप पेशेंट को like reconstruction,
So definitely,
Oncoplastic.
This patient has a single disease, though it was a large 6 centimeter disease. In my personal practice, I would never do breast conservative surgery. But breast conservation is not contraindicated if the patient and the surgeon are willing to do what now surgeons call advanced breast conservative surgery, where flaps are inserted. In my own practice, I don't do it, I don't advocate it. But in this case, I would definitely want to give her a mastectomy with a autologous flap, because we will have to sacrifice her skin. So this is the ideal case for if she wants immediate reconstruction, mastectomy with diet flap. And if delayed reconstruction, of course, we can opt for any.
Okay. So in Sona Nag madam's case series, 80% having a PET CR. Akash, suppose આ પેશન્ટ ને આપણે આપીએ તો કેટલા ચાન્સીસ છે કે એને PET CR આવે?
The ER/PR negative and only HER2 positive with 3 plus positive and with dual anti-HER2. Again, 80% chances with PET CR, because even I have experience with TCS regimen that I have achieved 60 to 70% PET CR. So again, with dual anti-HER2, more than 80% will achieve PET CR.
Okay. Hemant sir, any comment? 80% PET CR. That's what. Yeah, Sona Nag madam also commented on that when she also presented 83% in your case series. Now,
going to get a higher CR.
okay. So any chance, Sefali madam, you are working like in Samved hospital where radiology is prominent about the breast MRI, or whether after chemotherapy, before doing surgery, any role of breast MRI?
Not in this case, but yeah.
So which particular case you are interested as a surgeon to do? Because what I think that all are agreed about the mastectomy rather than any breast conservative surgery.
Breast conservation, then MRI would be more important in such
Correct.
cases.
Correct.
Or just suspecting a bilateral disease.
Okay. So here the point is that there is a higher chance to stop chemo also after 3 cycles in HR positive. So if it is ERPR positive, and if there is a very good response after 3 cycles rather than 6 cycles, can we stop and can we go for surgery if we do breast MRI? Perfect. Perfect. So finally, this patient underwent left modified radical mastectomy in December 24. Post-operative report is YP T2N0, ERPR negative. So यहाँ पे PET CR नहीं आया है, T2N0 है. HER2 positive, again lymph node negative. So final outcome was YP-T2N0 ECTA. Out of these 3 options, continue Phesgo, continue Herceptin, Kadcyla for 14 cycles. Kadcyla. Sona madam? Because of residual tumor, because of T2N0?
Because of risk adapt, you need to do risk adaptive therapy now, and we know that those that don't achieve PAC-CR, when you change the regimen to TDM1, there is now not only an IDFS benefit, there is an overall survival benefit of 4.8%. So I think it's important to consider.
So finally, adjuvant treatment of patient is on Kadcyla due to the residual disease, tolerating the treatment well. So finally, this is very important to optimize the adjuvant setting also. As madam told that it is not only IDFS, it is also very important about the overall or survival also. And this is the final recommendation by the international guidelines, various guidelines. If there is a residual invasive, TDM1 alone for 14 cycles, AGO guidelines, ESMO guidelines, as well as St. Gallen's guidelines. Last questions, additional questions. Anyone is interested to go for Perjeta plus trastuzumab? Residual, ECTA? No. Kadcyla for 14 cycles. Perfect. So finally, role of radiation therapy, madam. 6 centimeter tumor originally. Perfect. Perfect. If it is ERPR positive, hormone receptor, hormones, along with radiation, along with Kadcyla, after Kadcyla.
After radiation,
Along with Kadcyla. Akash, if it is BRCA positive and HR positive.
So if it is BRCA positive, then only we have data with to continue with as the patient is HR positive. So with the EI or tamoxifen with anti-HER2, that is Cellular, to continue with that regimen. And in progression, we can think about the changing of the regimen.
Olaparib or
yes.
Or this is the final St. Antonio Breast Cancer Symposium where phase 3 study of adjuvant again versus trastuzumab for residual for early breast cancer after neoadjuvant chemotherapy in HER2 targeted, that is Catherine, final IDFS and updated OS analysis. And again, very important, there is a very demarcation or difference between these 2 graphs. And finally, subgroup also, the Catherine second OS interim analysis, the median follow-up is 8.4 years. Very important. And finally, this is again in various subgroups. So finally, the last question is, would your adjuvant recommendation differ if this patient HER2 status changed from HER2 positive to HER2 negative after neoadjuvant? After neoadjuvant. मतलब जब आपने एमआरएम किया, मास्टेक्टोमी किया, YP-T2N0 आया, वहां पे HER2 नेगेटिव हो गया. No.
I think we would finish all the
Again, ERPR and HER2. It was done by chance by other clinicians. Okay, thank you. Thank you very much. Thank you, my all esteemed panelists. Thank you very much.
Thank you, Dr. Bhavesh Parekh, for moderating this session very well. And thank you, Chairperson Dr. Shona ma'am, and all the panelists. Now moving further to another session, Young Women's Cancer. I would like to invite Chairperson Dr. Ekta Wala, Dr. Himanshu Bhaveshi, and Dr. Shefali Desai.
મૈત્રી મદન વાળું કરવાનું છે ને પછી મારા પછી એ છે પછી યંગ વુમન્સ
Maitri, sir, please. Yes, yes. After, sir, please. One session has been pre-lunch has been remaining, so we will complete that session and then we will do your session.
પછી આપી દો પછી આપો મૈત્રી મદન વાળું સર પ્લીઝ.
So we are inviting Dr. Madan Maitri for neuropsychiatric sequelae in CNS tumor. We had postponed this session because of the time constraint. So after these sessions, we will go for young woman session. Sorry for interruption.
A very good afternoon to everyone. My sincere thanks to organizers and Prakash sir for inviting me here today. So I'm going to talk about neuropsychiatric sequelae in CNS tumor survivors and focusing on the AYA group. AYA group is something that we should always remind ourselves that this age group spans over a most important biological and the social milestones. And suppose the patient presents to your OPD with symptoms of the brain tumor, and that's where the all paradigm changes, and this is the starting point. CNS tumors, these are the second most common cancer tumors in AYA group. And as we know, we face diverse tumor histologies, and there is a relative lack of awareness in our country. But the evolution in treatment techniques, including refinement in surgery, radiotherapy, delivery techniques, and the chemotherapy, has led to increasing survival. And now we are realizing the survivor issues, and there is a focus on the rehabilitation of these patients. So who are these long-term survivors? On one hand, we have pediatric survivors over the age of 14 years, and they carry a lifelong risk of neurological and endocrine impairments. On the other hand, in addition to these problems, this subgroup faces educational, vocational, and social challenges as well. So this period from childhood to adulthood transition entails a great physical, psychological, emotional, social, and the sexual change. And it has been observed that tumor and the treatment-related induced neurocognitive dysfunction could be quite high, as in the range of 40 to almost 100%. So what are the key neuropsychiatric sequelae that we see? It is a vicious cycle, I would say, including the anxiety, depression, cognitive impairment, post-traumatic stress disorders, emotional liability, identity-related issues, and psychosocial and the vocational impact. There could be various contributory factors that we can broadly divide into tumor-related itself, patient-related, and the treatment-related. For example, location of the tumor, whether it is in eloquent area or non-eloquent area, presence or absence of the hydrocephalus, and the treatment-related factors, the bad players being the radiation therapy as well as the chemotherapy, which may have a synergistic effect. Psychological distress, suppose we have finished the treatment and the patients are coming into our OPD for follow-up, and every one of us has seen some fear, some hope, and we can read that out very loudly. And there is always a post-treatment anxiety and thoughts about persistence of the disease or the relapse of the disease. And often it becomes very difficult to break the news, and the question comes, why me? And we find it very difficult to answer those questions, and that leads to the depression about upcoming prognosis, low self-esteem, and the social isolation. There are a few rare but serious complications, that is late onset psychosis, which may occur decades of the treatment, and we may see just a tip of iceberg of depression, ADHD, and bad habits of alcohol dependence, self-harm. Neurocognitive deficits, the benchmark study done by childhood cancer survivor group, they assured us that these survivors have a lowest rates of education in brain tumor patients compared to their siblings. And when it comes to neurocognitive dysfunction, it is a complex interplay between memory, attention, processing speed, learning speed, and executive dysfunction. Something about late effects of the cancer-directed treatment, that part often goes unnoticed in our busy routine clinic. To broadly divide them is the neurocognitive dysfunction, where we see that the IQ drop of 12 to 14 points, and risk factors being the younger age, larger areas of radiation such as total body irradiation or craniospinal irradiation. Endocrine dysfunction, it's more common with midline tumors, pituitary adenoma, craniopharyngioma, and the most important axis is the growth hormone, which appears first. We also see cerebrovascular accidents and secondary malignancies, including gliomas, sarcomas, and meningiomas. There is also association of the hearing impairment, and if the tumor relapses and we consider the second course of the radiation, we have to keep in mind the risk of radiation necrosis and the chronic epilepsy. That will ultimately worsen the quality of survival. So some identity and the body image and the emotional health is that there are two aspects that we can see, whether in a negative way or in a positive way. When we see them as a victim identity, it is linked to the depression, low quality of life, leading to the physical impairment, limited peer interaction, and dissatisfaction with the appearance of the bodily images. On the other hand, if we are taking things positively, a survivor identity with a empowering and encouraging attitude, family support, and good support from the educational and the occasional rehab group, and ultimately the survivor support group. And that will, physical morbidities, it is directly linked to the neuroendocrine dysfunction, leading to the decline of the hypothalamo-pituitary hormonal production. And we can obviously that we can see that the patients are having stunted growth, lower intelligence, and the sexual immaturity. Hearing loss is often seen in more 14% or 15% of the patients in long-term survivors post-radiation. Also, concurrent use of the platinum-based chemotherapy may have an additional effect. Many times there is increased risk of chronic health problems and higher risk of cerebrovascular accidents. So a word about functional and the social outcomes. We do notice that there is lack of employment, poor social attendance, academic setbacks, health insurance related problems, marriage and relationships problems, and often the fertility complicated by fertility concerns. And if the patients are having strong history of family history of cancer in the family, the things become more difficult to assess. So the long-term psychosocial support is crucial with the help of dedicated survivor groups, with the help of NGOs and the support groups. Intervention and management, there is a modest benefit because what we think most oftenly we are not able to implement in our survivorship program. But rehabilitation and the cognitive training forms the cornerstone in the management. There is a very probably a modest benefit with the use of pharmacological interventions that I don't see. But school-based accommodations, behavioral strategies based on the patient's profile may help to improve their quality of life. So as we know, the cure comes at the cost. So if we know that patient is going to have very morbid problems in later ages of their life, then we must do something to prevent during the treatment itself. So there are continuous refinement in the surgery with better navigation, image guidance, and aggressive post-rehabilitation, occupational therapy, and the physiotherapy exercises. With the radiation therapy, high precision radiotherapy techniques can effectively spare the critical structures, cochlea, optic apparatus, and the brainstem. And in the particularly talking about AYA group, I believe that proton therapy, particle therapy holds a strong promise. So positive family environment, this is something I learned during my training period. And when you are meeting these patients and families, one thing I learned is that that you're not even only treating the patient, but finally you are ending up with treating all family members as well. Academic rehabilitation, it is neurocognitive impairment. It's just not because of lack of motivation to learn, but if we can arrange a supportive program that is returning to the school with classroom learning, preferential seating arrangement, written handouts, and the low homework, that can really help patients. And finally, the friendlier exam formats would be really impactful. And this is the cognitive risk model that we can adopt in our clinical practice based on the various biological factors, patient characteristic, treatment-related factors, and find out the specific domains that are affected with the cancer-directed treatment, and we can chop out the plan for each and every patient. Ultimately, support groups, it is most important thing, I believe, from diagnosis until the end of life, and integrative approach with the medical staff, psychosocial support, academic help, family and community education, and help from the government institutes would really change the picture. So to summarize critical clinical care, we have to tailor the survivorship program for each and every patient, and with the aid of psychosocial support, and there should be a smooth transition from AYA group towards adulthood, and understanding their unique demands at this age. So whenever we face a problem, every one of us feels that, okay, I am alone, but when you have a support, this is how it looks like. So I guess support is priceless. So and so as the service. And Manavali sir, I'm thankful to you for your training during my training in Tata Memorial Hospital, sir. Thank you, sir.
For this session, I would like to give moment to Dr. Now moving forward to another session, young women's cancer. I would like to invite chairperson Dr. Rita Vaya, Dr. Immunotherapy, Dr. Shefali Desai, and speaker Dr. Shunana. Would like to give moment to the session. I would like to give moment to Dr. Shunana.
Let me finish my talk first.
Thank you, moment to Dr. Rita Vaya, Dr. Immunotherapy, Dr. Shefali Desai. Now moving forward to the session, young women's cancer. Can I start?
Yeah, good afternoon, everyone, and thanks, Chitty, as I call him, for inviting me here today. We were together at Tata for quite a bit of period, and we went through the ups and downs of residency together. And being the oldest of the lot, we would just stand and talk around, and we were obviously deputed to the hospital, but we had a very enjoyable time. And I'm really proud of the way he has brought up this movement of TYAcon and the foundation. And congratulations for that. And I'm really happy to be here amongst friends and colleagues today. So I kind of chose my own topic and decided that I wasn't going to exercise my brain too much, but nevertheless made a little bit of an effort. And I'll be telling you a little bit about addressing the needs of young women with breast cancer. So breast cancer in young women is very inconsistently defined, and we saw that in the posters as well. The ESMO definition is women below 40 at the time of diagnosis, and these are distinguished from very young women who are below 35. It is often poorly understood. These patients are not well represented in trials. They face unique challenges of fertility, psychosocial, and survivorship problems. And it's truly a complex clinical situation which requires a multidisciplinary approach, and not only oncologists, but doctors from other specialties such as gynecologists become very important. So when we address the BCY needs, I will be covering the magnitude of the problem, genetic testing and management of BRCA patients, handling long-term toxicities and healthy living for survivors, fertility preservation and pregnancy after breast cancer, and a bit about breast cancer during pregnancy. So we look at the statistics, what does it really show? So we have worldwide data from adolescents and young adults from this ESMO open paper, which was a systematic analysis. And what we realized that in 2019, more than 1.3 million cases were diagnosed with over 0.4 million deaths. And the incidence since 1990 has reflected a little increase, but mortality has shown a great decline owing to our effective treatments. Women outnumbered men disproportionately. The highest burden is now in South Asia and East Asia, and even in countries like Canada, Australia, and New Zealand. Breast cancer makes up the largest number of new cases, 12.6%, and it also accounts for the second largest number of deaths after leukemia among AYAs at 10.8%, and that is very nicely seen in this figure. In the US, 5 to 7% of breast cancers are below 40. In LMICs, most available data is from retrospective studies, so I did a little digging. There's a study from GCRI of 8,440 patients, and it showed that 305 were less than 30. This is less than 5%, but less than 30. Then a Tata study looked at metastatic breast cancer in young women. Of 8,634 new patients registered over a 2-year period, 1,445 were less than 40. So that's a big number. That's 16.7%. And of these, 18% were metastatic. 2 studies from South India reported incidences of 15.4 and 4%. Our data showed the following. At Sahyadri Hadapsar, from November 2018 till date, out of 864 patients undergoing breast cancer chemotherapy, 141 were below 40. So that takes us to 16%. And the median age was 36. At the Ruby Breast Center, from August 22 to date, of 250 patients receiving chemo, 66 were below 40. Of course, there is a selection bias. We're looking at younger and fitter patients, and we're more likely to treat the younger ones with chemotherapy. The median age was 37. Breast cancer in young women is different. It has a poor prognosis. As shown in the posters already, a high HER2 expression, low ER/PR, increased nodal involvement, higher grade, larger tumor, and larger incidence of triple negative. The proportion of patients surviving is also poorer, and Dr. Bajpayee's data from Tata shows that the 5-year overall survival in this group is just 84% and DFS 65%. These patients also have a higher recurrence risk at 5 and 10 years compared to older women, and a higher rate of cumulative mets and brain metastasis. So if we look at the older data, and this is a very nice paper from NEJM, if you look on your left, published in 1986, you can see over there, women less than 35 had a 13% survival, 5-year survival difference compared to those between 45 and 49. So it was noticed way back then that younger women did poorly. And things have not really changed. If we look at the SEER data from 2015, we can see there is a 5% difference. Yes, it has narrowed, but it still remains to be poor. And the young women and the very old women are clumped together with a poorer prognosis. Not only do they have disparate outcomes, they have disparate quality of life outcomes. And I think this is very, very important. When you look at the cluster characteristics and you look at the drop in quality of life, they are younger, they have comorbidities, they come from a lower income strata, they have all the endocrine side effects you can think about. Some of them have behavioral issues, in the form of smoking and a higher BMI. So this really needs to be addressed. The genomic landscape is also quite different, especially in this study, in this sub-study of the SOFT trial, which looked at the addition of AIs and ovarian function suppression to tamoxifen alone. They did a subgroup analysis of 1,200 patients where the tumors were sequenced, and you can see on this side that there was an increased copy number in these patients who were less than 35, and also increased in 35 to 39, but not so much in more than 40. And then when you looked at the different types of mutations, you can see this dotted line separating out less than 40 and more than 40. And less than 40 years had more TP53 FGFR mutations, but there were less PIK3 mutations seen in this group over here. What about managing young BRCA carriers with breast cancer? So there are a lot of drawbacks in genetic testing, and I don't know if my colleagues have had the same experience as me, but it takes quite a bit of counseling to convince the patient to undergo BRCA testing. First of all, they're completely freaked out with their diagnosis when they're younger, and you need to spend a lot of time with them, convincing them about neoadjuvant strategies. And then on top of that, you talk about genetic testing, then you talk about the implications of genetic testing, and it really turns into a 45-minute to 1-hour conversation, and there's no getting away from it. So there are a lot of drawbacks. There's a lot of anxiety, family conflict. What if I'm positive and somebody else in the family is positive? The stigma, the survival guilt, and from the doctor's point of view, the barriers. What is the health insurance? It doesn't cover a lot of these genetic tests. What is the availability in every town? And what about the VOSs and how do we deal with them? So this is a study that we did that was presented at ESMO 2 years ago. And we looked at the prevalence of unselected breast cancer patients of BRCA1 and BRCA2 mutations. It was a multi-center study, and between June 22 and Feb 23, over 300 patients were recruited. The median age was 46, and you can see that the prevalence of pathogenic mutations was 8.8% in the full study. It varied according to the subtype. It was highest in the triple negative as expected, 14.8%. 8% in ER/PR positive, and 2.5% in HER2 positives. And when you looked at patients below 50 years, that made up 10.3% of the BRCA mutations. When you talk of treatment decisions, it's PARP inhibitors, it's platinum therapy, it's bilateral mastectomy, RRSO, concerns about secondary cancer risks with radiation, especially with P53 and ATM, second primary cancers, then future reproductive decisions, counseling and cascade testing of family members. So this is a very lovely paper because I remember in all our breast meetings, we used to have a lot of argument whether doing these prophylactic surgeries actually affected the survival. There was a lot of retrospective data, but no prospective data. And this lovely study in Lancet Oncology published this year is one of the largest cohorts to study young BRCA carriers with previous early onset, that is less than 40 years, at diagnosis. And they looked at the association of RRM or RRSO, and we have a very clear-cut answer that yes, these surgeries do improve survival in these patients. So if you are recommending, you need to recommend them earlier than later, and that's a conversation the surgeon has to have with their patient. Another very interesting study was a UK-based POSH study. It was a positive prospective cohort study of young onset breast cancer who had BRCA mutations. And what they showed was they had a similar survival as the non-carriers. This was a longer follow-up of 8 years. And there was no difference in OS in the multivariate analysis, which they performed at 2, 5, and 10 years. And very surprisingly, in the triple negative cohort, for the first 2 years, the BRCA mutation carriers actually had a better overall survival. You can see that little difference in the curves here. And then it kind of comes together and they do a little worse at the 10-year period. So the guidelines are very clear that patients with need to be tested for BRCA right up front as early as possible, especially triple negative all, and below 65 is referred to. Now the age keeps getting older and older. First it was below 40, then below 50, and now below 65. We do test all these patients. And after neoadjuvant therapy, we normally perform surgery, and the two things that we need to talk of in triple negatives are adjuvant pembrolizumab and olaparib, and both are given for residual disease up to 1 year. What about handling long-term toxicities? We are so excited to give the best chemotherapy that we forget that we sometimes leave them with permanent disabilities. And I think it's very important. And as you get older in practice, you will understand what endocrine therapies are actually doing to your young patients. So apart from the regular hair thinning and alopecia and the weight gain, the genitourinary symptoms are absolutely horrible. They go through psychosomatic symptoms, fertility impairment, they have vasomotor syndromes, fatigue. I mean, it's unexplained, and we tend to just shrug it off. I'm very tired. I'm feeling weakness. I'm feeling weakness. And this is a perpetual complaint your patient will have, especially the younger ones, that I'm not able to do the kind of things I was, used to do earlier. And don't just shrug it off. This is a genuine post or endocrine therapy effect. They also have severe musculoskeletal symptoms. Some just can't tolerate the AIs, and of course, they're at risk for increased bone fractures. Apart from that, chemotherapy also plays havoc, and so the new targeted therapies, cardiovascular issues, persistent pain and numbness due to taxane neuropathy. I mean, this is something that happens to these women. One of my patients told me, you've cured me, you've given me weekly Taxol, you've given me carbo, but I can't wear high heels anymore. And, you don't think it's important, but for her, it is very, very important. And I've taken off one pleasure of her life, and she's going to live another 40 years. So these are little things, but they're important. Second, malignancies, cognitive dysfunction. Again, they keep forgetting. They can't concentrate for more than a second. It's really bad, and it does last for many, many years. And there are functional MRIs, which show changes in the brain. And of course, we don't know what our immunotherapies are going to do. That's why there is a big move for doing the neoadjuvant immuno and triple negative. And there is a trial which is randomizing to no immuno versus immuno, because you're destroying the adrenocortical system, the pituitary, and the thyroid. And you need to be really, really careful with these toxicities. So survivorship care is critical. It's something very close to my heart. And in fact, we hold a breast cancer survivors conference every year. This is our 13th year in Pune. We do it together with WCI, which is the Women's Cancer Initiative of Tata Hospital. And this year, our focus is on women below 50. So we are trying to address fertility. We are trying to address all these different survivorship issues. And of course, fear of recurrence, psychosocial impact. Now, this may seem a bit much, but there are different interventions for long-term toxicities, and please try and implement them. In fact, for fatigue, you've got to tell your patients to exercise. It actually reduces the fatigue. There is strong data on this. We also, like Tata did a trial on yoga during chemotherapy. It really helps. So can I have just a few minutes more? Yeah, I'll hurry up. So fertility is important. All cancer patients need to receive complete counseling, and every patient is at the risk of gonadotoxicity. The younger the age, the less the toxicity, and more the alkylating agent, more the toxicity. There is preclinical evidence to show that PARP inhibitors and checkpoint inhibitors diminish oocyte number and quality. And we talked about embryo cryopreservation, always preferred as a methodology. 40% success rate. Positive data shows that these women could conceive. We do give regular GnRH to our patients. This is the POEMS and the PROMISE study, and it was for ovarian sufficiency for women wanting to avoid premature menopause, but they also happen to maintain their fertility as well. Patients with breast cancer are very less likely to have a pregnancy along with cervical cancer compared to all the others, but it is safe to have a pregnancy after breast cancer in BRCA carriers as well. And the safety has been demonstrated even after interrupting endocrine therapy. As you can see from the positive trial, these patients were not at a higher risk of disease-related events. It is also safe to have a pregnancy after breast cancer. Take care of the fetus, more likely to have Caesar sections, low birth weight, preterm weight, small for gestational, all related to chemotoxicity. The last part is breast cancer during pregnancy. 1 in 1,000 are complicated by a cancer. 25% of breast cancers are diagnosed during the pregnancy and the rest postpartum. And breast cancer makes up almost 40% of the cancers diagnosed during pregnancies. There are 2 entities diagnosed during pregnancy, prognosis good, same with age and stage match non-pregnant patients. Postpartum, worst prognosis related to the breast involution that is happening and immune tolerance. You need a lot of considerations. You need to limit the radiation exposure. One take-home message, terminating pregnancy has no impact on the mother's prognosis. Please remember that. The radiotherapy has to be postponed, target delivery earlier than later. There is no vertical transmission, and the neonatology care for the baby is very important to check for neutropenia. Systemic therapies only safe in 2nd and 3rd trimester. Stick to ANFRA, taxane, platinum, no immuno, no anti-HER2. So please remember that. You can do your dose tense, but give GCSF. So to end and to conclude, there has been an increased awareness and understanding of breast cancer in young women. We have several guidelines in place. Nevertheless, it is a growing problem, and the focus in the future needs to be conducting more studies in this special group of patients. So we do have our BCY5 from the ESMO guidelines, and we have our very own ISMPO guidelines for breast cancer in young women. Thank you for your attention.
Thank you very much. First of all, I congratulate Dr. Bhavesh Parekh and the whole organization for focusing on young patients with cancers and thinking about fertility as a part. Because most of the time, by the time patients come to us, they are in such a desperate situation that I have to do something from tomorrow, you don't have time. But just to complete a formality, go and consult a fertility specialist. So I would request here that if you can give some more time, then we can do embryo freezing, egg freezing or something like that. If the patient comes today and says, no, kal se treatment to chalu karna hi padega, I don't have that much of time. Even for men, it's very easy to give sperm. Female, it is still difficult. We need to stimulate, collect, etc. But they are in such a desperate condition when they come, so depressed, so frustrated. Sometimes even medicine given, the workup is going on for 1 month, 2 months. And then the patient comes to us and says, kal se mera treatment shuru karna hai, jo karna hai. So that fellow is not capable of giving semen also and is not at all in mood of doing testicular biopsy. So it's good that you have focused on it, that it is also a very important part of it. The another thing is that what we are talking about is young generation. We didn't talk very young people, but the name says very young people here. So these are the people where they even don't imagine they can have cancer or something like that. You know, they are just started enjoying their life. There are so many other things in their mind. They don't have their own decision power. They don't have their own financial independence. And the decision making is done by somebody else. And in those situations, to guide them properly, help them properly, counsel them properly, and try to prevent their fertility, whatever way best possible as per the situation, would be also a very, very great thing. Unfortunately, as I said earlier also, that when we have very limited time, the ovarian tissue cryopreservation works best, but we don't have too many cases done by them. But that will be possible only if you and we work together. And that is very easy, it's very simple, and it's very practical. So it's not that it is very difficult. And we are discussing the generation. I have been hearing the short forms, HR2, ERPR, Diku, means you don't talk any single word as a full form, right? And so when I was thinking that we are talking of young generation, we are talking of HOMO, DING, FIRE, etc., the short forms which they enjoy. And now when you are talking of this young generation, They have another set of short forms which we even don't know. When I read it for the first time, I thought, let me learn the short forms they use, and the list was going on beyond 200. I saw. So what I'm trying to say is that the times are changing and we need to change the thing, but it's very good. And I appreciate that all of you are focused at preserving the fertility part of this group of patients. It will go a very long way. Awareness is still not there. Patients come to us for gynec treatment, fertility treatment, even breast examination is more important than routine gynec. Even then, 50% of patients refuse breast examination. So that is the status of affair today, and I hope that will change with more and more awareness. Thank you so much. It was a wonderful presentation, nice data, and we invite the next speaker. Thank you.
Thank you, ma'am, for the session. And I would like to give memento to Dr. Shona Nag, ma'am. So now moving further, I would like to invite Dr. Anaga Zope, ma'am, for advanced oncoplastic reconstruction in breast cancer.
Good afternoon, everybody. At the very outset, I would like to thank Dr. Bhavesh Bhai for organizing such a wonderful conference and to invite me for this talk. Though my topic does say it is about advanced oncoplastic reconstruction, I'm only going to focus on one particular type of advanced oncoplastic reconstructions, which preferably we are using in young patients. All of us are aware that at what stage we are diagnosing our cancers is strongly going to influence the length of our surgery. And this is the basic thing which we need to keep in our mind when we offer heroic and skilled reconstructions to our patients. Above all, oncologic safety, looking at the patient's overall survival, looking at the patient's disease-free survival, and then thinking of what fancy reconstruction am I going to offer the patient is the call of the day. Whenever we talk about breast reconstruction, we have phase-wise evaluation of these patients. Other than all our oncologic evaluation that we do, the multidisciplinary care that we do, the management that we do, and then once we sit down and decide how are we going to offer reconstruction to this patient or what reconstruction are we going to offer this patient, the first aspect is the oncoplastic team evaluating whether this is going to be a skin sparing mastectomy. We are talking about whole breast reconstruction over here. And then whether it is going to be a skin sparing mastectomy where you will excise the nipple, or it is going to be a nipples and skin sparing mastectomy, whether this patient has germline mutations, whether the patient has received neoadjuvant chemotherapy and the patient is going to receive adjuvant radiation therapy. The patient forms a big or the most vital part in this decision-making process. And it is always a informed and shared decision-making where the patient needs to understand what are the perspectives of the reconstruction you're offering, what are the pitfalls, what are the advantages and the disadvantages over the other type of reconstructions. And of course, a lot of vendor availability, especially in the type of reconstructions that I am going to discuss, which is something which is to be kept in mind. Then comes your second phase of planning oncoplastic whole breast reconstruction, where there are 3 C's which have to be kept in mind. You have to understand what are the cornerstones of reconstruction. So what is the footprint of the breast? You need to understand what is the base of the breast. Every woman has a different base of the breast. What are the boundaries of the breast? What is the height of the breast? How does your the patient's breast extend? And then we go to the second C, which is a conus molding. So the conus is the actual 3-dimensional shape of the breast, and which defines what is going to be the height of the implant when we use an implant. And the last but the most important in all of this is what is called as a cover draping. So the implant can't just sit there in the absence of the breast. When we do cosmetic implants, they sit behind the breast, so there is no question of cover draping. But when the breast has been removed, you really need to have some sort of a cover drape on the implant. And so you form a scaffold, either that is the biological scaffold using the patient's own muscles, or it is a synthetic scaffold. And the muscular covers can either be just the pectoralis major, so that is a subpectoral cover, or it can be four muscle cover. Four muscle covers or scaffolds for implants are very difficult in Indian women where the implant size is really big. In Europe, most of the surgeons do four muscle covers because their implant sizes are very small and you can just lift up all the four muscles together and push the implant inside. And last but not the least, in all ptotic breasts, you can use the skin, deepicalize that, and then use it as a sling. So then we come to the three-step principle of managing this reconstructions, after and during the reconstruction. This is just a quick slide where you have to use, supportive undergarments. Physiotherapy has to be initiated at the right time in the right format. My backbone of physiotherapy is right there. And then the late stage, which is very significant, which most of us don't really pay attention to. When you come to the later stage, when the patient has finished radiation, when the patient nicely goes into that 3-monthly follow-up, where you as a surgeon are happy if she goes to the medical oncologist, then comes to you, is when you really have to work on the late physiotherapy of local massages and manual lymphatic drainages so that she does not at all face the risk of lymphedema. So what are the type of breast reconstructions that we really look at? Anaplastic and autologous. Anaplastic, of course, are the ones that I'm going to talk on today. Autologous are the ones which are pedicled or free flaps, could be done immediately or could be done delayed. The beauty of autologous flaps is because you get good skin cover. Like we discussed in the earlier case, if there is skin loss, your autologous flaps are the thing to have. Or of course, you come to alloplastic reconstructions, then you have a single stage direct to implant reconstruction, a two-stage where you have already done mastectomy, patient comes to you post mastectomy, put in an expander, then take it out after you have inflated and then add an implant, and a three-stage reconstruction. Once you have done the implant, after 6 months, you reconstruct the neck. Which planes prepectoral is when you don't lift the muscle, you just give a good cover draping to the muscle, to the implant and put it there subcutaneously. Subpectoral is you lift the pectoralis muscle, or it could be a dual plane. So half of it is subpectoral and half of it is covered with a sling of tissue, dermal sling or a mesh. So this is what I'm going to talk to and quickly about a few cases, how things change and how we have to change our options. So this is a very young patient. She was a 28-year-old who contacted me from Canada where she was told, you've got a 6mm disease. So then I asked for the films, and when I saw the mammography films, young patient, dense breast, yet we could see so much of difference between the density between the two breasts. And I said, I am not going to opine on this. You have to come down, we'll evaluate you. We did her mammography, MR mammography, and the MR mammography just lit up. On contrast, the whole breast lit up, showing involvements with multicentric tumors of varying sizes in the upper inner quadrant, central quadrant, lower inner quadrant, lower outer quadrant, totaling around 56mm in its largest extent. There were FDG AVID axillary level 1 and 2 nodes. The largest was 16 by 7 mm. We did a ultrasound guided core biopsy, and it was found to be a high grade, so that is a grade 3 IDC. She was classified as CT2CN1, and she was ER 90% positive, PR 15%, HER2 negative, and KI 6730, so a luminal B. And PET CT scan was done, and the PET CT scan also confirmed the findings of the MR. There were no distant metastases. Now, this girl just married a couple of months back. Very particular that I want fertility preservation. I do not want to start my treatment before we do fertility preservation. So she was immediately referred to the fertility expert. They started giving her induction for ovulation, and then they retrieved the ovum. Oocyte preservation was done. Now she's a married girl. but her husband was stuck in Canada, not able to travel, so we couldn't do her embryo preservation. So we've done her oocyte preservation, and then she was put up for a neoadjuvant chemotherapy. A dose dense 4AC plus 4T was given. Obviously, because it was multifocal, we have not done any tumor localization, and her germline hereditary evaluation was negative. Once she finished her entire chemo, this is where she presented to us. Now, if you see the image without any markings, that is a post-NSCT, and you can very well see there is a slight dimpling of the neck. There is some amount of retraction which is even visible on the left side nipple. The nipple is just inverted, and that was a place where the tumor was, it did pull over, and on the MR, we could see the extension. So she was explained that we cannot save her nipple in this case, and we have to do a nipple removing but skin sparing mastectomy. Wise pattern markings always, irrespective of whatever reconstruction you do, mandatory to be able to give the patient a symmetrical breast. And then I personally always take lazy incisions because they give me length to my incision and they allow me to maintain the conus of the breast. And if you don't take a laziest incision, what is going to happen is your scar is going to shrink and then you're going to get a square breast once the recovery from the scar happens. The post-hoist mastectomy, they showed multifocal IDC and 5 metastatic lymph nodes. She underwent a tie loop reconstruction. So this is a tie loop bra, which is a titanized mesh, and a prepectoral implant with a tie loop. And you can see the middle picture on the lower is the 4-week scar. And at the end of her radiation and recovery after radiation, that scar is also going to be not so visible. If you see the, so whenever we evaluate the cosmesis of any breast reconstruction, there are two aspects: out of bra reconstruction and inside the bra reconstruction. Sometimes patients refuse symmetrization. They say that as far as once I wear a bra, my breasts look normal and similar, I'm fine. So here you have a in-bra symmetrization as well as a out-bra symmetrization. Very quickly, we will go over the next case. Triple negative 30-year-old patient with a young 1-year-old baby and with a very significant family history. 3 first-degree relatives had breast cancer. No genetic evaluation done for them. She was not, no mammography done, no core biopsy done, and the patient, I'm going to take 5 more minutes, and the patient underwent a lumpectomy somewhere in the private, which was a circumareolar incision, horribly tethered, everything connected to the cavity. So when she came to us, we obviously explained her everything. We did the residual investigation. MR breast did not show any grossly visible invasive disease, but there were signs of extensive DCIs probably. And then that is when we explained the patient that we did a lymph node biopsy. I do lymph node biopsies for all my patients where I need to know the status, and it was negative. So the patient opted for a germline evaluation before she underwent any surgeries. We got her germline evaluation done that showed a BRCA1 mutation, and she has 3 children. She didn't want any fertility preservation. She opted for bilateral breast reconstruction, and she did want to ask us for a bilateral salpingo-oophorectomy, but the MDT decided that at 30, we don't want to offer her BSO right away. We will try to salvage her for a few more years and then, offer it to her. So this is where we have done, again, patient herself opted, I don't want nipple saving surgeries. So nipple excising bilateral excision was done. And you see the ptosis, this is grade 3 ptosis. So when there is grade 3 ptosis, you have ample amount of skin which you can use for a dermal sling, and you just don't need anything. The breast gets lifted. And if you see on the day of the surgery, there is no necrosis. But on day 14 or so, there is some epidermal necrosis. Now, this happens when you do extensive dissection, when you change planes. And as far as it is not full thickness, that's all good. The third case, BRCA positive lady, again, mother had breast cancer, grandmother had breast cancer. It was a small disease. It was a T2, a very small T2, 22 to 25 centimeters. She again opted that I want a BRCA assessment. Now see, this is what ma'am just told us about, how a young breast cancer patient behaves separately. She saw her mother dying of breast cancer when her mother was not even 40 and this girl was not even 18. And that trauma was so strong in her that she has been in severe endogenous depression. And when she came to me, she refused to open her mouth for the first 45 minutes. And then she said, "This is the day I have feared for the last so many years of my life. And I am still facing it." And she was so bad that she was taking 4 antidepressants. We had to literally bring in the psychiatrist, make him sit with us, the psychologist, and counsel her. But of course, we went ahead with the surgery. In her case, she wants a nipple, but she doesn't want the risk of recurrence. So what do we do? So we do a free nipple grafting. You take a full thickness graft of the neck, you shave off the base, send it for a histopathology, and then do free grafting. Make the patient understand that there can be a, she can lose it later on, but if she's fine with it, that's the best option. So here you have a dermal sling. I created a complete lower segment dermal sling. Lower half of the implant is covered with the dermal sling. Upper half, of course, the pectoralis, and the implant nicely sits together. We implanted the neck. There is some partial necrosis of the nipple on the left side, but otherwise it has taken beautifully. She is absolutely comfortable. And after 3 months of surgery, she has come from 4 antidepressants to 1 antidepressant. And that, I think, is where we have, our MDT team has succeeded. The last case, very last case, 35-year-old premenopausal multigravida came to us with a small palpable disease. Again, we did because it was extremely dense breast, did an MRI breast, and the entire upper outer quadrant lit up. Day one, before starting therapy, she tells us, "I want my breast to look the way they look now. Only then will I start any therapy." So, okay, we agreed. We did her, so she was a HER2 positive case, and because of that, she was given TCHP, or rather, she was given TC and FESGO. And after 6 cycles, we evaluated, there was remarkable reduction in the disease. And then we planned her, again, germline mutation negative, a small breast. If you see, her breasts are very small, but they're extremely totic. When we explained her that we might need to change, correct the symmetrization on the opposite breast, she refused. She said, "I don't want it touched. As far as the in-breast symmetry is fine, I'm good with it." We've done a nipple sparing mastectomy for this girl with a tie loop bra again and placed it sub-pectorally. This is the 3-week, healing, and it is so good. She has complete sensation of the neck. She even has maintained the erectile function of the neck, and the in-breast symmetrization is perfect. In fact, over a period of time, the implants will sag, and even the out-breast, out of bra symmetrization will be good. So why do we all now, the youngsters need to look beyond conventional nipple sparing mastectomies? Because when we started doing nipple sparing mastectomies, that is what we used to look at, those were our flaps. We used to dress them for months together. And then, Bhavishbhai used to glare at me every time I would pass by. When is she coming for, adjuvant therapy or whatever? Because that time we used to do in early breast cancers, no neoadjuvant chemotherapies. And then nipple sparing mastectomies are not easy. Half of the times you as a surgeon are balancing yourselves. You are bent laterally at 90 degrees, or, trying to reach over the mold and not using retractors to save the flaps. So that is where we really need to do. Just the last slide. Please remember, just as much as breast reconstruction and breast salvaging is important, more important for the patient is axillary salvaging, and all of us need to practice sentinel lymph node. All of us need to offer breast reconstruction if we want to empower our women to feel complete again. Life does not end at life, it ends at quality of life. Thank you so much.
Thank you, ma'am, for this session. I would like to give memento to Dr. Anaga Zuko, ma'am. Now, moving further, I would like to introduce Dr. Runu Sharma, ma'am, to share her insights on the topic motherhood and the journey with breast cancer.
Good evening, everyone. So,
So I'll be talking about motherhood through the journey of breast cancer. I want to disclose that most of my topic has already been covered beautifully by Dr. Shona Nagman, and many of it might be just a repetition of what ma'am has said. So we know that breast cancer is the most common malignancy in females globally, and around 7 to 10% occur in the younger age group. In India, we see the earlier age as presentation and many with the dependent children. So there's a unique challenge of balancing motherhood and the treatment at this age. So many young women who are suffering from breast cancer have to take care of the young children. They have the dual responsibility of battling with the cancer, its diagnosis and treatment, while nurturing the family. So it has an impact on their maternal identity, their caregiving, and emotional well-being as well. So we know that there is a higher proportion of triple negative and HER2 positive breast cancers. Younger females present with more advanced age stage at the diagnosis, and BRCA mutation prevalence is higher. Pregnancy associated breast cancers incidence is 1 in 3,000, and there is a diagnostic delay due to the physiological breast changes which impair the pathological diagnosis and often present with higher grade and advanced stage. So there are various issues that we see with the pregnancy-associated breast cancer, like the ethical issues in the best management of the mother and the fetus, the effect of cancer on pregnancy, which means the effect of the tumor, its management, the effect of the outcome of pregnancy, the mode of delivery, the fertility, and effect of pregnancy on breast cancer. That means the effect on of the biology and the effect on the management. So the effect of cancer on pregnancy can not simply be explained by the high dose of estrogen. We know that pregnancy-associated breast cancer are more likely to be advanced, mostly due to the increased blood and lymphatic supplies. This leads to the microscopic nodal involvement being more likely and high incidence of inflammatory breast cancer. On an average, we see a mean delay of 1 to 2 months in the diagnosis in pregnancy-associated breast cancer and the increased chance of nodal involvement because of that. Post-pregnancy, the breast remodeling again may favor the tumor dissemination, and the breast cancer, as we see, is more aggressive in the younger age. Then comes the diagnostic challenges in the pregnancy-associated breast cancers. Mammography has a limited use and ultrasound is the preferred imaging modality. If we are doing MRI, we have to do it without gadolinium, and biopsy, however, remains the gold standard. So the treatment should not be delayed solely because of the pregnant state. However, because of the rarity of the condition, the lack of awareness, and the fear of harming the fetus, they often complicate the management, and this emphasizes the need of multidisciplinary planning for the patients. That means that there should be the integral approach, which includes not only the medical oncologists, but the obstetricians, surgeons, the neonatologists, anesthetists, and the counselors. And the treatment has to be individualized, keeping into account the patients and the family's decisions, and individualized also based on the disease extent, the gestational age, impact of the pregnancy, and the fertility. Surgery can be done safely at any stage of the pregnancy. We follow the same guidelines as for non-pregnant females. Of course, the multidisciplinary decisions again come into picture, including the need for the anesthetic monitoring and the complications with the fetal heart rate monitoring and the analgesic issues. Coming to the systemic treatment, for the first trimester, the systemic treatment like chemotherapies are contraindicated because of the organogenesis. And in the second and the third trimesters, we can safely use the chemotherapies, anthracyclines, and the taxanes are usually safe for the second and third trimesters. As mentioned by ma'am again, the target therapies with the anti-HER2 targeted therapies and endocrine therapies and immunotherapies are always avoided. Radiation is contraindicated during pregnancy and can be planned postpartum with the counseling for the lactation. The similar findings have been elaborated in the ESMO guidelines as well, where they have elaborated the chemotherapy being contraindicated for the first trimester. Of course, the fetal benefit for the treatment delay should be balanced against the maternal risk. Chemo standard dose should be used without any adjustment during the pregnancies. Checkpoint inhibitor should be avoided and deferred till the delivery. The GCSFs could be used during pregnancy if they are clinically indicated. For the antiemetics, we can use ondansetron metoclopramide, and we have a judicious use of steroids. The mode and timing of the delivery is not affected by the diagnosis, provided that the myelosuppression of the cytotoxic chemotherapy is avoided by stopping it later at week 35 for the weekly schedules. And surgeries involving the nipple areola complex may affect breastfeeding as well. If the patient has mastectomy, the infant can have adequate milk from the single breast. After the pregnancy-associated breast cancer comes those young females who desire to become mother after the completion of their treatment. And there again comes the gonadotoxicity of the chemotherapy. We know that the cytotoxic therapies have decreased the ovarian reserve sharply, and we need to counsel the patients for the fertility preservation. That is very important. And not only the chemotherapy, but the PARP inhibitors and the checkpoint inhibitors also diminish the oocyte number and have an impact on the fertility. So it is very important that all the cancer patients in the reproductive age should receive the complete oncofertility counseling as early as possible in the treatment planning process, and that is irrespective of the type and the stage of disease. As there is no absolute threshold of exposure to the anti-cancer therapies that determines the gonadal failure and the infertility, it is important that every patient should be considered to be at potential risk for developing the treatment-related gonadotoxicity. So the fertility and ovarian function preservation strategies, we all know they are all safe for even in the pregnancy, to have the pregnancy later on after the breast cancer. And the positive trial again has emphasized on there's no increased risk of recurrence post breast cancer treatment. And the timing can be individualized, usually 2 to 3 years after the diagnosis. And again, the multidisciplinary decision is essential. So the safety of pregnancy after breast cancer has been evaluated in the meta-analysis, and it has generally been found to be safe, even for the BRCA positive patients. However, we need to change the physician's perspective regarding this. And this study has highlighted that only 50 to 60% of the oncologists believed that pregnancy does not affect the prognosis of breast cancer patients. And then comes into picture the positive trial, the need for positive trial because of that, for the hormone positive early breast cancer patients. And the duration of prior endocrine therapy was around 18 to 30 months. And the treatment interruption for up to 2 years with the 3 months of washout period was considered here. And endocrine therapy resumption strongly was recommended after to complete the full course of endocrine therapy. So this trial included young patients less than 35 years of age, were around 35% of them, having low BMI, mostly having a small tumor. 90% of them had stage 1 and stage 2 disease. 60% of the patient had node negativity and grade 1 and grade 2 disease. So the median follow-up of 3.4 years in this trial shows a no increased risk of recurrence with the treatment interruption of endocrine therapy. Around 70% of the patients had at least one pregnancy during this time, with 86% of them having a live birth. So pregnancy-related complications were seen in around 11% of the patients. And beyond the medical impact of this treatment, we have the deep psychosocial impact of the treatment of young mother. There's a conflict between the role of the caregiver and the patient. There's a fear for the loss of a motherhood role. And we have to, that is why, redefine the maternal role when the patient is battling with cancer. So such patients, they have higher rates of anxiety and depression. They may be suffering from guilt about the children's future. And that is why psycho-oncology support is important to improve their quality of life. So the impact on the children whose mother is suffering from breast cancer is also to be considered here. So the emotional and behavioral issues in such children have been reported. The age-specific responses can be there. It can vary from the younger patients. Younger age children may be behaving with the fear and anxieties, and they may be having denial, and the adolescent may be behaving with the aggression and frustrations. So it is important to have an open, age-appropriate communication with them. So if we have an honest, open, and age-tailored explanation, it will help them maintain the trust and their security, and that will encourage the expression of fears and concerns and make them cope with the disease and the diagnosis well. Apart from that, the support from the partners and extended families, the peer support, NGOs, and the survival group, of course, are very important. And the professional counseling should include not only of the patient, but also of the family members. So we see that many mothers, they draw strength from the faith and spirituality, and resilience is linked to the improved coping mechanisms. So we should have an integrated care approach in which the psycho-oncology and the spiritual well-being of the patient should be taken into consideration. So because of the shortage of time, I will skip the cases here. And the survivorship challenges, we know the fear of recurrence, and the long-term toxicities like fatigue, lymphedema, cognitive dysfunctions, sexual issues, and the relationship strains are some of the things which should be kept into account. And the risk of recurrence, the positive trial has shown that the temporary interruption of the endocrine therapy does not lead to the increased risk of recurrence, but of course there should be a careful risk-benefit discussion with the patient before we plan anything. So most children of such women, they develop normally. They need the emotional support programs, and long-term data is reassuring for such patients. Healthy lifestyle and breastfeeding protective for mothers, avoidance of obesity, smoking, and alcohol. Apart from that, we need the advocacy to propagate for the need for maternity leave and flexible work hours. There should be the financial support for the fertility preservation, and integration of the psycho-oncology should become the standard of care for cancer patients. So the journey of breast cancer for young women, from the diagnosis to the treatment and the motherhood challenges, support systems, and off to the survivorship, is the continuum care, and everything has to be taken into account before we plan the treatment for such patients. So the breast cancer in mother, it requires the holistic care. Fertility, pregnancy, and motherhood must be integrated into the treatment. The survivorship and the psychosocial care are essential to empower the mother, because when we empower them, we not only improve the outcome of an individual, but we actually empower the society as well. Thank you for your patient listening.
Thank you, ma'am, for this insightful talk. Ma'am, just a minute. One moment. So snakes and tea has been started, and our next speaker is Dr. Michelle Ingenio. Her topic is breast cancer in young women. Please welcome her.
I would like to thank Dr. Bhavesh Parikh sir and the whole TYAcon team for inviting me for the talk, and Dr. D.G. Vijay sir for giving me an opportunity to share our experience of young breast cancer at HCG Asta Cancer Center, Ahmedabad. So we know that is rising in the incidence of breast cancer in India. With higher percentage of young women in India, the incidence of young breast cancer is 10 to 20% in India compared to 2 to 6% in the West. Late stage of diagnosis, worst molecular subtypes like triple negative, HER2 positive breast cancer are common in young women, and this leads to long-term outcome concern. Breast cancer in young age are inadequately represented in trials and have unique concerns, and that's why a study is required. So our aim is to study the biological behavior of the disease and the long-term survival outcomes. It's not moving. Undo it. Yeah,
No, that is.
So, as I said, our aim is to evaluate the biological behavior and long-term outcomes in young women with breast cancer in our institute. A prospectively maintained database was evaluated retrospectively. Histologically proven breast cancer, consecutive patients, non-metastatic invasive breast cancer patients who were treated with curative intent and with age 40 and less than 40 were included in the study from years 2015 to 2024. Clinico-pathological characteristics were extracted from the medical records of the hospital, and follow-up data was collected by telephonic means. So we had total 3,644 patients, and the patients which were equal to 40 and less were 550 patients, which are 15%. From there, 54 were excluded because of benign diseases, DCIS Paget's Pilot sarcoma, and then we had the sample size of 496 patients which were analyzed. If we see the clinico-pathological characteristics, the median age was 36. LAPC was seen in 33% of patients. Majority were T2, which was 64%. Median clinical tumor size was 3 centimeter. Majority of them were N0 and N1 at presentation. Most common was IDC and grade 3. Hormone receptor positivity was seen in around 70% of patients. HER2 positivity was seen in around 24% of patients. Triple negative, just a sec. Yeah. Negative breast cancer was seen in 23.6% of patients. 41.7% patients received neoadjuvant chemotherapy. We are happy to say that breast conservation surgery was equal to modified radical mastectomy in our institute. Oncoplastic and reconstructive procedures was done in around 25% of patients. Pathological tumor size, median tumor size was 2.1 centimeter. Lymph node positivity was seen in 46% of patients. LVI positivity in around 42% of patients, and around 88% of patients received radiation. We saw recurrence in around 7% of patients, with distant recurrence seen only in 2.2% of patients. The median follow-up was 61 months. We're happy to say that 5-year disease-free survival was around 85.5%, and the overall survival was 90%. The reason for such good survival, which I can say, is because it's a corporate hospital. There, it has patients which are, half of them are affluent. They can afford different kind of treatments. They are very health conscious. They're very compliant. They all come for a regular follow-up. On Cox regression analysis, the factors that were responsible for poor overall survival and disease-free survival were all higher T stage, higher nodal stage, hormone receptor negativity, triple negative and HER2 new positivity, and pathological node positivity. Now I have compared our data with all other institutes in India. So if you see the samples, the young breast cancer in our institutes were 13.6%, which is as equal as TMH Mumbai data. And both of us have taken the age equal to 40 and less than 40. Well, if we see the data from AIMS Delhi and GCRI Ahmedabad, which was recently published in July 2025, there the percentage of young breast cancer is less because the age that they have taken is 35 and less, 30 and less. So that is the reason. Other difference is that we have taken non-metastatic cancers. TMH Mumbai have included oligometastatic breast cancers. AIMS Delhi and GCRI have included all breast cancers, including metastatic breast cancer. Locally advanced breast cancer was more seen in TMH Mumbai and AIMS Delhi. The clinical tumor size was 3 centimeter at our institute and pathological was 2.2, quite similar to TMH Mumbai. Triple negative breast cancer and HER2 positive breast cancer were almost similar across all institutes. At our institute and TMH Mumbai, we saw that BCS was almost comparable to MRM, while in AIMS Delhi and GCRI, there were higher rates of mastectomy. The patients receiving NECT were more in our institute and TMH Mumbai, while pathological complete response were almost similar. Node positivity was more seen in TMH Mumbai and in GCRI Ahmedabad, while it was comparatively less at our institute and AIMS Delhi. If you see the disease-free survival at our institute, TMH Mumbai and GCRI, that's quite high because in TMH Mumbai, GCRI, we have that group of patients who are not that literate. They cannot afford all the complete treatment. The compliance is a problem. So maybe that will affect all these things. And the factors that worsening the survival at our institute, as I already told you, which is also seen in other institutes like TMH Mumbai, has worse outcomes in triple negative and HER2 positivity. AIMS Delhi, higher T stage and N stage, hormone receptor negativity, visceral mets, and at GCRI, almost same hormone receptor negativity, HER2 positivity, triple negative breast cancer, high grade, non-luminal A, and high clinical stage. So in the conclusion, I just want to say that young breast cancer appears to be higher in India compared to the Western world. More than 1/3 of the patients present at late stage. That's why we have worse prognosis and poor survival. That is why escalation of cancer awareness and screening programs is very much needed in this group. Issues like genetic testing, fertility preservation, risk-reducing surgeries in case of genetic mutation should be discussed with these patients. I have not included these points in my presentation because we are still working in collecting the data, but whenever we'll be writing it, we'll be combining all those information and then publishing it. Thank you so much for your attention. Thank you.
Ma'am, so next, I would like to invite Chairperson Dr. Siddharth Srivastav. And सबको इनको invite करना वही सर चल रहा है
Yes.
Good evening, everyone. First of all, thanks TYAcon Foundation, Dr. Karan Chittagir sir, and GCRI for giving me this opportunity. When I was asked to give a presentation on germ cell tumors, I was like in front of all the medical oncologists, what extra knowledge will I be giving? But then I thought, let me put my surgical experience from the OT table in front of you all. So basically, the experiences from the OT table never come on the paper. It's only the notes that come on the paper, relevant for the medical oncologist and future follow-up. So we all know germ cell tumors
ovarian germ cell tumors are a battle beyond cancer. It's balancing between cure, fertility, and hope. It is a unique and sensitive challenge that is posed to us. Typically affects the young girls and women. Fertility preservation is definitely under radar because the ovaries will be lost. And adjuvant chemotherapy are always cytotoxic, affecting our fertility potential. Parental concerns, risk of losing the child to cancer. The fear is always running in their minds. To see the child suffer from the pricks and the scans and the surgery is always heartbreaking. They have had plans to secure the child's future, but then sudden malignancy diagnosis takes them off the track, and definitely the future of fertility is a concern. The slide is not changing. Okay. So malignant germ cell tumors represent 5% of the ovarian cancers, and 80% of them are pre-adolescent malignant ovarian tumors are germ cell. They're more prevalent under 30 years of age, median age being 16 to 20%. Younger the age or elder age, they have different behavior of the disease and different tumor biology. So they are more aggressive with poor prognosis. Majority of them are diagnosed in early stages. So the prognosis is better in stage 1 as compared to stage 4, which is 59% in stage 4. If we talk about the histology, the immature tetrasomas and dysgerminomas do better as compared to mixed germ cell and embryonal carcinomas. If we talk about the prognostic factors, we all know that extreme of ages, that is premenarchal girls more than 45 years, incomplete staging or yolk sac pathology have poor prognosis as compared to the others. The prevalence is more in African and Asian countries. At SAMES, this is the data where in 5 years, we found 25 cases of germ cell tumors. Majority of them were under 20 years and unmarried. And the commonest pathology was mixed germ cell tumors, followed by immature teratoma, dysgerminoma. We also had youngest patient of 11 years and the eldest patient of 62 years. So we have a strict protocol at our institute, our department. We take detailed history, followed by menstrual history is important. If she's a premenarchal, we upfront send her for karyotyping before any anti-inflammatory or antibiotic is also given to the patients. That is more important. After the routine workup, which biopsy is not required, one must understand that tumor markers and radiology is itself enough. We can lose the patient in improving the malignancy. So when we come across the workup, low hemoglobin levels might indicate internal hemorrhage, so needs pre-op optimization and reserve adequate blood and components. Counseling sessions with the parents should take detailing, and the parents have a lot of questions about the fertility, about the scars, and about the adjuvant treatment and everything. And one has to address them very patiently and in the details to satisfy them. Upfront surgery versus NECT, it all depends on the radiology imaging findings, the tumor markers and the clinical examination findings. If the patient is fit for surgery, the general condition, there is no pleural effusion, upfront surgery is possible, we will definitely operate her. But if there's pleural effusion and we don't have time to optimize her, we send her for neoadjuvant chemotherapy. Informed and return consent in every scenario is important. What challenges do we face when we get the patients? The first important challenge is the delayed referrals. Extensive unnecessary investigations are done. The resources are exhausted by the time patients reach us. The anxious and tired patients, even the relatives are tired. They are improperly managed. They are kind of just partially surgeries done. They are unstaged, and they're not even told about the diagnosis, and they're referred. At times, not even referred. So when they come to us, there's fear of surgery and treatment, concerns about loss of fertility, loss of hair, surgical scars, fear of pain, and school absenteeism, which is not much talked about. When it comes to staging, open versus minimal invasive surgery, I will always say open route is better in a larger tumor, where I will like to palpate each and every structure and confirm there's no residual disease that I'm leaving behind. I will reserve the minimally invasive option in select cases, such like the post-NACT patients where the tumor load has decreased and without any problems, without any fear of complications, I can go inside, do the surgery. Even if the tumor is bigger, I can deliver them in the endo bag from a small transverse incision that will give her the benefit of a early recovery. But a careful examination of abdominal cavity with no compromise at the bottom line. Intraoperatively, midline versus transverse incision, I will always go for midline when I'm doing an open surgery. Transverse will be reserved only for a minimal invasive surgery where I will remove the specimen through the transverse incision. Generalized ooze, as soon as we open the peritoneum and we touch the tumor starts bleeding and oozing in the pelvis. It doesn't stop, no matter what we do, it doesn't just stop. You have to keep cauterizing, you have to keep using paracriline solution or use Surgicel. In my experience, only pressure and time has helped. By the time of end of surgery, the oozing had stopped. So probably the tumor biology is like that these vascular tumors have vascular adhesions as well. Frozen section, no, with all due respect, but I take it with a pinch of salt because they have their limitations. The expertise is not always there in terms of oncopathologist. And then no matter what, the intra-op decision is always important, whether or not to go for a aggressive or a radical approach. Wound cosmesis in young girls is important. I will give a midline incision and work 30 minutes more to give better cosmesis to the young girl because those scars speak stories for the patient, for the child, but it also tells the story about my work in the future. So primary surgeries are definitely easier. Upfront surgeries, they have good planes and everything. Even though they bleed, they are still okay. But secondary cytoreductive surgeries, in my experience, were nightmares. I'll be sharing the cases next. In terms of secondary cytoreductive surgeries, any resectable residual disease should be removed because of the possibility of growing teratoma syndrome as well as the somatic malignant transformation in the immature teratoma. So coming to case one, many of us must be knowing these cases from the Aurobindo. So first one was she is 28 years old, presented with mass in abdomen, operated somewhere, and then she wasn't told about her histopathology. She lost to follow-up, came to us in 22, and she had this liver lesion, big liver lesion of around 10 centimeters. And her markers were first time done, which showed AFP 1,80,000 and LDH raised. So she received 4 BB because the general condition did not support. Then after the NACT, the tumor markers were normal, but still there was residual disease over the liver and in the pelvis, peritoneal disease, not the pelvic disease. So we did a cytoreductive surgery. The uterus was normal, the opposite ovary was normal, peritoneal disease was residual dead disease. The diaphragmic disease was also dead. There was no live disease in the histopathology. But the tricky part was the lesion over the liver. It was infiltrating the diaphragm. And while dissecting that, the diaphragm got injured, the pleura was opened twice in 2 areas, and we sutured it with 3-0. Patient did well, discharged on day 6, but and the histopath was also all R0 was achieved. But on day 11, the patient came back with fever, vomiting, breathlessness, and she was not doing, general condition wasn't good. So we did her optimization, we gave her antibiotics, we did pigtail catheterization, ICD insertion. And after that, when we did a CT scan, you see this, the rent that we had repaired had opened. that because of the sepsis, it was infected. This was the rent here, and it is seen clearly here. Now, it was a bigger challenge. Many people had said, "Ki, don't go into it. You cannot do much about this." But we gathered all our mites and posted her for the surgery again. It was a challenge how to suture that rent. So what we did was we reflected the peritoneum from the abdominal wall and sutured it over the diaphragm. Thankfully, it worked, probably with all the efforts, with the gastrosurgeon, and it was a team effort with good anesthetist. And see, on the 2-year follow-up, the diaphragm is all good. The patient is very happy. We had, literally, we were all scared and guilty with all her condition. We celebrated her anniversary in the ward. And then the second picture is of a cute family together. The second case is a 16-year-old smart, intelligent girl diagnosed to have germ cell tumor, yolk sac tumor in 21, operated, no adjuvant treatment required, came to us in July 24 with a huge mass of 10 centimeter in a periaortic region. I'm sorry, I'm exceeding, but I'm sure you will all like it. So this was a conglomerated nodal mass from the left renal vein up till the common iliac bifurcation, left common. It was abutting the ureter as well, and it was abutting the psoas and the aorta as well. So we again, Chitalkar sir puts all the challenges to us and pushes my limit. So we dissected it. So this is the video of that surgery. This is the aorta. This is the bifurcation. Here, bluish part is the IVC, and this is the periaortic node of almost 8 centimeter post NACT. So this is how we dissected. We are not afraid about the aorta being injured. It's very difficult. You need to be grossly wrong to injure the aorta. But IVC, it's very easy. Thankfully, it was periaortic region, and this is how we dissected the mass. Third case is a 30-year-old para 2 live 2. She had 2 children, 5 and 3 years old. Came from Shivpuri, had ovarian mass, got operated, did not know about the malignancy, lost to follow-up. After 11 months, she presented in Bhopal with pain in abdomen and chest pain and pain in epigastrium rather. CT scan had a 8 centimeter lesion, and tumor markers and biopsy was suggestive of yolk sac component. Then, in view of recurrence, she received 4 BEP. But then in December, they found that in spite of giving the chemo, the tumor size was rising. So they started her on TIP. So the CT scan had heterogeneously enhancing multiseparated lesion from gastrohepatic region in the retroperitoneum along the celiac trunk and hepatic artery and gastric artery, splenic artery. All the vessels you can imagine in the epigastrium were abutting. The tumor was abutting, and it was displacing the caudal lobe as well. So you see the 12 centimeter lesion in March after TIP also had increased to 16 centimeters. And this was the lesion. And this, you see here, the IVC is totally C-shaped IVC pushed by the mass. The aorta is curving this side, and it is kind of infiltrating the diaphragm intraoperatively. We saw that. So we, again, in the unknown territory, we had to jump and operate on this. We took help of the gastrosurgeon. And we had 2 things in mind: growing teratoma syndrome in normal markers and somatic malignancy. So this is the picture where we see this is the solid component of the tumor. It was a bilobed mass passing under the bile duct and hepatic duct. This is the cystic part here. This is cystic part. This is the solid part. This is the tumor that we excised. The cystic part was there, and then the solid part, and this is the part after dissection with the help of a gastrosurgeon. So at times it becomes very challenging to operate in the unknown territory and with all the major vessels in the young patients where they have a good life ahead. Patient did well in the post-op period. She had low count sepsis, but definitely recovered and went home. And her surprising histopathology report had clear cell carcinoma with teratomatous germ cell tumor. So one has to always remember the possibility in a residual disease of growing teratoma syndrome and somatic malignancy. She is after 1 year with her family doing happily, and she's getting regular periods. So in this case also her opposite ovary was normal in spite of the recurrence in the retroperitoneum. The last case, 12 years old, studying in 7th standard, again a yolk sac tumor pathology, had a nodal metastasis. And this was the periodic dissection for a 4 centimeter nodal mass that we did. It was definitely very challenging. This is sitting between the aorta and the IVC and completely closely abutting it. So this, we are lifting it over the aorta first. Again, because aorta is very, I find it very safe to dissect. This is the lymph nodal mass. We are lifting it over the aorta. So coming, this IV, the aorta is free now, but if one sees this IVC is tented, it is completely lifting the IVC while we are operating. So we were trying to be close, very close to the nodal mass than to the IVC. So this is the 4 centimeter lesion that we dissected, and those were the diaphragmatic deposits which were biopsied and were negative. Coming to the last slide, the early diagnosis and timely referral has better outcomes. So all the 3 cases that we saw now were operated outside first and then came to a oncology center, which affects the outcome. Act fast and act right. Within 24 hours of admission, we have the treatment plan ready and we are executing. We have a good team with medical oncologists, surgical oncologists, and the gynae oncology would help definitely in our difficult cases. Top priority for such patients, these are young patients, so they go first in OT and delayed causes survival. Diagnosis is always clinical, radiological, and with markers. Please do not biopsy. Think fertility always. 1 ovary makes such a big difference in all 3 patients. One could have easily thought of removing it, but I went ahead and saved the ovary. The guidelines even support it. So patients getting menses are happy. They feel better that menopause is not hitting them early. Consent in this case is very important because we are preserving the ovary, the kind of recurrence, but we always know that the bilaterality is very rare. Surgical fitness definitely matters because of the cosmesis that these age group require for the wounds that are very big for the open surgeries. And MI is only in the hands of experienced and select cases. Definitely gynae surgeons ensure complete staging, fewer recurrences, so prefer operating by a gynae oncologist. Primary surgery is the power surgery, definitely, and secondary surgeries are always unpredictable. In ovarian germ cell tumors, surgeons feel like superheroes because they're backed by the medical oncologist. The chemosensitive tumors, one can skip easily the radical weapon and save the day with less painful invasive surgery. Communication is the backbone, and stronger patient-doctor relationship improves the follow-up and outcomes. And patient-friendly mobile apps to monitor the tumor markers should be set up, where the tumor markers will be uploaded in the app itself and the doctor can see that. This is our team in the Aurobindo Medical College, the gynae oncosurgeons. I was impressed by the last line when the surgeons, anesthetists, and nurses and oncologists come together, the patient wins. Thank you.
Yes, yes. Thank you, thank you. Thank you.
For the concluding tumor board, I would like to invite Dr. Runu Sharma and his panelists, Dr. Priyanshu Tripathi, Dr. Prutha Jenwala, Dr. Mahima Khajanda, and Dr. Shakuntala Shah. Dr. Ronu Sharma.
तब तक पैनलिस्ट को बुला लो ऊपर तो बुला लो ऊपर तो बुला लो पैनलिस्ट को भेज दो
नहीं तो फिर नेक्स्ट वाला भी कर लेते थे दूसरे वाले से बात कर लेंगे
ठीक है हाँ बस विराट के पहले है ना
अगर वैसा कर लेते फिर नेक्स्ट कर लेंगे
ठीक
So I would like to call Dr. Viraj sir, and he doesn't need any introduction. For panelists, Dr. Rajesh Patil sir, Dr. Pushpendra, Dr. Rajan, Dr. Avinash, and Dr. Parthiv Shah.
Thank you. Good evening, everyone. Thank you, Bhavesh sir. Thank you, Chitalkar sir, for having me here. So for next 15 minutes, we are going to discuss few cases of GI cancers and molecular profiling of them. Okay. Right. Everybody can see the screens. Okay. So we have 3 to 4 cases and we'll discuss mainly the molecular profiling part of this. So this is young woman, 50, had a sigmoid CA, underwent operation, was stage 3 cancer, MSS, got a 6 months of adjuvant chemo, finished in January 2022. Within a year, her CA started going up, liver showed bilobar liver lesions. There was no extrahepatic disease. Okay, so still in the potential realms of curative intent could be performed later on if we have an excellent response. Patient PS good, biopsy from the liver lesion shows poorly differentiated adenocarcinoma. So starting with you from the left, Raja, do you do PCR-based RAS testing, or do you do small profile NGS? Do you do comprehensive genomic profiling? Do you do combo testing? Please tell us, what do you do in your practice?
So if patient is affordable, I prefer to do broad test, comprehensive genome.
On tissue, liquid,
On
both,
tissue,
or
tissue.
only liquid?
The patient is affordable on both, not on tissue.
Okay, both tissue as well as liquid. NGS, CGP.
Yeah, if patient is affordable. Otherwise, I prefer only on block first.
On block. Pushpendra, what about you?
As Dr. Rajesh said, if affordable, both upfront. If not, you start with tissue, limited panel, NGS. Otherwise, if affordable, full.
So now tell me, in your practice, what happens? Out of 10 patients, how many go for PCR? How many go for NGS? How many go for combo NGS?
We are a restricted institute. We serve the poorest of the poor. So we usually
PCR.
don't do NGS. For us, it's PCR. And I would dream of doing a liquid biopsy sample for this.
Okay, what about you?
Same thing, but in select patients, like beneficiary patients and affordable patients, we go with tissue NGS.
Okay. Right. So, Rajat, back to you. This was a tissue NGS sent and APC and TP53 mutation. What would be your treatment line based on this? Or you want any more tests? This was a CGP. Yeah.
It's metastatic colon
Yeah.
cancer again.
First line.
Yeah. And
So RAS, RAF, wild type, MSS, no HER2, left
sided
sided.
colon cancer. And only 2 lesions are there in the liver.
No, bilobar, multiple, 12 lesions at
12
least.
lesions are there. So intent will be palliative.
Or conversion.
Yeah, or conversion. So I plan treatment with the EGFR inhibitor.
The chemo anti-EGFR. Anybody differs from that? Chemo EGFR. So this patient was from rich family background and also had a combo testing done. So the liquid biopsy showed this. Now, would you change, or you think liquid can pick up small subclonal, and I would still focus on anti-EGFR? Change. So the lesson learned is whenever we in colorectal cancer, especially with liver metastasis only, when we send tissue-based NGS, we are more likely to miss the RAS-RAF alteration pathway. And this was beautifully shown in this paper a couple of years, almost 3 years back. 150 patients of metastatic colorectal cancer patients on day one, they did both tissue as well as liquid. And you can see the Venn diagram on your left. Only 75% was concordance. On the green 10%, you would miss, the tissue would pick up, the liquid would miss. And on the pink, 16%, tissue would miss and liquid would pick up. So then they further identified who are these patients on the extremes. And if you see on the bar graph on the right, you see if patients have liver metastases, the tissue tends to miss more often, and you would pick on liquid biopsy. While if you have a peritoneal metastasis or lung metastasis, colorectal cancer, the liquid biopsy misses and tissue biopsy trumps. So this is a very good suggestion that if at all you want to do one, in patients with liver metastasis colorectal, you would rather do a liquid NGS. If you had to choose one, I agree. If everything is there, we want to send both. That would be very expensive. But if you want to send one, I would rather send liquid NGS for liver metastatic patients versus a tissue NGS if your patient has peritoneal or lung metastasis.
I have a doubt. Is there sensitivity for all other mutation is same for tissue, liquid?
So mainly we want RAS and RAF, right? So this was a good question. So this was another experiment from an Indian from a lab which did test for colorectal cancers. And if you see, about 14% of our patients in India have alterations in important pathways like PI3K kinase, HER2, RET, and MET. Now we know why are these important, because we call them something called as pressing panel. If they are altered, just see on the right, anti-GFR is worse than bevacizumab. While if they are all wild type, we call them hyper-selected, right? So not only RAS-RAF wild type, but we want PIK3 wild type, we want RET, MET, we want HER2, all wild type, and suddenly anti-GFR trumps over bevacizumab. So yes, NGS is the way to go in 2025, and PCR-based testing should be only restricted to lower socioeconomic strata. And perhaps I don't even do it, just use Bev in that case, and don't spend money on PCR. Quickly, let's go to second case. Elderly gentleman, but fit PS, underwent first line with FOLFOX plus anti-GFR. Mind you, this was KRAS and BRAF by the coupon test, what the companies offer us free of charge. HER2 negative MSS, had an excellent response for about a year, had new liver lesions, got a second line FOLFIRI-Bev, and had another new liver lesion. So this time they said, okay, let's do NGS. And this was the NGS. Okay, let's take 10-15 seconds, each one of you, and go through this NGS. Something pops up, BRAF mutation, and there is a green color treatment written on there, cetuximab plus encorafenib. So I want all of you to tell me, are you tempted to act on this NGS report? We'll start with you, Raju.
Yeah, BRAF mutation is there, but here KRAS, along with that, KRAS mutation is also there.
But we were taught they are mutually exclusive.
Mutually exclusive.
We were wrongly taught. Or something is happening here.
Pressure.
Yeah, correct. So these are all subclonal alterations. These are not clonal mutations. Remember, we were taught correctly that clonally they have to be mutually exclusive. So when you see under the pressure of anti-GFR, so many KRASs, so many NRAS, all BRAF, that means these are all subclonal alterations, and one should not target these mutations and just go ahead with chemotherapy or bevacizumab, whatever is there. So it was an interesting learning point from this case. Okay, we have 6 more minutes, so 2 more cases. This is now pancreatic cancer. Middle-aged man, 54, metastatic pancreas, MSS, germline BRCA negative. This was from the, again, a coupon test. Germline BRCA is very cheap in coupon. We got excellent 6 months on FOLFIRINOX. Then we removed the oxaliplatin because of neuropathy. And within 2 months, the CA19-9 started rising and CT showed new liver lesion. Do you do NGS? Let me start from the right. Do you do NGS in your practice in pancreatic cancer? Yes, no.
With
Yeah, okay.
Okay, so with this availability of this days with KRAS inhibitor, yes.
How often do you see KRAS G12C?
Very less, sir. Less than
2 to 3%.
2 to 3%.
So what would you see in NGS in pancreatic cancer?
Sir, one would be MMR, but definitely
That
again,
we've done
it's
through
less than
IHC.
three. Yeah. Another is germline BRCA because
That we've done through
coupon.
coupon. We've done that. We've done germline BRCA, we've done MSS. Then what's the utility of NGS in pancreatic cancer?
TMB.
Okay. What about you?
TMB.
TMB. What about you, doctor?
Other than that, I think if you're taking any clinical trial, then
So do you send NGS in pancreatic cancer?
no, sir, not really.
No. So I was looking at one of the companies to see what are the number of prescriptions for pancreatic cancer in GI portfolio, and it was rank 1. Number 1. Number 1 indication for prescribing an NGS by Indian oncologist in GI cancers was pancreatic cancer.
What company was that?
Can't you see this report? Can you identify which company is this based on this report? Yeah, it's Guardant. So in the Guardant portfolio, the number 1 GI case for prescribing NGS is pancreatic cancer. And it's, it was not because we wanted to find something. It was because the doctors wanted to protect themselves that, okay, NGS लिख दिया और कुछ नहीं हो सकता अभी तुम्हारा. So it was an interesting learning. But having said that, we still get cases like this, KRAS G12C, and we have pills available, FDA approved, at least for colorectal cancer and lung cancer. One could consider using it. Another pancreatic cancer, young female, coupon germline negative, MSS, FOLFIRINOX, and an NGS showing BRCA1 somatic mutation. Rajesh, starting from you, how would you interpret this report? Germline BRCA negative, but somatic on liquid biopsy positive. So is this somatic or the coupon test missed?
No, I don't have much experience of discrepancy between coupon test and
coupon test was germline. This was on tumor.
There is germline and it's a tumor, so it could be somatic or germline.
Yeah, but the VAF of 52, does it discomfort you?
Yeah, so it looks like somatic. 52 is higher.
Higher. Pushpendra, what about you?
So basically, sir, in open sometimes they don't test it by MLP. So this 52% is very high web. It will give me some hint that I should check germline again, not with coupon.
Not with coupon. What about you, doctor?
I'd rather pay myself towards the NGS report rather than going towards the coupon. I would.
So would you then do maintenance olaparib?
Yes, I would.
If this was not germline, you do again the germline test and germline is negative, only somatic mutation. Would you still do olaparib in pancreatic cancer?
No, then
no. Okay. You want to add?
The implication of germline getting a germline BRCA might not be therapeutically relevant, but maybe definitely for familial and screening.
For pancreatic cancer, olaparib is only approved for germline, not somatic.
Sir, as we have read in breast and ovarian cancer also, BRCA is a very large gene. So I would agree with Pushpendra sir to go with MLPA.
MLPA. And that is negative then?
Then sir, the indication I think somatic there's no indication. So
in pancreatic cancer?
Somatic there is no indication, but in later line or some line,
this is first line. This is first line.
So in first line, obviously I will not give olaparib, but
you will not do maintenance.
In somatic, but in some
Okay.
later line I will.
Okay. So this was cholangiocarcinoma, 34 female young lady.
What else, sir? And then what did you get inside of?
No, we did not give olaparib. So we did a germline again in second lab. It was negative. A patient did not want to go to Myriad Diagnostics, which is the gold standard for germline testing. But another lab in India as well did not show germline positive. So we did not put the patient on olaparib maintenance.
If there were no financial constraints, would you have preferred a period over this?
100%.
So, sir, in this
Patient post multiple lines, for example, he progressed second line, third line. At any time, will you choose olaparib?
No, so even in ovarian cancer, olaparib has been retracted, right? In later line.
So somatic.
No, olaparib in later lines of ovarian cancer has been retracted, right? By FDA.
Yeah.
Yeah. So point is PARP inhibitors don't work late. Okay. The last 4 seconds, last case. So 34 female intrahepatic cholangiocarcinoma. Last 1 minute, only 1 minute. Intrahepatic cholangiocarcinoma. Okay. Your treatment of choice is GEMSIS plus IO. Okay. So do you do NGS on day 1 for intrahepatic cholangiocarcinoma?
I should be definitely, sir, should be there.
Why?
Because those who are driver mutated in the TOPAZ trial, they have least benefit from IO.
Okay. What about you?
We don't do, but I would rather.
You would do. You would as well? Yes. Okay. Very interesting. So in Topaz, like you said, patients who had driver mutation had a questionable benefit from addition of IO. But mind you, this was a post hoc analysis and it has not been proven. So the current standard has to be GEMSIS Durva, even though you have a driver mutation, until somebody comes and proves it that just like lung cancer, when you have driver, IOs don't work. It's not the case so far in intrahepatic cholangiocarcinoma. Okay.
So Oration was very good.
Huh?
So far, it's nothing good.
So far.
So far.
So far.
And the push for IO, addition of IO can be different, right, sir? Then in that case, like if they have driver mutated, we might not be too much strong to push them for IO.
I don't think so. That's the right inference, at least today. Okay, thank you so much, organizers, and I'll hand back the mic to you.
Thank you, sir. Thanks a lot. Please give a big hand.
Original Viraj, the point is the pediatric surgeon is available. We want that pediatric tumors to be explored. For the
Colorectal Thank you.
Our next speaker is Dr. Ankita Daya.
Yes,
Available. After this, we'll have just last molecular tumor board. Okay.
Take to the time, madam.
Good evening, everyone, and thank you to the organizing team for having us here and giving us this platform to speak. So the previous session, Dr. Viraj has very beautifully illustrated the role of NGS that we have right now in colorectal cancer. So we'll just go one step beyond and we'll try to understand how he can go beyond genomics and can incorporate transcriptomics and epigenomics to make better patient outcomes. So we know that there's a rising challenge of young onset of colorectal cancer in patients now. So it accounts for about 10 to 12% of all CRC cases globally. And by 2030, it is projected to represent around 11% of colon cancers and 23% of rectal cancers. And often the younger patients, they present at a very later stage with a more aggressive histology and risk factors that go beyond lifestyle, which mostly include germline predisposition, epigenetic changes, DNA repair pathway differences, metabolic differences as well. So CRC, when we talk about it, it is not just, it is, it has a lot of different molecular subtypes that we talk about.
Okay, so CRC, when we talk about, we look at the consensus molecular subtypes, CMS1, which is more towards the immune filtration, CMS2, which is more the canonical pathway, the Wnt pathway, the APC pathway, that is usually how it gets activated, and CMS3, which is more in the metabolic region, and lastly CMS4, which is, which is related to a more poor prognosis and stromal invasion. So there's a wide variety of molecular and genetic changes that mediate the colorectal carcinogenesis. And this heterogeneity is what leads to differential outcomes and differential prognosis as well. So we know that the first wave of precision oncology, when we talk about it, it was mostly driven by genomics and what we discussed here also in the last session. And we believe that the next wave of precision oncology would be driven by multi-omics, where we try to understand the genes at a very even more molecular level, not just the DNA level, but go beyond the DNA level. So by integrating these genomics, transcriptomics, and predictive modeling and dynamic tumor profiling, and with advancements in liquid biopsy, we feel that there would be a greater evolution of precision oncology. So when we talk about RNA-seq, we should not limit ourselves only to the fusions that we generally know of, but we should go beyond the fusions, the gene transcript expression levels, and the express sequence variants and splice variants to help us understand the tumor biology in a bit better way. So we at OneCell, our mission is to democratize precision oncology, and we are working towards that by making it more accessible and affordable. So one of the major multi-omic tests that we talk about is OncoIndex Prime Plus, which is a DNA, RNA, tissue, liquid normal match test with IHC-driven protein analysis. It's a multi-omics test that will perform a 360 molecular profiling of your tumor samples as well as your normal samples simultaneously from the same patient. So whatever results you get, it would be more acquainted and more patient-centric in nature. So this is a study that we have done, and it's still currently going on, where we have found that, when we try to combine liquid and tissue biopsy with a normal match, we get the detection rate up to 97.22%, unlike doing just a tissue biopsy, as Dr. Viraj also very nicely illustrated that in some of the cases, sometimes you would miss out on tissue, some things you would miss out on liquid. So a combinatorial approach, even for NSCLC, it's now NCCN recommended, a combinatorial approach is going to give you better information. Similarly, if you look at here, if we do fusions only on RNA versus only on DNA, they have limited, efficacy. But if you combine both, it improves clinically actionable fusion detection across all cancer indications and cancer types. So this is a case report that we have taken up. This is not ours, but we would be discussing some case studies also later on. So this was a 50-year-old patient with no previous history of cancer, with presented hematocesia and had a negative colonoscopy 4 years earlier. Then colonoscopy findings showed that it was a mid-transfer colon mass with 4 centimeter in length. Post-operative therapy for this patient was FOLFIRI plus bevacizumab for 4 months, and there was a complete response for this patient. However, given, later on after 4 months, this patient again recurred, and given the unusual pattern of this patient's disease progression and treatment response, there was a molecular profiling where was done on RNA, DNA, as well as a whole exome sequencing that was done for the patient. And it was found that the patient had a triple mutant genotype. Basically, APC, KRAS, TP53, all were mutated. And we know that the prognosis is influenced when there is a KRAS co-mutated with TP53. Now, ideally, this patient was again given FOLFIRI plus bevacizumab for another 4 months, but there was no response. There was a very subtle response to that. And when an RNA sequencing was done, it showed that there were features of CMS4 phenotype, which is basically related to worse prognosis. So it kind of tells you here that, bevacizumab did not work enough because bevacizumab is linked to, stromal invasion, and whereas FOLFIRI did show some response here because irinotecan is kind of, reverse of what bevacizumab works for when it is a CMS4 phenotype. So when we talk about colorectal cancer, there's a biomarker guided therapy. We usually go for RAS, pan-RAS test, where we try to look if it is RAS wild type or if it is MSI high or low, whether it's BRAF mutated, ERBB2, whether it's fusion positive, or whether there are any co-occurrence alterations. So in almost 20% of patients with young onset CRC, there is always a hereditary cancer syndrome, which is found as the underlying cause, which is why germline testing is very well important here. So if you do only a somatic testing, you miss the pathogenic variants, which are, which give, there's a lost opportunity for family cascade testing and prevention. So there was this study, a retrospective cross-section study that showed that the early onset CRC, they had a very different pattern of somatic mutations. There were more TP53 mutations in early onset CRC rather than average onset CRC. And the germline mutations were also more common in early onset CRC, which again substantiates that we should do germline testing upfront. And moving on, there was another study which observed that early onset tumors have a high tumor mutational burden and increased DNA repair features and mutational signatures, as well as increased copy number alteration and gene expressions, along with immune filtration. So that shows that, if you can go ahead with an upfront comprehensive analysis, if affordable, then that definitely helps the patient. This was another study which showed how transcriptional metabolic profiling is different in young onset colorectal cancer patients. So there was a difference in the metabolic profiles of young versus the older CRC population. The older CRC population had more of immune signatures compared to the ones which were early onset colorectal cancer patients. So this biology we feel could be explored in the future as new avenues for treatment in younger CRC population. So moving on to the case studies. So this is a case of a 41-year-old female who presented with multiple metastatic masses in the liver, was undergoing treatment for 5 years. Then histopathological examination showed liver lesions, confirmed colon adenocarcinoma metastasis and infiltration, and we did a liquid plus tissue biopsy for the person, for the said patient. So as we can see, this was a KRAS G13D mutated mutations, which shows that cetuximab, panitumumab upfront will not work for this patient. Then there was TP53 mutation. Along with that, SMAD and MAP3K mutations were also there, but surprisingly, those mutations were only found in the plasma ctDNA and not the tissue DNA. Along with that, at the tissue RNA level, we found an elevated expression of CD274, which is PDL1, which kind of correlated with the PDL1 positive that we saw on the IHC. So basically, since you have KRAS mutation and therapy resistance, we know that KRAS G13D will cause resistance to anti-EGFR therapy. So therefore, FOLFIRI plus Bevacizumab is the way to go. Then, of course, the co-mutation of TP53 contributes to, reduced response to monotherapies. That's why combination therapy will work better. The SMAD4 and MAP3K6 roles are that they actually cause enhanced chemo resistance. And since we have although PDL1 is usually high expression of PDL1 is generally not considered for immunotherapy for the patient, but here with TMB, along with TMB, it kind of supports immune checkpoint inhibitors can work. And if immunotherapy fails, then FOLFIRI plus Bevacizumab remains a strong subsequent line of treatment for this patient. This was a case study of 46-year-old female, second case study, which the patient was initially presented with the recurrent vomiting and loose motions. And the HP showed metastatic poorly differentiated signet ring cell mucinous adenocarcinoma, received 12 cycles of FOLFOX, and then had persistent ornamental and peritoneal thickening with ovarian lesions increased, and was given Tipanat and 2 cycles of Bevacizumab, then had mild reduction in masses. For this patient, when we did a combination therapy, I'll just take 5 minutes, TP53 and MUTYH mutations were detected. There were only 2 mutations. Now, MUTYH was a subclonal mutation. That means it was not present in all the cells. And this could be attributed to the treatment that the patient had undergone. So the treatment actually led to the evolution of this particular clone of MUTYH. And surprisingly, at the RNA level, we had a high expression of PIK3CA, FGFR, 1, 2, 3, KRAS, EGFR, PDL1, CTK12, mTOR, BRAF, and SRA genes. So what does it show? That this combined molecular profile of PIK3CA and all the other markers that we saw, it suggests an aggressive growth and a potential resistance to targeted agents. So in colon cancer, it is known that if there's an overexpression of EGFR, KRAS, and FGFR family members, there's a more aggressive tumor behavior and reduced responsiveness to specific targeted therapies and poorer patient outcomes. So last study that I would just take 2 minutes again. So this is again it's not a young patient, but it's a 62-year-old female who had a pancreatic head mass causing biliary obstruction and a sigmoid colon mass detected on colonoscopy. The key question was this a metastatic pancreatic cancer to colon or liver, or two separate primaries, pancreatic and colorectal cancer? So how a multi-omic test helped in here? So both the tissue was taken. Tissue 1 corresponded to pancreatic site, tissue 2 corresponded to colon site, and as you can see, KRAS G12V was detected in tissue 1 DNA, and KRAS G13D was detected in tissue 2 DNA. So this kind of supports towards their different sites. And additionally, the RNA expression of PDX1, SOX9, GATA6, etc. suggested that there was a lineage-specific transcriptional programs which suggest that there was a strong evidence of pancreatic adenocarcinoma, colorectal adenocarcinoma. So here it resolved the ambiguous presentation with precision, and we were able to distinguish clonally unrelated tumors versus a metastatic spread. To conclude, a comprehensive profiling for therapy, selection, and diagnosis and progression, we all know that's very important to identify the driver alteration, also to understand the inter and intratumoral and metastatic heterogeneity. We also need to understand the biomarkers, how they are responding, what is the resistance causing mechanism. That's also important along with the actionability. Also, when you're talking about a liquid biopsy, it is more preferable because it's a non-invasive procedure. However, a combination would always give you a better options. At the same time, we now should also understand that there is we need to assess the increase and decrease in ctDNA over time. So that could help in longitudinal monitoring and allow us to correlate the patient's disease status, and could help us understand the molecular minimal residual disease, which we usually look at. So biases should not determine our choice between tissue and liquid NGS. Personalized decision making has to be undertaken to distinguish between the best modality for a particular event given the patient's condition. So the choice has to depend upon the tumor biology, the tumor evolution, and the tumor heterogeneity. Thank you so much.
Thank you, ma'am. Thanks a lot. Good. Dr. Siddharth Srivastava, sir, please. Sir. So just you call them. This is the last session we're having, the molecular tumor board on breast cancer.
Dr. Mani Sharma. And the panelists, Dr. Priyanshu Tripathi, Dr. Prutha Jinwala, Dr. Mahima Kharbanda, Dr. Shakuntala Shah, and Dr. Sayari Shukwas. Panelists. Priyanshu Tripathi, Dr. Prutha Jinwala, Dr. Mahima Kharbanda, Dr. Shakuntala Shah, and Dr. Sayari Shukwas.
Hi, good evening. So I welcome all my panelists today. So we'll quickly move to the first case of the tumor board. So this is a case of hormone positive, HER2 negative metastatic breast cancer with multiple genomic alterations. So we'll discuss the impact on the first line therapies and how to prioritize the target and the role of liquid biopsy here. So this is first 40-year-old lady who was initially diagnosed with the disease T2N0 grade 2 disease, ERPR positive, HER2 negative. She underwent surgery followed by adjuvant chemotherapy and was on endocrine therapy. She later presented with the metastatic disease. Here we can see multiple liver lesions. So my first question would be to Dr. Mahima. Dr. Mahima, what will be the next step here? What will be your next step?
Ma'am, in a hormone positive metastatic disease, and we discussed irrespective of the vaccine and solutions, I would actually want to go ahead and see the process.
But would you like to do the repeat biopsy here?
Yeah, definitely, yes.
Yeah, so
Yes.
what will be your preference, a liquid biopsy or a tissue biopsy?
Tissue biopsy.
Tissue biopsy. So everybody is agreeing on that. So Dr. Prita, my question to you is, what is the role of liquid biopsy here? When do you consider the patients who present in such scenarios for liquid biopsies?
Now, since it's a metastatic, it has progressed and it's a metastatic disease, I would want to see if there are any new mutations that have developed. I would like to look at the ESR1, the PIK3CA, and again, if ESR1 is positive, then it sort of shows a resistance to our AIs. So in that case, I would want to combine my CDK4/6 with fulvestrant rather than AI. So that would be my choice for the.
Dr. Priyanshu, your version?
And even BRCA would be seen.
Yeah, so over a period of time, we see like 10 to 15% patient they do show change in the mutation. So it's possible that initially she was ER positive and HER2 negative. It's possible that we don't see such pattern in the new biopsy. That's why biopsy is very necessary. And since recurrences occurred after I think 10 years, so a repeat biopsy is definitely man.
So, Dr. Shakuntala, ma'am, I want to ask you, do you see the patients with liquid biopsies, or do you offer liquid biopsies to some of your patients? What if the patient has denied for the tissue biopsies? The patient
No.
is not willing.
Usually the treatment modalities are as per the tissue diagnosis. Do the tissue biopsy.
Dr. Priyanshu, your opinion? Suppose the patient is not willing for the tissue biopsies. Would you go give the opinion of liquid biopsies to such patients in metastatic settings?
No.
Not really. What about the recurrent disease? Suppose the patient had breast cancer metastatic disease and now it has progressed. What about that? And then the patient is if the site is not biopsyable, or the patient is not willing for the biopsies.
Maybe liquid biopsy has a role, but it will not change my first line of management. As per NCCN and ESMO guideline, I think CDK4 inhibitor.
No, I'm not talking about the first line. I'm talking about the second later lines of therapies. The patient who has progressed on CDK4/6 inhibitors after that.
Liquid biopsy will help me choose my second for the subsequent line of management, but it won't change my first line.
Of course, I agree with you. So the liquid biopsy here for the patient showed these ESR1 and the PIK3 mutations. So we have already discussed the first line here. Suppose the patient now has progressed on the first line of therapies. We did the liquid biopsies. The NGS panel shows the PIK3CA mutations and the ESR1 mutation now here. So what will be your choice of treatment now?
The patient has progressed on a CDK4/6 and has progressed on and first that's the question. So now this time I would want to add targeted targets for the this time. And obviously again if since it has progressed again a fresh biopsy depending on the duration the DFI. The DFI is strong enough, then I want to feed another tissue analysis and then.
So in our clinical practice, we come into this scenario comes into picture that we see multiple molecular alterations. So how do you prioritize your treatment in later lines when there are multiple molecular alterations that are seen? What all things do you keep in mind, Dr. Pritha?
So essentially, we need to find out what is the driving mutation that has. ESR1 and XCCA both are positive. So essentially, there is a resistance to the first the hormone. So I would like to use the second line like the newer search, which is the elacestrant. And since PIK3CA is possible, it gives us an opportunity to use a targeted therapy also. So a combination of that plus alpelisib. And again, if and when the patient progresses, a re-investigation, a new biopsy, and again to look, all these are dynamic mutations. So we would want to, if and when the patient progresses, we would like to decide based on the latest results that are available.
Right. So as we have discussed already, the first line CDK4/6 inhibitors with the endocrine therapies, the preferred modalities. But in the subsequent therapies, we have these options for PIK3CA, CSR1, all these things are targetable. Even the germline BRCA mutations will be targetable here. So this slide I've kept just to show that the ESR detection by the liquid biopsy might show the more option for the patients. And even so, with the Solar 1 trial, we have the options for the PIK3CA mutation. To catch this mutation in the liquid biopsy also is equally sensitive. So now we are coming up with the combination strategies. So though this is just a phase 1 trial of the novel certs with the combinations, but in the upcoming years, we will have the combination strategies as well. So let us move to the next case, metastatic triple negative breast cancer with somatic BRCA mutations. So we'll be discussing the somatic versus germline alterations, the tumor-based NGS guiding the genetic referrals, and the data from the single-arm basket studies. So this 35-year-old female with a significant family history of breast cancer presented a year after delivery with a 4-centimeter left breast lesion, clinically node negative. Biopsy showed the IDCs with grade 3 triple negative breast cancer. The staging showed no metastasis, started on neoadjuvant chemotherapies, and relapsed after the 18 months of last chemotherapy with 3 lung nodules. Biopsy was done, it showed the triple negative, PD-L1 was not tested. What will be your next step, Dr. Pratha?
So it's a TNBC grade 3 and PD-L1. And the first thing that I would be testing for is PD-L1. And you mentioned that germline BRCA was negative, correct?
Right.
Somatic was positive. So as of now, there are no therapeutic implications for somatic BRCA. But if PD-L1 is positive, then in that case, we can offer the patient with a chemoimmuno option with pembrolizumab.
So likewise, a patient at another institute underwent lung surgery followed by gemcitabine carbo with pembrolizumab, had a partial response. Later on progressed with the frontal lobe lesion for which resection followed by SRS was done. He went on to receive subsequent lines of therapies with capecitabine and eribulin. And later on, when the patient progressed, we did the CGP on the resected brain lesion. And this was what the report showed us. So, Dr. Mahima, do you want to throw some light on what you see here in the NGS?
Yeah, so the this thing was done on the tissue. And
this was done on tissue.
So again, BRCA1 is this is the somatic result, 54%. And as it is saying that BRCA1 mutation tested again, not found in germline. So here, I would want to do BRCA testing by NLP.
So you would want to repeat the germline BRCA because the patient has a significant family history and has a somatic BRCA positive. So you want to repeat it. Yeah, justified. So I want to ask about the VAF here, Dr. Shakuntala ma'am. How do you interpret the VAF, and do you base your treatment based on the Dr. Priyanshu, I think you can take this question. So this VAF of BRC of 54% or VAF of TP53 of 73%, how do you interpret the VAF, and do you base your treatment based on how much VAF the particular genomic alteration is showing?
So I'm a radiation oncologist, so I'm the right person to answer this question.
So if you are taking a tissue, right, you have to be very mindful that when you take the tissue, you will have normal cells also and cancer cells.
Heterogeneity, yes.
So it is not blood that 50% has in tissue is very different. How much you have taken, how many cancer cells are there, that will change the task.
Absolutely. So, sir, and what about in the liquid biopsy, sir? When we have this VAF, like in the previous report?
In liquid biopsy, the rule of thumb should be, if you are seeing a mutation, that means that mutation exists in the tumor. If you are not seeing it, you cannot say that it won't be there. There are too many things that cloud the liquid biopsy data. One of the biggest thing is if you imagine like that, the DNA that comes out of the tumor cells, right? And in the 5 liters of peripheral blood, they are only taking 5 to 10 in them. So it's a very small snapshot. It has to be taken with a lot of caution.
Absolutely. So if we have a positive report in the liquid biopsy, we can consider it as positive, but a negative doesn't mean that it is not there. That is very important. And similarly for VAF, sometimes we can over-interpret VAF. It is very nuanced to interpret VAF. We have to be a little cautious about it. So the patient has progressed on multiple lines of therapy. We did the germline BRCA testing again. Again, it came out to be negative. Dr. Pratha, I would ask you now, what will be your next line? So she had a somatic BRCA mutation positive, but the germline is negative. But it has progressed on multiple lines.
Since it is negative, I would still be compelled to choose only from my limited options of the chemotherapies which are available. And immunotherapy, again, I have exhausted. So that also I cannot use. What was the HER2? Was it?
It was triple negative tumor.
So 0 or was it?
It was zero, not HER2 low.
Okay. So in that case, we can go to sacituzumab or if the patient is not affordable because that is a drug which we are importing as of now. So in that case, I believe eribulin has also been used.
It was used, yes.
So sacituzumab is the only thing that we are left with.
Dr. Mahima?
Sacituzumab or maybe HER2 0 ultra low.
Okay. That is what I was coming on. That we have the phase 2 data here for the olaparib also. So it is extrapolated like with the HRDs here. We had the genomic loss of heterozygosities. LOH was high. So we have some data of the use of olaparib which had shown a good response here. But of course, we don't have the phase 3 studies recommendation yet. But post multiple lines, I think that can be considered. Coming to the next case quickly, 39-year-old right breast cancer patient, ERPR positive, HER2 negative, diagnosed in 2016, T2N1, M0 disease, germline BRCA mutated. With she underwent bilateral mastectomy followed by adjuvant chemo and radiation. Because of germline BRCA mutation, she underwent TH-BSO and was on aromatase inhibitor since then. And she presented in November 24 with the complaints of chest pain and back pain. That time MRI was done and it showed a T2 pathological fracture and the PET CT showed the T2 lesion and liver lesion. So bone biopsy was done, which came out to be inconclusive, which is a common scenario. Most of the times with the bone biopsies, we find it difficult to interpret. So Dr. Mahima, what will be your next step?
I will do the biopsy from the next session.
Dr. Priyanshu?
From my point of view, there is a T2 fracture, so I will address that first. So I will see whether there is a impending cord compression or not. How is the GC of the patient, and whether this needs stabilization. If there is pain, then upfront palliative or SPRT. If there is no pain, then definitely I'll ask orthopedic surgeon for the stabilization first. This is the urgency, and then I will proceed with the.
After that, what will you do?
Then yes,
After
stabilization. First of all, I would just like to know if the patient is oligometastatic or it's
So there was a single T2 lesion and there was two liver
biopsy needs to be done. I need biopsy. And then
So when the patient is taken up for the stabilization at that time,
we can take the biopsy.
An adequate biopsy, bone biopsy.
I think that was when the biopsy was taken and it came out to be inconclusive at the time of stabilization. So liver biopsy was performed, showed the metastatic cancer from breast and ER positive, PR negative, HER2 2+, FISH negative, which will come in the HER2 low now. And the tissue was sent for the comprehensive genomic profile. So, Dr. Mahima, this is the CGP report with the genomic LOH showing high, BRCA2 mutation is positive, PIK3CA is positive here, microsatellite is stable, and TMB is 12. How do you interpret this report? I think we are running short of time now.
BRCA2 is 16, victory back 30. So I would, in this case particularly, and BRCA can be considered the driver mutation here, I would want the biology.
Okay, so we have the options here for the later lines of therapies. We can have the combination therapies where we have too many targetable mutations here to target.
Nothing used CDK4/6.
So that is what CDK4/6 inhibitors was not used initially and was started on later on. But these are the options for the later lines of therapies. Yeah.
So was that a single metastatic lesion in the liver?
No, there were two lesions in the liver. There were one lesion in the bone. So
The bone was ruled out.
yeah. No, bone lesion was not ruled out. It came out to be inconclusive, but it looked the pathological fracture and everything favored the. But again, it is coming in the oligometastatic disease. So the intention of treatment, again, next question would be to.
We are able to do SBRT to the liver lesions, both the liver lesions. And since we've already taken care of the solitary bone lesion, so and there is no local recurrence. So in that case, we can go ahead with the curative intent if we are taking care of all the disease.
Dr. Priyanshu, your opinion.
Yes, it can be.
So what will be your treatment line there?
Definitely SBRT to the liver lesion should be done. So the total biological equivalent goes up to 100 gray.
Okay.
Maybe 50-60 gray in alternate fractionation 3 to 5. And yes, definitely it will fall under oligometastatic. So I will not call patient upfront value.
So what after the radiation? What after you have completed your?
What I see here is BRCA2 and TMD, both of them actually show the genomic instability. That means, BRCA2 being mutated, that means original DNA breaks are not getting repaired. So a lot of mutations will be accumulated, which is reflected in TMD 12 and 11.
Yes.
And if there is a lot of genomic instability, the tumor may, respond to immunotherapy. That's what it looks like.
So the genomic LOH is what is correlating with the BRCA2 biology. Because of the BRCA2, there is more scarring, and because of this, we are seeing the genomic loss of heterozygosity here. That is correctly pointed out by you, sir. So, okay, then after radiation, Dr. Putta?
I will still go ahead with olaparib. Because evidence point of view that is a more explainable.
You would not like to use CDK4/6 inhibitors if they were not used?
I asked you that. Have we already? We've not exhausted it, right?
No, if we are talking upfront, that was used in this case. It was
Initially, we had used only the AI. Yes. So in that case, my first line would still be CDK4/6. And only after that would I, because there is still no data of using CDK4/6 along with olaparib.
What about HER2 positive? Like
HER2 plus fish is negative. So when you are treating it with the curative intent, would you like to use CTXT then in that case? No, in that case, I don't think so. Yeah. So we have to be clear about our intention of treatment. We are treating it as oligometastatic with the curative intent initially. So based on that, we have to plan our further treatment. What if the patient presented with the metastatic disease with multiple liver lesions upfront?
Now, even still, I would use CDK4/6 first. Only and if the patient progresses on that, then the next thing I'll consider is olaparib. And after that, I'll probably go ahead with HER2 low and TDXT. So that would be my sequence. And after that, chemo.
Dr. Mahima, I want to ask you, for your metastatic breast cancer patients upfront, are you doing NGS regularly? Upfront metastatic patients?
Upfront metastatic, no.
No.
Once it progresses on the first line NBC, then we go ahead with the.
And what is your choice then? Liquid biopsies or tissue or both?
Both.
Both. So now we have too many options for the later lines, of course, not for the first line that we were discussing about, but in the later lines, when we do the liquid biopsies and the NGS upfront, we may have the options ready for us. And later on also, when we do the liquid biopsies or the NGS on the tissue, we may have the options of combination. Now we have the combination therapies for PIK3CA mutated With the INAVO study, we have the combination of inavolisib with the palbociclib and fulvestrant, which has shown the PFS improvement. If we have not used it upfront, in the later lines also, we have the capivasertib with the fulvestrant combination for the AKT pathway alterations, which has again shown a PFS benefit. Like we have discussed with the TDXD for chemo-naive patients, now with the Destiny Breast 06, we have the PFS advantage of using it in the HER2 low and ultra low after the endocrine-based therapies. So this I'll end my slide here. I'll thank my panelists for this.
Thank you, ma'am. Thank you, all panelists. Photo. Most important thing. Photos. जल्दी वो ओवरी से इनटू ओवरेज में आने वाली है।
Yes, sir. Sir, बिल्कुल.
बस बहुत जल्दी मतलब मैच आने वाले हैं।
Yes, sir. Wait, sir. नहीं ऐसा बताओ नाम बताओ। ये लास्ट वाला बोलो तो नहीं कौन सा करना है?
सबसे
ऑलरेडी ओपन
बस ये लास्ट है, इसको लगा के छोड़ दो।
So, good evening, everyone. Now we'll start with the inauguration ceremony. So, first, I would like to welcome Dr. Bhavesh Parekh, sir, organizing chairman TYAcon 2025, for the welcome speech. Kindly give a big hand to Dr. Bhavesh Parekh, sir.
Good evening, everyone. चितलकर सर, can we start? Yes. रुथा मैडम, आपको कहीं नहीं जाना है, पहले बैठो, 5 मिनट बैठो, बड़ौदा ही जाना है। हम सब लोगों को तो यूएसए का वीजा है।
तारीफ है सर अभी
वो तारीफ अभी कल मीटिंग होने वाली है, तारीफ सुलटाने वाले हैं। So 14th TYAcon. yes. आप सर मुझे हर बार क्रिकेट मैच से ही पहचानते हो, कहीं ना भी अहमदाबाद में क्रिकेट मैच होता है तो भावेश तेरी टिकट आ गई कि नहीं, या मेरे पास टिकट कब आएगी। Thanks for that comment also for me. As a organizing chairman of 14th TYAcon 2025, I welcome all of and our inaugural functions. I am inviting on the dais, first of all, Dr. Hemant Malhotra sir, President TYAcon Foundation, Senior Most Medical Oncologist, Jaipur. Sir, please. I am welcome Dr. Sasank Pandya sir, GCRI Director. We all are because of GCRI, and along with Dr. Pankaj Shah. Please, sir. Pankaj Shah is godfather of all of us. Pankaj Sai is also only one Padma Shri award winner. So, sir, we are really grateful to you. તમે અમારા બધાની વચ્ચે છો એ અમારો ખરેખર સદભાગ્ય છે. સાહેબના આશીર્વાદ જો કોઈને મળી જાય ને, સાહેબ બોલા એક અમારા જૈન મહારાજ હતા ને એ પાછળ ખભા ઉપર હાથ મૂકે એટલે સાહેબ હજી જીસીઆરઆઈ ના રાઉન્ડમાં એક દર્દીના ખભા ઉપર હાથ મૂકે ને દર્દી સારો થઈ જાય. એમ આપણે બધા લોકો યસ સર, યસ સર. I am inviting Dr. Prakash Chitalkar sir. हेमंत सर बोले और सर मैं ना बुलाऊं सर, मेरी कोई औकात नहीं है सर. Prakash Chitalkar sir is real backbone of this TYAcon Foundation. सर मैं आपका रियल शुक्रगुजार हूं कि आपने मेरे को ये कॉन्फ्रेंस ऑर्गेनाइज करने का एक मौका दिया. बहुत छोटा आदमी था लेकिन आपने जो मेरे पे ट्रस्ट रखा, especially with the help of Sasank Pandya and Pankaj Shah. Without GCRI auditorium or survivor workshop and without this venue, I am really zero. So with આ બે એકા, એક કાળીનો છે અને એક ચોરકટનો છે, અને એ બે એકાથી મારા જેવો ગુલામ કદાચ પત્તીમાં જીતી જાય છે. I also welcome Archan Trivedi, one of the very good, એનું હમણાં જ પિક્ચર નાન ખટાઈ રિલીઝ થયું છે. કોઈને નાન ખટાઈ એટલે કદાચ ખબર નહીં હોય, પણ નાન ખટાઈ એ બહુ જ સારી ગુજરાતી મીઠાઈ છે. અર્ચન ત્રિવેદી એ એક સર્વાઈવર છે. આ એક સર્વાઈવર આપણા સ્ટેજ ઉપર કે આપણા ઓડિયન્સમાં આ બધા ડોક્ટરોની હાજરીમાં છે. ખરેખર તો અમે બધાએ કદાચ પંકજભાઈ સાહેબે અર્ચનને હસતો કર્યો, પણ અર્ચન અત્યારે બધાને હસતા રાખે છે. અને હજી પણ અમે બધા જે અત્યારે આજે આ ઇનોગ્યુરલ ફંક્શનમાં સાહેબ તમે ખરેખર પહેલા ભરત પરીખે ના પાડી હતી, અથવા તમે બોમ્બે હતા અને તમે એક જ 2 દિવસમાં જવાબ આપ્યો કે ના હવે હું આવી જવાનો છું પાછો. અને અમને એટલું બધું આનંદ થયો. ભરત પરીખ હોત તો વધારે આનંદ થાત, પણ આજે એના મમ્મીનું શ્રાદ્ધ હતું અને એમના ઘરે જમવાના હતા. જેમ કે પંકજભાઈએ બી છેલ્લી ઘડી એવું કહ્યું કે પ્રવીણાબેન નથી આવતા, એટલીસ્ટ ચિતલકર સર અને મારા બંનેના વાઇફ અહીંયા હાજર છે, એટલે તમે કદાચ આ બધાની ખોટ પૂરી કરશો. સાહેબ પીકે લેરી સાહેબ ઉપર મીટિંગમાં છે, આવવાના છે પીકે લેરી સાહેબ? પીકે લેરી સાહેબને ફોન કર્યા છે, ઉપર જ છે સાહેબ ઇન્ટરવ્યુ. અનિલ નાયક સર જે આઈએમએ ના પ્રેસિડેન્ટ છે એ ઓન ધ વે છે, એ પણ હમણાં પહોંચી રહ્યા છે. ખરેખર તો આવું ટીનેજ એન્ડ યંગ એડોલસન્ટ અથવા આવી કોન્ફરન્સ કરવી, અને આ બધી જ કોન્ફરન્સમાં આપણે બધાએ ભાગ લીધો. હું ખરેખર દિલથી બધાનું સત્કાર કરું છું, બધાને વેલકમ કરું છું. અને આપણે પહેલા લેમ્પ લાઇટિંગ કરીશું અને પછી આપણે બધાનું થોડીક સુવચનો સાંભળીશું. અર્ચન ત્રિવેદી તો કદાચ ઘણું બધું કહેશે અને અમે સાહેબ તમને ફૂલ ટાઈમ આપીશું. કદાચ કાલ સવારે 6 વાગ્યા સુધી ડાયરો ચાલશે તો વાંધો નહીં આવે. Yes, over to lamp lighting, please.
A little bit. Some light on what you said.
Absolutely, sir. मैं कहीं ना कहीं पे गुजराती में बोल गया, तो सर का ये मानना है कि एटलीस्ट पुट सम लाइट्स, सर, on like teenage and young adolescent is a topic where also we discuss in executive committee meeting. I think if we create awareness, and that's what Pankaj bhai also telling me during my residency, that we all oncologists should encourage people to have more and more insight of new things. And today again, with your blessing or with your scientific program all discussion, we had a wonderful sessions and we had a wonderful discussion also. And might be in the future also, we are doing this TYAcon on a more and more longer basis, and people are more and more interested in such type of activity. So first of all, to lamp lighting, followed by our whole inaugural function. Please, डायस जो भी मेहमान गेस्ट है वो सब लोग लैंप लाइटिंग के लिए. Sorry, I missed Hemant Megnani. Please, sir. He is the organizing secretary. Please, Hemant.
Thank you, Bhavesh Parekh sir. So at the end we realized we are in Gujarat. Bhavesh Parekh sir की speech के बाद, है ना? So I will request Padma Shri awardee Dr. Pankaj Shah sir to have a few words. बैठ जाइए सर.
Good evening, everyone. First of all, I welcome the whole team of young oncologists and the young cancer patients conference. Particularly, I'm very happy that Prakash is doing this for last so many years, and he has converted into a movement. Hemant is also our base. Along with me, my colleague, Dr. Shashank Bhai. Anil Bhai, please. Please. Have a listen conference in the conference hall of NGO is something which is not very known to all of us. Go having conference in the 5-star setup, go there, come back. This is your home, Sarvichar Parivar. It is a family where all of you are here. Is our special guest. And I'm very thankful to the organizer to select this center as a venue for the conference. Now, I would like to talk about how this conference hall is created. With whose help, whose good devotion. And Bhavesh has told me, Bhavesh has conveyed lots of things, but he is just like Hanuman to me. When I joined this Sarvichar Parivar, this was all deserted place. There was nothing. So, being a senior oncologist, it is always a privilege to order something to your own colleagues and friends. So, part of a director and medical oncologist and that little bit inclination for academics. I requested that all the meetings for our medical oncology we will have at a Sarvichar Parivar. And this is how, and the main person behind this, all my effort from that day onwards for last 15 years is Dr. Boris. When we are sitting here, the money which we got from the pharma support, it was compulsory for them to say something, to say money for the Sarvichar Parivar. And this is how the small hall was created, where we were used to get about 15, 20, 30 oncologists every month. Incas and other people they used to support. I openly acknowledge support by Incas, particularly Manoj and his team, for all throughout. And this is how you are in a house, not in the hotel. And your dining area is our new addition to the social service. And this is for the bedridden senior citizen. Those who are staying in a small house, but when the senior citizens get infection or hemophilia, they require about 6 to 8 weeks to recover. So we have kept that 40 bedded indoor rehab center for senior citizens over there. Now comes to the oncology aspect of the young cancer patient. And the young cancer patient always is a patient where you have to not try everything because they are in the beginning of their life. The example here is my archer. He was hardly 16, 70 years when he had a lymphoma. He came out of it. And almost any, apart from the leukemia and lymphoma, we see many solid tumors in young people. In the last 3 months, we had about 3 breast cancer patients below the age of 25 with a very aggressive disease, bilateral disease with mastitis and all those things. And there is a dynamic change in their behavior also. So Prakash, I congratulate you to pick up this particular topic on a national level. It is the need of a day. If a cancer patient with my age comes, I give you option. Then you decide what you want to do. But when somebody who is 20, 25, 18, 16, even up to 30, you will have to save them. And for that, this type of interactions are very important. And I feel that this is going to be a major cancer issue when we are lots of diagnostic tools. We come across lots of issues for which we don't have answer. All of these things we were talking about the molecular test, and I call them a horoscope of a cancer. All these molecular tests are like a horoscope. But all horoscope does not match each other. And still, we have to fight with those patients. And they require maximum support from whatever setup they are having and taking with them. And nowadays, somebody was talking from Assam that because of the this PMJ and all those government policies, they are very comfortable with quick tests. And now, at least we have a responsibility to see that what government is spending, how much we can give back to the society. So every center who is using this PMJ and treating patients, and they are coming out of it, we must have every year data. There are so many cases of leukemia treated by PMJ, or so many cases of breast treated by PMJ, particularly young. And this is what the result is. So and all the platform, whenever I have to talk to government people, I tell my director, I ask him, okay, let us find out what is the outcome of the efforts put up by our tax to the people of our country. That it was our commitment to come out with the data. The government has given 5 lakhs, 10 lakhs, the society has given another money, and this is what the result we can achieve. If we support the patient emotionally and economically, probably we can get the best out of it. And what Dr. Banawi told us in the body. So Assam lady was talking about that she is going there to the house of the patient. So there is the community called oncology community has become very large, and we are very sensitive to help our patients. This is the only disease which gives time before death. And within that time, you support patient in a very nice way. And in a scientific way, probably we go on increasing the responsibility. Thank you very much. Again, Prakash, it is worth listening to the President of Indian Medical Association. I am one of his fans. Whenever he talks with sense. He does not talk anything else but the interest of our medical community. So thank you very much again to be with us. Thank you. my joint organization. Thank you, Arshan. Arshan has made lots of anti-cancer and the tobacco awareness videos for us. मार खाए झगड़ो, मार खाए भगड़ो. You also said he has done immediately after he got considered cured, and once he got cured, he was adopted by the society. People try to give money to him, to us, and he came out of it. And when he got his first check from the performance, he gave it to us. Cancer Society got. At that time, the adoption program was 20,000, 15,000 rupees for one child. If you give 15,000 rupees, being a director, I will try to find out money from the grant and other thing and help the patient. So he was patient adopted, and he started adopting patient once he has been declared cured. So he's one of the special ways for us. That is, we have taken initiative, and then whatever there are few things I have asked, what about my toilets and what other things and cleanliness. Please bear with us. After all, this is an NGO, and we try to give you the best. Thank you. Thank you.
Thank you, sir. Thanks a lot. I will request Dr. Anil Naik, sir, to give a shawl to Dr. Pankaj Shah.
અરે ને આપવાની મારો સ્ટુડન્ટ અમારું ઘર છે this પરિવાર.
I will request Chitalka sir to give a shawl to Shashank Pandya sir.
શશાંક પંડ્યા સાહેબની તબિયત ખરાબ હતી છતાંય આવ્યા. થેન્ક યુ વેરી મચ. એમને ખરેખર વાયરલ ફીવર હતો, શરદી ઉધરસ છે. એમને રિક્વેસ્ટ કરી છે કે હું સ્પીચ નહીં આપું. સાહેબ બે લીટીમાં જો થેન્ક યુ બોલી શકાતું હોય.
ભાવેશભાઈનો પ્રેમ એટલો છે ને કે આવવું જ પડે. અને સાહેબ બંને માટે જ્યાં પણ ગયા ત્યાં મતલબ first of all, I would like to congratulate organizing committee for arranging this conference and involve GCRI for this conference. At GCRI, if I share data of last year we have treated 25,956 new patients. Except Manipur, Meghalaya, Sikkim and Ladakh, we have treated patients all states of the country. At GCRI, 34% of patients are coming out of Gujarat. 34% of patients. From Maharashtra, according to the last year data, we have treated 4,338 new patients from the MP, new cases in the year of 2024. If you see the data from UP, we have treated 1,043 patients, new patients. So average 2 to 3 patients from UP are coming at GCRI, and that shows their confidence in the team of the GCRI. From Bihar, we get new patients, 265 in the last year, new cases. So that shows trust of the people of across the country on the team GCRI. As sir has said that through PMJ, that is flagship scheme of our honorable PM, majority of patients are getting treatment under free treatment under PMJ Yojana. For pediatric patients or patients of Gujarat, they are getting free treatment. Even bone marrow transplant, we are doing free of cost under School Health Program. Out of Gujarat, many patients, majority of patients are covered under either one or another scheme like PMJ scheme. I would like to share one thing also. Before 1 week, Minister of Education, Government of India declared NIF ranking. In medical category, for last 4 years, we are in first 50. This year also, our rank is 44 in medical category across the country, and BJMC was on 45th. So at GCRA also, we have increased our capacity for BMT from 4 bed to 11 bed. So we can do more and more BMT, and patients should not wait. So as a team, we are doing lot of we are always, our team is trying to cater services to the more and more patients, and we are running 3 satellite centers across the state at Chitpur, Rajkot, and Bhavnagar. And next year we will start another 4 centers: Porbandar, Valsad, Godhra, and Himmatnagar. So our team is constantly doing work, and they are trying to give care to the cancer patients. Thank you for inviting me. Thank you.
Thank you, sir. Thanks a lot. Now I'd like to request Dr. Prakash Italkar, sir, Vice President and Convener, TYAcon 25, to have a few words.
Thank you, Ahmedabad. Thank you, Gujarat. And thank you, Dr. Pankaj, sir. And thank you, Bhavesh bhai. Today is Saturday and Maharashtra में हनुमान का दिन होता है. और I think rest of it, I don't know, गुजरात में कब होता है? आज ही होता है? So Ram और हनुमान का रिश्ता. So that's one of the things that I say when I talk about leukemia counseling. कि अगर राम और हनुमान का रिश्ता रखोगे तो आप ठीक हो जाओगे AML की वजह से. So एक राम और हनुमान का रिश्ता मैंने यहाँ भी देखा. That is Dr. Pankaj and Bhavesh bhai. They're like Ram and Hanuman, and there's no Ram के काज सारे करता है हनुमान. तो here, and plus this work is of course Ram का what we are trying to do in TYAcon, going from state to state to state to state. It's there's always a debate. Oh, we should do all the TYAcons in Indore. You know, it is our own place. So no, we should go from place to place so that we learn. Firstly, it's a transcultural movement. A young adult movement is a transcultural movement because India is transcultural. And every 7th Indian is a young person who will get cancer. Every 7th patient who gets cancer in 2025 is going to be in that age group of 15 to 30. So we have to reach him. That you cannot reach unless we, health educationists, cancer educationists, we create a dialogue between different cultures. I think that was the reason why we move from place to place. It is obviously a big challenge, and we always need friends in different places. And besides being medical oncologist, besides being part of the community since 1990, one more thing that I always have comes to me a little naturally is that I'm a little bit of a chronicler. एक इतिहास में जमा करके रखता हूँ और अपने peers को भी बोलता हूँ, अपने friends को भी और अपने students को भी. और अपने oncology movement का इतिहास है. That is also part of my daily conversation with my students and so on. So this is also, we know Dr. Pankaj since 1990 and Dr. Bhavesh also since 2001 and so on. Dr. Hemant has been, we've actually traveled in a railway engine between Lonavala and Thane in August of 1990 when there was no trains running. Dr. Hemant and me requested the railway that we got to do a night duty in Tata Memorial, so please take us to Bombay. And so Lonavala to Thane, we actually traveled in a railway engine. So so those are the history, and so thank you very much, Sadvichar Parivar, GCRI, Ahmedabad and Gujarat. And I think they've been a wonderful scientific program which Bhavesh and team had put together. It's been a grand success. Plenty of issues related to AYAs have been discussed, plenty of data. And the matter of greatest pride is that so many of the alumni of our institutions, Sri Aurobindo Institute of Medical Sciences, where Dr. Runu, Dr. Prutha, Dr. Mahima, Dr. Hemendra Mishra, all of them, and Dr. Prashant Kumbaj, all of them graduated DM Medical Oncology from our institute, and they were part of the scientific program over here. So thank you very much. And please keep young people in your mind always, because I think it's a game changer. It's a low hanging fruit and also the ultimate frontier in medicine. Medical oncology is ultimately a branch of medicine. It's a healing art, and one must know how to relate to a young person, because if our country takes care of young people, then the future is bright. Thank you very much.
Thank you, sir. Thanks a lot. I will request Dr. Pankaj Shah, sir, to give a shawl to Dr. Prakash. Moving on, next we have a presidential address by Dr. Hemant Malhotra, sir.
Thank you very much. Dignitaries on the dais and dignitaries off the dais. There's at least one of my teachers on the dais, Dr. Pankaj Bhai, and several of my teachers in the audience. Kurkure, Dr. Banavle, Dr. Naman, और जो फैकल्टी इस TYAcon 14 TYAcon में दूर दूर से आए हैं, देश के विभिन्न भागों से आए, उन सबको धन्यवाद. And of course, many thanks to our local organizers, particularly Dr. Pankaj Bhai and Dr. Bhavesh Bhai for organizing a really good conference, taking care of us. And for this auditorium, even though it may lack the finesse of a room or a hall in a 5-star, the warmth which is there is not there anywhere else. So that's Pankaj Bhai. Many thanks for selecting this particular place where you can feel the seva in the air. Dignitaries on the dais, chief of the GCRI, which is one of the highest volume cancer centers in the country, chief of the Ahmedabad IMA. National our cancer survivor, the very reason why all of us are here, the very reason why all of us do these conferences and keep updating ourselves. My co-first name, Dr. Hemant, and of course, my very dear friend Prakash. And I very distinctly remember that ride in the train engine. We were stuck in Lonavala. It was raining like nobody's business. And there was this engine ready to go to Bombay. So I didn't even think that they could, you could take a lift in a railway engine. When Prakash went and said, "I'm Colonel Hu," and this and that, he hitched us a ride, and we got back safe home in time for our duties at Tata Hospital. So we go back a long time, and I remember those days, 30 years back, 35 years back, when I started oncology. Quite a few of you were not born at that time. I was there in Tata from 89 to 91. And that time, after I finished my training, I went back to my state in Rajasthan, आपका जो पड़ोसी राज्य है वहाँ पे. And I used to be really envious of Gujarat. The very fact that every single childhood cancer patient was treated free, and I would get patients of ALL, and I knew that I could cure about 3/4 of those patients. And I couldn't do anything. They didn't have money to even buy vincristine. They didn't have money or the support for blood transfusions, platelet transfusions. I mean, they used to just die in my ward. And I cannot convey to you the frustration which I felt. So you guys, the young people, you live in privileged times where there is so much state support, there is so much government support that at least lymphomas, leukemias, maybe you won't get a 3rd generation monoclonal antibodies or you won't get CAR T cells, but at least rituximab, trastuzumab, basic treatment for acute lymphoblastic leukemia, treatment for Hodgkin's, treatment for DLBCL, adjuvant treatment for so many solid tumors that is available to you and that you can offer to every single patient. I remember I used to be really envious of Gujarat. And several times I met my ministers and my chief ministers कि आप राजस्थान में ऐसा क्यों नहीं कर सकते हो कि सिर्फ बच्चों के कैंसर वालों को हमको मेडिसिन फ्री दे दो बट it work. I don't know how you managed to do it in Gujarat. Also remember very fondly coming to GCRI in 1992, where Dr. Pankaj Bhai had done the first meeting of the Indian Society of Medical and Pediatric Oncology. हम लोग उस टाइम पे टाटा में रेजिडेंट थे और बड़े शौक से ट्रेन में बैठ के आए थे पेपर प्रेजेंट किया था So it's been a long journey and it's been a fascinating journey to see the improvement in cancer care, to see and witness the fact that we can now offer at least standard of care to a lot of patients. Teen and young age cancers is a special group of patients. They have special needs. They have different kind of cancers. Just imagine आप लोगों के जिनके teenagers हैं, when they are normal and healthy, just being a teenager is a massive problem, right? And imagine a teenager with a life-threatening disease, a disease in which they lose hair, a disease in which they have vomiting, a disease in which they can't go and meet their friends, a disease in which they can't go for a date. Just imagine the complexities of the mental issues involved in a 15-year-old or a 16-year-old girl or a boy with cancer. So that is why we feel, and I think Colonel Chitalkar is the lead in this, that special attention needs to be paid to this group of people. We have like national level influencers here on the dais. And I would urge you to help us in starting teen and young age cancer units, specialized units which can take care of the mental aspects, the fertility aspects, and the cure part of these teen and young age patients and people who have cancer. We can start a movement together. Now, Chitalkar and myself have been trying for several years, some success. The fact that we are holding our 14th conference is success enough, but a lot more needs to be done. And if all of us join hands, if at GCRI, sir can start a teen and young age cancer unit, that will be an example to the whole country that, okay, if GCRI can do it, why can we not do it? And once the patient gets to know, once the patient's families get to know, okay, this is a center of excellence where teen and young age cancers are treated, then they will gravitate there. And then the corporates will get interested. Oh, why are those patients going to that particular hospital? Because they have a teen and young age cancer treatment unit. We will set it up all. We will do the investment and set it up. So that movement needs to be created. We have so many young oncologists spread all over the country. So we need you to light that lamp in your areas and see if we can benefit this special section of population with its own special problems. So with these words, I'd once again like to thank Bhavesh Bhai and his team for their incredible warmth and hospitality, for holding this meeting, and for increasing our knowledge, and so that we can go back to our native places with renewed energy to take the teen and young age cancer movement forward. Thank you very much.
Thank you, sir. Thanks a lot. I will request Dr. Bhavesh Parekh, sir, to give a short to Dr. Hemophilia.
Yes, sir.
Our next speaker, Shri Archit Trivedi ji. cancer warrior and film artist. Please give me a big hand.
जी मुझे भावेश सर का एक जेस्चर बहुत अच्छा लगा कि जो भी डायस पर गेस्ट आए हैं वो उनकी स्पीच दे, उसके बाद ही उसका शॉल से सम्मान होता है। इसका मतलब ये है कि वो स्पीच कैसी देते हैं, सम्मान के लायक है कि नहीं। आई लव यू। જી જી હું ગુજરાતીમાં જેટલું સ્વસ્થ ચિત્તે બોલી શકું છું એટલું કદાચ હિન્દીમાં ન બોલી શકું, પણ મને એવું સમજાય છે કે બંને સર ને જો હિન્દી બોલવાનો પ્રયત્ન કરીશ તેમને સમજાશે. મારે તો મારી બે વાત કરવી છે. મૂળ તો मुझे 91 16 नवंबर 1991 में कैंसर डिटेक्ट हुआ था और मैं भाग्यशाली था कि डॉक्टर पंकज शाह और उनकी टीम के हाथ में मेरा केस था, क्योंकि मैं कॉन्फिडेंस के साथ कह सकता हूं इतने सालों के बाद, 32 इयर्स हो गए, 34, कि पंकज शाह हमारे ड्रामा में एक राजा मिडास की कहानी आती थी कि जिसको भी छुए वो सोना हो जाए। ऐसे पंकज शाह सर कोई भी पेशेंट को हाथ में ले तो वो क्योर हो ही जाता है। मुझे बराबर याद है कि उनकी टीम पहली बार जब मुझे जहां एडमिट किया था वहां पर आए चेक करने के लिए। डॉक्टर पंकज शाह थे, डॉक्टर भरत परीख थे, डॉक्टर चिराग देसाई थे, डॉक्टर आशा आनंद जी थे और डॉक्टर पाई थे। पंड्या साहब जब सब बोल रहे थे जीसीआरए के बारे में, तब मुझे ये बात याद आई कि शशांक सर का काम कितना आसान हो गया होगा जब वो डायरेक्टर की चेयर पर बैठे होंगे तब, क्योंकि આયાનું કામ જેણે કર્યું છે એ કેટલા બધા ડોક્ટરો, ભલે એ લોકો કદાચ મેડિકલમાં નહીં હોય, સર્જરીના ડોક્ટર હશે, જેમ કે દેવેન્દ્ર પટેલ સાહેબ, શિરીન શુક્લ સાહેબ, આઈ દવે સાહેબ, કીર્તિ પટેલ સાહેબ, આ દરેક के દરેક ડોક્ટરોએ वहां पर जो काम किया था उसके कारण एमपी शाह कैंसर हॉस्पिटल का नाम दुनिया भर में प्रसिद्ध हो गया। देवांग सर यहाँ पर बैठे हैं, डॉक्टर देवांग भावसा, वो तो मेरे गुरु के भी डॉक्टर थे। कैलाश पंड्या जी को उन्होंने उनके निश्चित आयु तक जीने का मौका दिया ट्रीटमेंट करके। खुश नसीब लोग होते हैं जिनके हाथों में हमारे जैसे कलाकार ट्रीटमेंट के लिए आते हैं। पैसा वैसा कुछ नहीं था, कुछ नहीं। मैंने बराबर याद से साहब, पहला कीमोथेरापी का इंजेक्शन उस टाइम, तो अभी सब अच्छा हो गया, सरल हो गया। उस टाइम एक कीमोथेरापी जब मुझे दी जाती थी तब बाल बाल सब तो जड़ जाते थे, मगर માથામાંથી જૂની હિન્દી પિક્ચરોમાં પેલા વિલન લોકો આમ સિગરેટ પીવે અને પછી જે રિંગ કાઢે એવી રિંગ મારા માથામાંથી નીકળતી હતી। એટલા ગરમ ઇન્જેક્શન આવતા હતા। તો મારું પહેલું ઇન્જેક્શન એ સમયે 3,500 નું હતું કે જે પૈસા તો મારી પાસે હતા જ નહીં, કારણ કે હું તો 6ઠ્ઠા ધોરણમાં ભણતો હતો ત્યારથી 1 થી 5 ધોરણ ના ટ્યુશન કરતો હતો. હું 6ઠ્ઠામાં ભણતો હતો અને 1 થી 5 ના છોકરાઓના ટ્યુશન કરતો હતો, એક્ટિંગ કરતો હતો, ટીવીમાં કામ કરતો હતો, રેડિયો પર કામ કરતો હતો. મજાની લાઈફ છે, એકદમ અદ્ભુત. પણ મતલબ મારો એ જ છે કહેવાનો કે ત્યાં તમારે લોકોને તમે પણ બધા ડોક્ટર્સ છો એટલે તમારા ભાગ્યમાં પણ આ બધી ક્ષણો આવી હશે. પણ તમે જુઓ कि जब पहली वक्त डॉक्टर पंकज शाह और उनकी टीम जब मेरे रूम में आई तब मेरी हालत तो देखने जैसी थी. मैं कब चला जाऊं उसके लिए सब वेट कर रहे थे. कभी ये नहीं जिंदा रहेगा, गया 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 गया. तो कलाकार था, उसके कारण पूरे अहमदाबाद में, फिर पूरे गुजरात में, फिर जहां जहां एक्टर्स की कंपनियां हैं, बम्बई शहर जैसे सूरत में, बड़ौदा में, जामनगर, राजकोट, सब जगह पर पता चला कि भी अर्चन त्रिवेदी एक्टर को कैंसर हुआ है और सब लोग इकट्ठे हो गए और मेरे लिए फंड इंक्रीज किया. उस टाइम 2,86,000 रुपया 2,86,000 रुपया एक्टर्स लोगों ने इकट्ठे किए थे मेरे लिए. डॉक्टर भाग्यशाली हूं मैं, सही में. मैं तो एक बात हमेशा बोलता हूं कि मुझे अगर कैंसर नहीं हुआ होता तो मैं इतना पॉपुलर नहीं हुआ होता. एक्टर तो हूं मगर कैंसर के कारण सब जगह पर भगवान ने मुझे प्रथम पंक्ति में बिठा दिया. एक विश्वास मिला लोगों का. और सर ने बोला वो बिल्कुल सही बात है. जब मैं कैंसर हॉस्पिटल से बाहर निकला 4 दिन में मुझे काम मिलना शुरू हुआ. મારા વાળ નીકળી ગયા હતા, બે વાળ હતા મારા. તો જેવો હું બહાર નીકળ્યો 29 માર્ચ હું હોસ્પિટલમાંથી બહાર નીકળ્યો અને પહેલી સિરિયલ એક गोरस नामनी एक सीरियल હતી. गोरस नाम की सीरियल में मुझे गांठिया बनाने वाले का रोल मिला क्योंकि बाल ही नहीं थे और इतना दुबला पतला हो गया था. हंसते थे सब वहां पर कि राम से ब्रदर्स का हीरो है भूत वाली फिल्मों का. ऐसा नाम था मेरा. मगर बहुत अच्छा हुआ. सर ने बोला वैसे ही सही बात है. हॉस्पिटल में से बाहर निकल के बाद मैंने कैंसर के लिए बहुत सारे लोगों को फिर से ट्रीटमेंट लेना शुरू करवा दिया. मैं उनके पास जाके मालूम नहीं मैं क्या बातें करता होता मगर बात करते सीधा वो पेशेंट फिर से ट्रीटमेंट लेनी शुरू करते थे. હું હંમેશા માટે એમના ઘરે જઉં ત્યારે એમની બે જ વાત જાણીને જઉં કે એમનો સ્વભાવ શું છે અને એમને કેટલા સમયથી કેન્સર છે. આ બે જ વાત જાણીને જઉં. મને મારી ઘણા બધા 499 જેવા પેશન્ટોને મેં ફરી વખત ટ્રીટમેન્ટ લેતા કર્યા છે. મને એક પ્રસંગ બરાબર યાદ છે. એનું નામ હતું સીમા. લગ્ન એના 3 મહિના પહેલા થયા હતા અને એને કેન્સર ડિટેક્ટ થયું હતું. એની ચિંતા શું હતી ખબર? મારા વાળ જતા રહેશે કીમોથેરાપીને કારણે, એટલે મને ટ્રીટમેન્ટ નથી લેવી. એટલે મારે એને પાસે જઈને એવું સમજાવવું પડ્યું કે વાળ છે ને એ ઓળખાણ નથી. જો વાળ જ ઓળખાણ હોય તો ગાંધીજીને કોઈ ઓળખતું હોય? આ ભાવેશજીને કોઈ ઓળખતું હોય? પછી મેં એવું સમજાવ્યું કે તને તારા વાળ આજે જ કેમ ગમે છે? કારણ કે તને આ ચિંતા છે કીમોને કારણે વાળ જતા રહે. કીમોને કારણે હતા એના કરતા વધારે સારા વાળ પણ આવે. પણ કોઈની વાતો માની અને ટ્રીટમેન્ટ બંધ ના કરાય. પછી મેં એને એવું સમજાયું કે તું જ્યારે સ્કૂલમાં ભણતી હતી, ફ્રોક પહેરીને યુનિફોર્મ પહેરીને સ્કૂલે જતી હતી ત્યારે તારી માં તારા વાળ ઓળતી હતી, તારા વાળમાં જે ગૂંચ પડી હોય ને આમ કાઢે ઓ માં મને બહુ ખેંચાય છે એમ તું કરતી હતી. એના કરતા વાળ ના હોય તો સારું એવું ત્યારે તું કહેતી હતી. તો હસતા હસતા કે હા. તો મેં કહું જો વાળને જ તું આટલો પ્રેમ કરતી હોય તો તારા વરની પાસે બહુ સમય છે, તારા 3 જ મહિના થયા છે લગ્નને, તારા વાળની જોડે રમવા માટે એની પાસે બહુ સમય છે. वो खेलेगा तेरे बालों से, मगर अभी ट्रीटमेंट शुरू कर. પછી એને ટ્રીટમેન્ટ શરૂ કરી. આજે ખૂબ સુખી ઘરમાં રહે છે, એને 3 બાળકો છે, મસ્ત રીતે જીવે છે, જેમ હું પણ મસ્ત રીતે જીવું છું. જે કામ હું કેન્સર પહેલા કરતો હતો એના કરતા 4 ગણી એનર્જીથી આજે પણ કરું છું. 4 ગણી એનર્જીથી. આવું મને કહેતા સારું લાગે છે કારણ કે તમે તાળી પાડો છો એટલે મને એવું જરાક મન થાય કે વધારે તાળી પડે એવું થાય. કેમ? આજે 5 દિવસ પછી આજે હું અમદાવાદમાં સવારે આવ્યો છું મુંબઈથી. 14 કલાકનું શૂટિંગ કર્યું છે. તમે મારા નાક વિશે જાણતા હશો. આમ તો મારો કિશોર કુમાર જેવો વાત છે પણ આજે મુકેશ જેવો લાગે છે કારણ કે ખૂબ શરદી છે, પણ તે છતાં અહીંયા આવવાનું મન થાય જ ને થાય જ. એમાં એ સાહેબ આદેશ કરે એટલે પહોંચી જ જવાનું હોય. સ્થિતિ અને સંજોગ કોઈ પણ હોય હાજર જ થવાનું હોય. બધા જ મદદગારોને મેં પાઈ કરીને પાછા આપ્યા. પછી મારા ઘરમાં હું પંખો લાવ્યો. ત્યાં સુધી મારા ઘેર પંખો નહોતો. અને ગુપ્તા સાહેબ સાચું સરનેમ બોલ્યું?
પંડ્યા સાહેબ.
પંડ્યા ખરા, પણ તમારું?
હેમંત મલ્હોત્રા.
मल्होत्रा सर. मल्होत्रा सर, मुझे कैंसर जब हुआ ना तब मेरा घर तो बहुत छोटा था. मैं सिटी एरिया में रहता हूँ और सिटी से भी अंदर रहता हूँ. तो मेरा छोटा सा घर था, मगर रहने के लिए अच्छी सुविधाएं नहीं थी. तो डॉक्टर पंकज शाह जी ने उनके क्लिनिक में मुझे रखा था, जगह दी थी रहने के लिए. 6 મહિના હું રહ્યો છું ત્યાં સાહેબના ક્લિનિક પર. 6 મહિના. આટલી એમથી જગ્યા, વીજળી ઘરની બરાબર જોડે ઉપર જવાય આટલી જ દાદર, આટલા જ દાદર હતા. હું હાથ બતાવું છું એટલા જ. એ દાદરમાંથી 4થે માળે સાહેબનું ક્લિનિક, પંકજ શાહ સાહેબનું. ત્યાં ઉપર હું રહું અને સાહેબ એમના ક્લિનિકનો સમય પૂરો થાય એટલે ઘેર જાય ત્યાં જ હું સૂઈ જાઉં. કારણ કે મારા ઘરમાં હું સચવાવું એવી વ્યવસ્થા નહોતી. साहेब में कैंसर हॉस्पिटल में बदा हमारी खबर काढ़वा आवे, मुझे देखने के लिए जो भी लोग आते थे उनके लिए फुल टाइम. ऐसा नहीं था कि 4 से 7 में ही मिलना है. मेरे लिए फुल टाइम. कोई भी आए, कहां से भी आए, सबको आने की छुट्टी थी. क्योंकि सर ने, पंकज सर ने मेरे कमरे के बाहर जो एक छोटा सा ब्लैक बोर्ड होता है उसके ऊपर मेडिकल या सर्जरी जो भी केस हो वो नाम लिखा होता है. मेडिकल 1, मेडिकल 2, सर्जरी 1, सर्जरी 2 ऐसा लिखा होता है. मेरे कमरे के बाहर सर्जी ने अर्चन आवास ऐसा लिखा था क्योंकि मैं लंबे अरसे तक वहां मुझे रहना पड़ा था. मगर वो सब बातें आज भी याद करने से मुझे बहुत खुशी मिलती है क्योंकि वो था तो आज मैं हूं, और आज मैं हूं वो सब आपके लिए हूं. बहुत अच्छा लगा मुझे. ભાવેશ ભાઈ, થેન્ક યુ વેરી મચ. તમે મને બોલાવ્યો, હું આવી શક્યો અને તમારા બધાની વચ્ચે મને રહેવાનો મોકો મળ્યો. થેન્ક યુ વેરી મચ સર. થેન્ક યુ. આઈ લવ યુ. થેન્ક યુ. થેન્ક યુ સર. થેન્ક યુ સર.
Request Dr. Bhavesh Parekh sir.
આઈ લવ યુ સર. અને તમને જે ગુજરાતીમાં નથી સંભળાયું ને એ વધારે સારું છે.
आप बहुत अच्छे बोला है, इसीलिए साल बढ़ाने का.
Yeah, thank you very much. Thank you.
Moving on, I would like to request our chief guest, Dr. Anil Naik sir, IMA president, to have a short speech.
Good evening. In today's TYAcon 2025 inauguration, Dr. Pankaj Vishal sir, Dr. Sasank Pandya, Mr. Archan Trivedi, Dr. Hemant Malhotra ji, Dr. Colonel Prakash Chitalkar ji, Dr. Bhavesh, Dr. Hemant, all the delegates from various parts of the countries. Being a national president-elect from Indian Medical Association, headquarters New Delhi, I am first time knowing such type of association is there. Teenager and young adult cancer. So thank you, Bhavesh bhai, for inviting me. Because before 2 days he called me, our conference is there. And if you have a time, please come. I say, okay, Bhavesh is good friend of mine, so I have come. How many members are members of Indian Medical Association? Very less. So all these associations regarding the subjects are for your continuation, medical updates, knowledge sharing, and new research for. But for protection of you, protection of business, and protection of your clinic, Indian Medical Association is the mother institute. So I request all of you to become the member of Indian Medical Association. Because at present our strength is more than 4 lakh members, more than 1800 branches all over the India. And highest members in Maharashtra, second is Tamil Nadu, third is Kerala, and fourth is Gujarat. And particularly Ahmedabad is the largest and oldest branch of Indian Medical Association. Ahmedabad had more than 60,000 members of Indian Medical Association, and it was established in 1902. Our Indian Medical Headquarters established in 1926, but Ahmedabad Medical Association was established in 1902. So it is the oldest association.
Pankaj bhai is also one of the president of
Ahmedabad Medical. So regarding this young adult and teenager cancers, we have discussed many things regarding research, treatment, and support system. But let us remember the resilience and courage of these young warriors. We have to take care of this young warrior not for only treatment, but what is the impact of the cancer on these teenager and young adults? That we have to know. They does not affect only body. You are more expert than me, but they play a role with their emotions, their relationships, and their future. Previously, in 1970s and 80s, cancer was a new disease. So many Hindi movies, Bollywood making, Akhiyon ke Jaru Kaise, Anand, which are concerned with the cancer patients to encourage the moral strength and to give the strength to the patient. There's such type of Anand, after seeing Anand movie, anybody can arrange because that role was fantastic role by Rajesh Khanna in Anand. So such type of movie there. Nowadays cancer is common, so no one is making film movie regarding cancers. But they are finding the various uncommon diseases. Tare Jamin Par, Sitare Jamin Par, many uncommon diseases. Now they are coming in the movie, but not cancer. But you should take care. क्योंकि कैंसर में सिर्फ आदमी को खुद को सोशल डिप्रेशन भी आता है। एक सर्वे है कि मोर देन 50% ऑफ द सफरिंग आर मेंटली डिप्रेस्ड। सो वी हैव टू take not only chemotherapy, radiotherapy, and we have to take care by publishing their stories, just like the Archan Bhai story, many stories, because they will give promotion to the young adults and support to for their treatments. So, while seeing the patient, teenager and young adults in a cancer, we have to think spiritually. हम लोग जानते हैं कि हमारे जीवन में हमारे कर्म की सजा हमारे जीते जी मिलती है। कोई बुढ़ापे को कैंसर होता है, कुछ होता है, बोला वो ऐसे काम किए तो कैंसर हुआ होगा। बट टीनेजर को, जो बच्चे को कैंसर होता है, यंग को कैंसर होता है, तो वो हम कौन सी कर्म की थियरी आती है, वो भी हमें सोचना पड़ेगा कि क्या संचित कर्म है, क्या अगले जन्म के कर्मों की भुगतान है, क्या है, वो सोचना पड़ेगा। क्योंकि 2 साल का बच्चा, 5 साल का बच्चा जिसको कैंसर हुआ है, उसने कोई पाप नहीं किया है, कोई व्यसन नहीं किया है। आप बोलोगे कि हैबिट सिगरेट से होता है, तंबाकू से होता है, ऐसे होता है, उसने कुछ नहीं किया है, फिर भी हुआ है। और जीसीआरआई कैंसर हॉस्पिटल तो इंफ्रास्ट्रक्चर नंबर 1 है, पेशेंट भी बहुत आता है, लेकिन हमारा आईएमए का और हमारा लोगों का अप्रोच, हाउ टू प्रिवेंशन के बारे में जितना कहा कि हमारी पॉपुलेशन है 114 मिलियन, 140 करोड़ है, जितने भी हॉस्पिटल बनाएंगे कम पड़ेंगे प्राइवेट। तो वी हैव टू थिंक रिगार्डिंग प्रिवेंशन। And recently I have just read in the article that Russia had find out one vaccine to prevent the cancer. For cervical cancer there is HPV vaccine. IM is doing try to give children HPV vaccine, because it is a 100 conference in December where I am going to be installed in Ahmedabad. 100 national conference of IMA. It is in Club 07. More than 5,000 delegates are going to be attend this conference. So in this conference, because it is 100-year centenary conference, so we have targeted 100 camps of 100 girls to give HPV vaccine. Already we have 27 camps. We have already done, we have given vaccination to 2,700 girls. So such type of activity for prevention. So I wish कि आप लोग प्रिवेंशन के बारे में कोई सोच करें, क्योंकि रिसेंटली रशिया एंड चाइना इज वर्किंग इन जीन्स। वो लोग कहते हैं कि हमारा पूरा कोई भी डिसीज हो वो जीन्स में आ जाता है, आप व्यसन करो ना करो। दैट इज आने वाली जनरेशन को मालूम पड़ेगा कि वो जीन थेरापी चालू करने वाले, जीन में ही मोटिवेट करके इतने साल में उसको कैंसर होने वाला है तो जीन चेंज कर दो। ये थियरी पे काम चल रहा है और एआई का जमाना है, आर्टिफिशियल इंटेलिजेंस इज नाउ गोइंग वर्किंग विद अस। सो वी हैव टू वर्क हार्ड टू फाइंड आउट द प्रिवेंशन, बिकॉज प्रिवेंशन इज बेटर देन क्योर। एंड यंग जनरेशन, you should be a member of IMA. And for yourself also, I always used to ask 3 questions. कितने लोग रोज रेगुलर एक्सरसाइज करते हैं? How many doctors are doing regular exercise? जो करता हो हाथ ऊंचा करे। गुजराती में कहते हैं कि पहलू सूखते जाते न रमिस, अपने हेल्थ है वो अपनी प्रायोरिटी है। और इन द इरा ऑफ असॉल्ट ऑन डॉक्टर्स, डॉक्टर पे हमला होता है, हॉस्पिटल में होता है, तो आप मार ना सको तो कोई बात नहीं, लेकिन मार खाने की ताकत हो तो कसरत तो करनी पड़ेगी ना। मार खाके नहीं खाने की ताकत तो होनी चाहिए ना। आरजी कर का केस आपने देखा, रेसिडेंट के रेप हुआ, मर्डर हुआ, शी कैन नॉट प्रिवेंट, शी कैन नॉट प्रोटेक्ट। वो बच्ची अपने आप को बचा भी नहीं पाई। हम फिजिकली फिट हो, हम है तो कैंसर का डिग्री भी काम का है, एमबीबीएस भी काम की है, एमडी भी काम की है, डीएम। हम नहीं रहे तो 1-2 साल के बाद अपने जो पेरेंट्स हैं वो भी अपनी सर्टिफिकेट जला देंगे। तो हर रोज मेरा एक रिक्वेस्ट है कि डॉक्टर्स टू बी स्ट्रांग इनफ। कैंसर के बारे में तो ये लोग एक्सपर्ट है, वो पढ़ाएंगे, लेकिन मजबूत बनना पड़ेगा। आप लोगों को रेगुलर एक्सरसाइज 40 मिनट देने की है, हैवी एक्सरसाइज नहीं, 40 मिनट्स सिंपल वॉकिंग। क्योंकि हैवी एक्सरसाइज का मैं विरोधी हूँ, क्योंकि मैं ऐसा मानता हूँ कि भगवान ने सांसें गिन के दी है, तो दादा हैवी एक्सरसाइज करके हम सांसें जल्दी खत्म नहीं करना चाहते हैं। क्योंकि टॉर्टोइस होता है कछुआ, वो 300 साल जीता है, शांति से खाते पी के धीरे धीरे चलता है, रेगुलर वॉकिंग, रेगुलर स्लो वॉकिंग, तो 300 साल। और आप रैबिट देखोगे, बंदर देखोगे, 10-20 साल में चले जाएंगे, ज्यादा कसरत करके, हैवी एक्सरसाइज नहीं रिक्वायर्ड, 40 मिनट सिंपल वॉकिंग, हार्ट कार्डियो पर, दैट इज माय टेक्निक। तो रेगुलर 40 मिनट, और गुजराती में तो कहता है कि 40 પછી 40 मिनट, तो 40 नहीं तो तू क्या है 40 नहीं। रेगुलर एक्सरसाइज इज द इम्पोर्टेंट पार्ट। आपने देखा है कि यंग एडल्ट आजकल, जब भारत आजाद हुआ तो एवरेज लाइफ स्पान वाज 35 फॉर फीमेल एंड 30 फॉर मेल। इन 2021 इट इज 70 फॉर फीमेल एंड 65 फॉर मेल। किंतु हमारे लिए शर्म की बात हो, चिंता की बात होती है कि डॉक्टर की आयु कॉमन मैन से 10 साल कम है। डॉक्टर्स की आयु कॉमन मैन से 10 साल कम है, बिकॉज ऑफ स्ट्रेस। डोंट टेक एनी स्ट्रेस। तुम्हारे पहले भी कितने डॉक्टर आए, तुम्हारे बाद में अब तो लाइन लग गई है। जितनी मेडिकल कॉलेज बन रही है, तो आप नेशनल हाईवे पे हो, आपकी गाड़ी है, वो कैंसर की गाड़ी हो, डीएम कार्डियो की गाड़ी हो, कोई भी गाड़ी हो, कितनों को ओवरटेक करेगी। आपके आगे भी हजारों डॉक्टर है, आपके पीछे भी हजारों है। स्ट्रेस फ्री लाइफ जियो। मैं आया तो रस्ते में भाई भी मिला, बोला कि डॉक्टर साहब मजे में, मैं नहीं भी आनंद में। मैंने कि मजे में और आनंद में क्या फर्क है? मेरी मजे के लिए पैसे चाहिए, मजे के लिए पैसे चाहिए, लेकिन आनंद के लिए आप जैसे मित्रों के साथ बैठो, 2-4 बातें करो, आनंद आनंद हो जाता है। तो मेरी आप दूसरी एक्सरसाइज, आफ्टर क्लोजिंग योर क्लिनिक, 8 बजे आप क्लिनिक बंद करो, कभी कोई डॉक्टर फ्रेंड को नहीं मिलेगा। नॉन मेडिकल फ्रेंड के साथ बैठो, आधा घंटा 1 घंटा बैठो। डॉक्टर के साथ बैठोगे तो पूरे दिन की कहानी तुम्हें सुनाएगा, या तुम उनको सुनाओगे। आज तो एक पेशेंट आया था, साला ऐसा था वैसा था, ये किया वो किया। क्लिनिक बंद किया, माइंड मेडिकल का बंद कर दो, किसी नॉन मेडिकल के साथ बैठो, आपका लाइफ स्पान 5 साल बढ़ जाएगा। सुबह 7 बजे से शाम को 7 बजे तक मेडिकल, बाद में भूल जाओ मेडिकल। 24 घंटे मेडिकल मेडिकल मेडिकल। आपको 5 स्टार होटल में रखूं, आपको शूट रूम दूं, लेकिन साल में खाने के लिए 1 साल रहने का शूट रूम, आप जो होटल इंडिया की वर्ल्ड की चुनो, उसमें शूट रूम दूंगा, लेकिन खाने के लिए आपकी मनपसंद एक ही स्वीट 1 साल के लिए मिलेगी, बाकी कुछ नहीं मिलेगा। कि आपको मोहन दाल पसंद है तो मोहन दाल 1 साल तक खाना है, मजा आएगा। आपको जो स्वीट पसंद हो, आएगा मजा। तो दिमाग को भी सिर्फ अंको नहीं चाहिए, उनको भी दूसरा चाहिए। लास्ट मूवी कब देखी आपने? लास्ट मूवी कब देखी? कितने कितने लोगों ने कल रात को देखी? 1 लोग। मूवी देखो, हफ्ते में 1 मूवी तो देखना चाहिए। एक नॉवेल 3 घंटे में पढ़ती है और शाहरुख खान 500 रुपए में अपने आगे नाचता है, ऐसा कहाँ सीन मिलेगा? बड़ी से बड़ी हीरोइन 500 एरिया में नाचूंगी। एंजॉय लाइफ को, एंजॉय करो। डॉक्टर डॉक्टर हम क्यों बने? जैसे टीनेजर को कैंसर होता है ना, अगले जन्म के कर्म, तो अगले जन्म के हमारे पाप बढ़ गए होते, तब हम ये जन्म में डॉक्टर बन जाए, पाप धोने के लिए, सेवा करने के लिए। और जो नॉन मेडिकल वाइफ होती है, उन्होंने पुण्य किए है, तो वो डॉक्टर की वाइफ बनती है कि वो जलसा करे। हमें तो इमरजेंसी में जाना है, कॉल में जाना है, वही पूरी जिंदगी वही।
शीतलकर सर बोलते हैं कि मेरी वाइफ
सबको उन्होंने पुण्य किया होता है, तभी हम कम मिलते हैं। हमने पाप किए, पाप धोने के लिए आए हैं, तो आप ऊपर जाओगे तो आपको स्वर्ग मिलने ही वाला है, चिंता मत करो। लेकिन ये जन्म, क्योंकि भगवान रजनीश ने भी कहा है,
सर, लेकिन वो स्वर्ग में अनिल नायक चाहिए, मेनका नहीं चाहिए।
मैं या नर्क में जाने वाला हूँ, मेरी कंपनी चाहिए तो नर्क में आ जाना। एक आदमी ने पूछा कि आप दारू पीते हो क्या, नर्क में जाओगे? तो ठीक है, तो दारू बेचने वाला शेर सिंह कहाँ जाएगा? वो भी नर्क में जाएगा। चिकन बेचने वाला राम सिंह कहाँ जाएगा? वो भी नर्क। वो सब नर्क में है, तो मेरे लिए वो स्वर्ग ही है। आप लोग मेरे साथ नर्क में आओगे तो मेरे लिए वो स्वर्ग ही है। तो नर्क स्वर्ग नहीं है, लेकिन एंजॉय द लाइफ। मैं 82 में MBBS में एडमिशन लिया, तब से मैं एक ही बात करता हूँ कि एंजॉय द लाइफ, स्ट्रेस फ्री लाइफ। हमारे पहले कितने भी डॉक्टर साहब आ गए, ऑर्थोपेडिक में हमारे दीनू भाई थे, MT मेहता थे, ढोलकिया थे, बड़े बड़े नाम थे। आज कोई याद नहीं कर रहा, कोई याद नहीं कर रहा था। आप बोलोगे कम याद करेगा, 5 साल 5 जनरेशन आपके स्टूडेंट हो गए, याद करेंगे, बाकी नहीं करेंगे। सो लाइफ एंजॉय। रजनीश ने बोला है कि भगवान ये नहीं पूछेगा शनिवार हनुमान का दिवस है, तेल डाला कि नहीं डाला, शेविंग किया कि नहीं किया, है चिकन खाया कि नहीं खाया, आमलेट खाया कि नहीं खाया। भगवान हिसाब रखेगा 140 करोड़ इंडियनों का कि उसने क्या किया। वो बोला कि इतने 80 लाख योनि में पास होने के बाद तुझे इंसान का जन्म दिया, तूने लाइफ एंजॉय किया कि नहीं किया, एंजॉय किया कि नहीं किया, तो इतना ही पूछा है। तो एंजॉय द लाइफ, स्ट्रेस फ्री बनो। हम अकेले डॉक्टर नहीं, बाकी सब प्रोफेशन वाले एंजॉय करते हैं, हम नहीं करते एंजॉय। तो स्ट्रेस फ्री बनो, लाइफ करो, रेगुलर एक्सरसाइज। एंड थर्ड एंड लास्ट वन, मैं सबको बोलता हूँ, इसमें सबको, किसके 2 या 2 से ज्यादा बच्चे हैं?
किसी के दो या दो से ज्यादा,
2 या 2 से ज्यादा 30%। मेरी 2 हाथ जोड़ के विनती है, आप क्रीमी ऑफ द सोसाइटी हो, अच्छे डॉक्टर हो, DM तक पहुंचे हो, सुपर स्पेशलिस्ट हो, आपके बच्चे सुपर स्पेशलिस्ट होने वाले हैं। आप डरो मत कि 2 बच्चे आएंगे तो कैसे होंगे, कैसे होंगे, अच्छे बच्चे ही होने वाले हैं। मिनिमम 2 बच्चे क्यों चाहिए कि हमारा कल्चर है, मैं पब्लिक पॉपुलेशन कंट्रोल की बात हमें माननी नहीं है, क्योंकि जो लोग कम IQ वाले होते हैं वो तो 5-5 बच्चे पैदा करते हैं। इंटेलिजेंट बच्चे अच्छा नहीं पैदा करोगे आप, तो 2 चीजें नुकसान हुई। एक हमारा कल्चर है, हमारे कल्चर में क्या है, चाचा चाची, मामा मामी, फूफा फूफी, मौसा मौसी, है कि नहीं। अंग्रेज कल्चर में अंकल और आंटी, उसमें कुछ नहीं है, अंकल और आंटी सबके लिए। तो हमें एक बच्चा पैदा करेंगे तो 90% रिलेशन खत्म हो जाए, 2 करेंगे तो 60% रिलेशन कट हो गए, 40% रहेंगे। पहले के जमाने के, वी आर 5 ब्रदर एंड सिस्टर, मेरे माँ बाप भी 5 लोग थे, उसके माँ बाप तो 11 लोग थे। सही में पहले तो क्या पीडियाट्रिक और ऐसी मेडिसिन अवेलेबल नहीं थी, 2-4 बच्चे तो स्पेयर में पैदा करते थे। तो ये पीडियाट्रिशियन नहीं मर जाएगा तो कोई चिंता नहीं, सबके घर कोई भी जाओ। भगवान कृष्ण में भी 8वां संतान थे उसके माँ बाप की। अब्दुल कलाम राष्ट्रपति थे, वो अपने माँ बाप के 11वें संतान थे। विवेकानंद अपने माँ बाप के 7वें संतान थे। आम्बेडकर इसके माँ बाप के 8वें संतान थे। अब सबका देखो, जो जो 1-2 के चक्कर में महापुरुष पैदा होने बंद हो गए। थैंक यू। मेरा एक रिक्वेस्ट है कि आपका बच्चा अच्छा होगा, मेडिकल मैनेजर IIT में जाएगा, IAS बनेगा, IPS बनेगा, चिंता मत करो। हम गिनते हैं कि बच्चा आएगा तो कितना खर्चा, हमारा कैरियर क्या क्या होगा। कैरियर अच्छा ही होगा, वो सब जो आता है वो अपना नसीब लेकर आता है। हमारे गुजरात में कहा था कि हर एक का अपना डेस्टिनी लेकर आता है, और किसी की ब्लेसिंग की जरूरत नहीं। ऐसा नहीं है कि ब्लेसिंग नहीं, ऊपर वाले की दया होगी तो 2 हो गए 3, आपकी मर्जी होनी चाहिए, तो ऊपर वाले की दया नहीं चलती। सर एक हमारे गुजराती राजा ठाकुर साहब थे, उसके घर एक साधु संत आए। तो साधु संत आए तो उन्होंने अपने कपल ने बहुत ही सेवा की, 15 दिन रहे तो खाना पीना सुबह शाम भक्ति भक्ति सब सेवा की। 15 दिन के वो जाने लगे तो बोलो बच्चे आपको कोई आशीर्वाद चाहिए कि महाराज शादी को 15 साल हुए, एक भी बच्चा नहीं है। गुजराती में इसको बोलते हैं शेर माटीनी कोट छे, कि हमें बच्चा एक भी नहीं, औलाद नहीं है। बोला ठीक है, मैं जूनागढ़ जा रहा हूँ, वहां जाके दिया जलाऊंगा गुरु दत्तात्रेय के वहां, आपको कुछ ना कुछ अच्छा फल मिलेगा। ठीक है, वो गए। 15 साल के बाद वो आए, साधु घूमते घूमते वापस आए। बोले चलो एक भक्त के घर लास्ट टाइम गया था, तो उसके घर जाके मिल लो। तो घर के आंगन में देखा तो 8-10 बच्चे खेल रहे थे। नॉक किया, घर में गए तो उसकी बीवी ने कहा ओ महाराज आ गए आ गए, आप आ गए। तो कहे बच्चे कितने, बस आपकी कृपा थी, 8-10 बच्चे सब आपके ही आप आशीर्वाद से हुए हैं। कि तुम्हारे घर वाले कहाँ गए, आपके हस्बैंड कहाँ गए? वो क्या जूनागढ़ दिया बुझाने गए हैं। कि अब 8-10 बहुत हो गए, तो आपके लिए हमें दिया ना जलाना पड़े, तो आप मिनिमम, और देखो भारत कुछ एक्सपोर्ट ज्यादा कुछ कर सकता नहीं है, मैन पावर एक्सपोर्ट करता है। हर एक का बच्चा कहाँ है कि अमेरिका में है, कनाडा में, माँ बाप अकेले। गांव में ये हालत है कि पेरेंट्स आर, वो वृद्धाश्रम में रहे हैं। एक बच्चा था अमेरिका गया, 2 बच्चे थे कनाडा चले गए, अकेले रहे। पहले तो क्या करते थे, 5-10 बच्चे में से चूज करते थे कि ये पढ़ने वाला नहीं है, ला बेटा बीड़ी जला के ला, ला बेटा हुक्का जला के ला, ला भैंसों को पानी पिला दे, कि ये पढ़ेगा नहीं, हमारी बुढ़ापे में सेवा करेगा। उसको सब व्यसनी बना देते थे। बीड़ी जलाने जाएगा तो फूक मारेगा ही, हुक्का जलाने फूक मारेगा ही, काम ही सौंपते थे। तो 2 बच्चे ऐसे रखते थे कि जो पढ़े नहीं और काम करे। ये सही बात है। हमारे नाथू भाई कार्डियोलॉजिस्ट थे, उसके बड़े भाई थे, वो गांव में खेती ही करते थे, कि नाथू भी पढ़ने वाले हैं तो ठीक है, बाकी ना को खेती कराओ। तो आप मिनिमम 2 बच्चे, एक मेरी ये रिक्वेस्ट है। और भारत के 250 कंट्री में से 16 कंट्री में भारत ओरिजिन वाले के बड़ा प्रधान है। हमें 250 कंट्री में प्राइम मिनिस्टर बनाना हो अपना भारत ओरिजिन, तो कितनी चाहिए? हमें एक्सपोर्ट करना ही पड़ेगा, तो भारत विश्व गुरु बनेगा। और इसके लिए इंटेलिजेंट आदमियों की ड्यूटी है, बुद्धिशाली लोगों की ड्यूटी है कि हमें मिनिमम 2 बच्चे, मिनिमम 2 बच्चे आप करोगे। नहीं तो क्या है, पारसियों में क्या सब बस्ती कम हो रही है, पारसी कम्युनिटी में तो 1 बच्चे पे 1 करोड़ देते हैं। अब जैनों में भी चालू हुआ है, वो 1 बच्चे पे 1 लाख 2 लाख देने चालू किया है। मैं डर रहा हूं कि कहीं आईएमए को भी ये चालू करना पड़े, तो हम बजट कहाँ से लाएंगे कि डॉक्टर बच्चा पैदा करे 1 लाख हम देंगे? ऐसा हमें सोचना पड़ेगा। तो आप आईवीएफ चालू किया, ये सब चालू किया, लोगों के बच्चे निकालते हो, हमारे लिए क्या शर्म करना? आपके बच्चे अच्छे होने वाले हैं, लेकिन एक बड़ी रिक्वेस्ट है कि मिनिमम 3 मेरी बातें सुनना, याद करना। आईएमए डॉक्टर स्ट्रांग रहेंगे। पहली रेगुलर एक्सरसाइज, दूसरा स्ट्रेस फ्री लाइफ, और तीसरा 2 बच्चे मिनिमम, 2 बच्चे मिनिमम। इतना करोगे तो आईएमए डॉक्टर स्ट्रांग रहे और हमारी यूनिटी बढ़ेगी। सर ने हनुमान की बात की, राम की बात की, तो राम और हनुमान को सब पूछते हैं, लेकिन हमारा कोई पूछता नहीं। जब राम और रावण के बीच में युद्ध हुआ तो मेघवान का क्या नाम था, रावण का, मेघनाथ। मेघनाथ तीर चला, लक्ष्मण मूर्छित हो गए। राम की टोली में तो कोई डॉक्टर था नहीं। सुसेन को, जो रावण का डॉक्टर था, वो वैद्य को बुलाया, ऑपोजिट पार्टी का डॉक्टर आके ट्रीटमेंट लिखा कि उसको मूर्छित हुआ है, संजीवनी की नाम की दवा चाहिए। प्रिस्क्रिप्शन दिया हनुमान को, हनुमान पूरा मेडिकल स्टोर लेके आ गए। संजीवनी नहीं लाए, पूरा स्टोर, उसमें से ढूंढ के दवाई दी। सर, अयोध्या में राम मंदिर बना 500 साल के बाद, हनुमान का मंदिर है, रावण का है, लक्ष्मण का है, सीता का है, सुसेन का एक नानी नानी डोकरी भी नहीं बनाई। हमने प्राइम मिनिस्टर को लिखा कि सर, डॉक्टर है, राम के भाई को हमने सजीवन किया था, सबके बड़े बड़े टेम्पल बनाए, हमारी छोटी सी दिरिया तो बनाओ। अब तक लिखा है, कोई जवाब नहीं आया। तो हमारा आने वाले समय में डॉक्टरों को कोई याद करने वाला, प्रिस्क्रिप्शन दवा लेके जाएगा, हनुमान की पूजा सब करेंगे, लेकिन हम कच्चे नहीं है सब। डॉक्टर लोग इतने पक्के हैं कि हनुमान भी घुमरी कराते हैं। हमारे में एक खामी है, यूनिटी। लेकिन एक बार 400 साल पहले सब डॉक्टर इकट्ठे हुए, राम भगवान की पूजा की। राम भगवान ने प्रसन्न हो गए, बोलो डॉक्टरों क्या चाहिए, वैद्यों क्या चाहिए? कि अभी तो कुछ नहीं चाहिए, लेकिन हमें कोई तकलीफ हो तो हमें कोई चाहिए ना आदमी, तो क्या हनुमान के देके जाता हूँ, कोई भी तकलीफ हो तो आप मुझे घंटी बजाना, मैं आ जाऊंगा, आपकी सबकी जो काम मनोकामना हो पूर्ण करूंगा। ठीक है? पिछले साहब ने टिकरे बजाई, हनुमान आया, बोलो साहब कुछ काम है? काम नहीं, चेक कर रहा हूँ, तू आ रहा है कि नहीं। अहमदाबाद भावेश ने जिन टोकरी बजाई, हनुमान आया, बोलो भावेश के काम नहीं है, चेक करा तू आ रहे। तो पूरे इंडिया से सभी डॉक्टर टोकरी बजा दे, हनुमान आ जाए, काम नहीं है, चेक कर रहा हूं, तो आता है कि नहीं आता है। 15 दिन हुए तो हनुमान एग्जिस्टेड हो गए, निराश हो गए, सीधा राम के पास, बहुत से डॉक्टरों के रवाड़े कहाँ चढ़ाया है। ये डॉक्टर चेन्नई से, मद्रास से, हिमाचल प्रदेश से, गुजरात से, सभी से टोकरियां बजती है। मैं जाता हूँ, काम नहीं बताते, सिर्फ चेक करते हैं। जैसे पेशेंट चेक करते वैसे मुझे चेक करते हैं, लेकिन वो काम बताता नहीं। फिर राम ने सभी डॉक्टरों की मीटिंग बुलाई कि आप सब आ जाओ। फिर बोला कि हनुमान का ये प्रॉब्लम है कि आप टोकरी बजा दो, काम नहीं कहते हो, तो हनुमान अब थक गया है। अब पिछला रास्ता है कि जब 5 डॉक्टर इकट्ठे होके, 5 डॉक्टर्स टूगेदर होके घंटी बजाएंगे, तब हनुमान आएंगे और आपका काम करेंगे। उसके बाद 5 डॉक्टर एक हुए नहीं, हनुमान आए नहीं, और हमारा समस्या पे समस्या, समस्या पे समस्या, पीयू परमिशन लाओ, फायर परमिशन लाओ, ये लाओ, वो लाओ, क्लिनिकल एस्टेब्लिशमेंट एक्ट, सभी इतने एक्ट आ गए ना, आप प्रैक्टिस करना तो भूल जाओगे। और आने वाले 2047 में बोले कि हमारा भविष्य क्या होगा, तो हमारा भविष्य आपको देखना चाहिए। 2047 में आप जाओगे कैंसर हॉस्पिटल में या मुलाकात पे, तो होम्योपैथिक का डॉक्टर ट्रीटमेंट लिख रखा होगा, आयुर्वेद का ऑपरेशन करता होगा, और कि मॉडर्न मेडिसिन वाले वो कोर्ट के धक्के खा रहे होंगे कि आज डिस्ट्रिक्ट कोर्ट में मुद्दत है, कल हाई कोर्ट में मुद्दत है, पर सुप्रीम कोर्ट में है। तो हमारा फ्यूचर अच्छा नहीं है, हमें अच्छा बनाना है। अच्छा बनाने के लिए हमें एक यूनिटी करना है। क्या यूनिटी इज अवर स्ट्रेंथ। तो आप सब लोग आईएमए के मेंबर बने, 4 लाख डॉक्टर से ज्यादा है, तो उसमें आपका भी सुर उड़ाइए, तो हम स्ट्रेंथ से लड़ सकते हैं। एक अकेला आदमी कुछ नहीं कर, स्ट्रेंथ होगी तो हमारा काम होगा। और हमें स्ट्रेंथ इसलिए चाहिए कि हम गवर्नमेंट से रूल मॉडिफाई करा सकें। हम हमारे बच्चे, जैसे सरहद पे सैनिक होते हैं, वो हमारी रक्षा करते हैं, तो आईएमए का काम सरहद के सैनिक जैसा है। आपके कोई भी प्रॉब्लम हो तो आईएमए उसके लिए तैयार है, लड़ता है। और यूनिटी हमें 60% करनी है, 100% कभी नहीं होने वाली, क्योंकि चरक संहिता में लिखा है व्याघ्रा नाम महत निंदम सर्पा नाम च अतीत भयम वैद्या नाम अनेक ततम तव जीवती जंतव। मीन्स व्याघ मीन्स शेर एक दिन खाना खाता है, शिकार करता है, फिर 15 दिन सोता रहता है, हर रोज शिकार नहीं करता, नहीं तो जंगल में कोई भी प्राणी बचता नहीं। स्नेक्स करोड़ों की संख्या में है, लेकिन वो किसी को काटने नहीं आते। गलती से क्रॉस करे, पैर पड़े तो ही वो काटते हैं, क्योंकि वो डरपोक प्राणी है। वो डरते नहीं और सबको काटने लगे करोड़ों की संख्या में, तो कोई आदमी जिंदा रहेगा नहीं। और वैद्या नाम अनेक तत्वम, डॉक्टरों में यूनिटी नहीं है। ये 3 वजह से पृथ्वी पर लोग जी पाते हैं, तीनों की चरक संहिता में लिखा है। अगर हम एक होते, हम कुछ भी करें, तो हमारा पीएम करने वाला भी अपना, काउंसिल का मेंबर भी अपना, सब भी अपने, जो एक्सपर्ट आएंगे वो भी अपने, वो सब नॉर्मल लिखेंगे तो क्या होगा, कुछ होगा नहीं होगा। लेकिन एक नहीं होना है, तो हमें 60% यूनिटी आएगी तो हम एक हो गए। और यूनिटी ये अपनी स्ट्रेंथ है। कोई भी आदमी बड़ा नहीं, मैं भी बड़ा नहीं हूं, आप भी बड़े नहीं हो, अकेले कोई भी बड़ा नहीं है। आप ग्रेप्स खरीदने जाओगे तो जो झुमके में ग्रेप्स उसकी कीमत ज्यादा होगी, अलग पड़ी हुई ग्रेप्स की कीमत कम होगी। आप झाड़ू करेंगे तो एक एक तीली है, वो जुड़ के झाड़ू बनता है, वो तो कचरा निकालता है, लेकिन उसमें जो अलग तीली हो गई तो खुद कचरा बन जाती है। तो हम एक रहेंगे तो हमारे प्रॉब्लम सॉल्व करेंगे, और एक करके हम अपना अपना जो राइट है करेंगे तो मिलेगा। नहीं तो परसों आपने देखा होगा कि फिजियोथेरेपी को आगे डॉक्टर लिखने से मना किया, 8 घंटे में उन्होंने रिप्रेजेंट किया, वापस ले लिया, क्योंकि हमारी स्ट्रेंथ नहीं है, हमारी यूनिटी नहीं है। तो हमें यूनाइट होके लड़ना होगा। अब 700 से ज्यादा मेडिकल कॉलेज है, क्वालिटी ऑफ द एजुकेशन भी डाउन हो रही है, चिंता का विषय है। हम लड़ रहे हैं, लेकिन क्योंकि जहाँ स्टाफ नहीं है, 30% स्टाफ में मेडिकल कॉलेज चल रही है, और एजुकेशन की क्वालिटी बिगड़ रही है। तो हम क्वालिटी के ध्यान लेने के लिए हम हर बार रजूआत करते हैं, मेमोरेंडम देते हैं, लेकिन हमारा सबकी फर्ज है कि आने वाले बच्चे, जो करिकुलम है, जो हमारा ऐसे टाइप के क्वेश्चन आंसर आते थे तो हम सब पढ़ते थे, क्लिनिक में जाते थे, अब सब नीट नीट नीट। 12वां से नीट चालू हुआ तो सर को पेशेंट के वो बोलेगा, आप ऑप्शन देगा तो वो सारवार कर सकेगा। क्या मेरे पे करोड़पति जैसा हो गया, पेशेंट हिस्ट्री देखा तो कुछ नहीं आएगा, ही हैव टू गिव ऑप्शन, ये 4 में से कौन सा है, तो ये बोलेगा। तो हमें नीट की वजह से हमारा नॉलेज कम हो रहा है, तो हमें उसे भी सोचना पड़ेगा। आप सब लोग यहाँ अहमदाबाद में आए, भावेश भाई ने, पंकज भी साहब ने अपनी हॉस्पिटल अच्छी की होगी, और आप आईएमए के मेंबर बनो। नेटकॉन 2025 अहमदाबाद में आप आओगे 26, 27 एंड 28 डिवीजन से, फ्राइडे सैटरडे एंड संडे है, क्लब ओ 7 वेन्यू है, अच्छी जगह है। आप लोग जो आओगे तो गुजरात आपका हॉस्पिटैलिटी अच्छा करेगा, इतनी मैं गारंटी देता हूँ। और आईएमए के लिए कोई काम हो, मैं सभी काउंसिल का भी मेंबर हूँ, गुजरात और नेशनल मेडिकल डेंटल नर्सिंग सब में मैं मेंबर भी हूँ। तो मेरे लायक कोई भी सेवा हो तो मुझे बताइएगा, मैं आपकी सेवा में करने के लिए तत्पर रहूंगा। लेकिन आप यूनाइट रहे आईएमए का और आपके एसोसिएशन का भी नाम आगे बढ़ाएं। यूनाइटेड, किसी को अपने फ्रेंड को क्रिटिसाइज ना करे, क्योंकि अपना ही अपने को मारता है। रावण बनने वाला नहीं था, मरा है विभीषण की वजह से। तो हमारे में कोई भी विभीषण पैदा ना हो और हम एक भाई के राम लक्ष्मण की तरह प्रैक्टिस करें, कंपटीशन नहीं, अपने को आगे बढ़ाने की करो तो आप अच्छा रहोगे, अच्छे बनोगे और नाम भी होगा। बोलने चाहे तो घड़ियाल के कांटे नहीं, लेकिन कैलेंडर के पत्ते फाड़े इतना बोल सकता हूँ। लेकिन टाइम इज मनी, थोड़ा अच्छा शॉर्ट एंड स्वीट हो तो अच्छा लगेगा। लेकिन मिलता रहूंगा। मुझे कैंसर के बारे में ज्यादा हो गया, मैं ऑर्थोपेडिक सर्जन हूँ। कोई सार्कोमा का आता है मैं रिफर ही करता हूँ, बाकी कुछ करता नहीं हूँ। कभी कभी बायोप्सी लेता था, बाकी कुछ करता नहीं हूँ। तो ऑर्थोपेडिक में ट्रॉमा में ही ब्रेड एंड बटर है, तो हम वही करते हैं। तो मुझे ज्यादा नॉलेज अंकों का नहीं है। लेकिन आप जो भी आपका पेशेंट हो, अच्छा हुआ उनकी स्टोरी पब्लिश करो, उनको एनकरेज करो। और आप भी अपनी जिंदगी, क्योंकि आपको जस्ट मिलने वाला नहीं है कैंसर के, आपने ब्रांच ही ऐसी पसंद की है, इसमें जस्ट रेखा नहीं होती है। तो आपको जितना जिए वो अच्छी दर्शन भी तरीके, जैसे पेशेंट हो कुछ तो वो आपको जस्ट देंगे। बाकी तो हमारे जमाने में था कैंसर मीन्स कैंसर, ऐसा था, ऐसा ही बोलते थे, कैंसर हुआ तो कोई हमारे तो क्या है कि वी हैव टू टेक एक्स्ट्रा कैंसर। पेशेंट की जो खबर पूछने आते हैं ना वो भी डिप्रेस करके जाते हैं। कैंसर हुआ, कौन सा स्टेज है, ओहो हमारे उसको हुआ था 3 दिन में मर गया। वो बेचारा थोड़ा ठीक हुआ था, डिप्रेशन में चला जाता है। ये रूटीन है, ये रूटीन है। एक आज अभी अभी तो आपने एक लास्ट जॉक के मेरी बात को विराम देता हूँ। एक आदमी को, सभी सुनते नहीं, यंग को हार्ट अटैक ज्यादा आता है अभी, तो सब बोलते हैं कोरोना और कोरोना की वैक्सीन की वजह से यंग लोगों को अटैक बहुत आता है, सीरियस कार्डियक अरेस्ट प्लस सडन एमआई होता है, वो मर जाते हैं। तो एक डॉक्टर भावेश भी जितना टेंशन में आ गया। चलो भाई कार्डियोलॉजिस्ट को पता, कार्डियोलॉजिस्ट ने सब चेक किया, एंजियोग्राफी की, सोनो इको की, सब कुछ किया, नॉर्मल आया सब रिपोर्ट। फिर बोला कोई चिंता की बात नहीं है, ये तो लाखों में एक लोगों को कार्डियक अरेस्ट और कुछ होता है, बाकी चिंता की बात नहीं, आप घर शांति से जाओ, कोई चिंता मत करो। घर गया तो सामने बीवी आई, आ गए आप, हाँ कि आप तो सभी बात बात सही भी। महिला यार मेरी किटी पार्टी में बात कर रही थी कि आपके पतिदेव तो लाखों में एक है। फिर वो टेंशन में आ गया कि अटैक आने वाला भी लाखों में एक है और मैं भी लाखों में एक हूँ। तो टेंशन तो जिंदगी में आता रहेगा, आप चिंता मत करिए, एंजॉय द लाइफ एंड दैट इज द मैसेज, होम टाउन मैसेज। तो ले जाने का मैसेज एक है, एंजॉय द लाइफ। पहली बार हमारे डॉक्टरी में आए हैं, हम अपने पाप धोने आए हैं, कुंभ के मेले की तरह। जब गंगा में कुंभ में लोग पाप धोने जाते हैं ना, तो हम पाप धोने के लिए डॉक्टर बने हैं। अच्छी जिंदगी अगली बार मिलेगी, हम आईएएस आईपीएस और पॉलिटिशियन बनेंगे नेक्स्ट जन्म में। नेक्स्ट जन्म में हमारा बढ़िया है। वो जब अभी जो पॉलिटिशियन है कि आईएएस आईपीएस, वो अगले जन्म में डॉक्टर थे। तो चिंता मत करो, अगला जन्म हमारा बढ़िया आने वाला है। और यही जन्म में जो हमारा कर्म अच्छा पूरा हो गया पाप, तो कोई डॉक्टर अभी आईएएस आईपीएस बनना चालू कर दिया है, पॉलिटिशियन बनना चालू कर दिया है, तो आप समझ लेना कि उनके पाप धो गए, अब वो नया जन्म चालू हो गया। तो हम कोई भी ब्रांच में जाओ, लेकिन एंजॉय द लाइफ, दैट इज द माय होम केयरिंग मैसेज टू यू। जय आईएमए, लॉन्ग लिव आईएमए।
Thank you, sir. Thanks a lot. I will request Dr. Hemant.
थैंक यू वेरी मच अमन सर, जीरो ब्लॉक ની યાદ આવી ગઈ સાહેબ। ખરેખર તમે આવ્યા અને અમારું આખું કોન્ફરન્સ અથવા તમે બી કહું છો ને, અમે બધા ડોક્ટરોને કદાચ હસતા બી નહોતું આવડતું, તમે એટલી હસાવ્યા તો ખરા બધાને। અને આઈએમએ માટે ખરેખર વધારે આપણે યુનાઇટ થઈએ, પાર્ટિસિપેટ કરીએ। અને બહુ શોર્ટ નોટિસ ઉપર પંકજભાઈ પણ મને આજ કહ્યું હતું, મેં કહ્યું ને કે સાહેબ અનિલભાઈ આવે છે, તો કે બરાબર આવે છે અનિલભાઈ આવે છે ને એટલે કે વાંધો નથી આપણું ઇનોગ્યુરલ ફંક્શન સારું થઈ જશે અને પંકજભાઈ પહેલા બી કહ્યું કે ખાસ અનિલભાઈને હું બહુ સારી રીતે અને મારો ખાસ ફ્રેન્ડ છે એવું શબ્દ સાહેબ બોલ્યા હતા અને થેન્ક યુ અમને ગર્વ છે કે તમે આઈએમએ ના નેશનલ પ્રેસિડેન્ટ મલ્હોત્રા સર અને ચિત્રકર સર પૂછતા હતા કે શું ખાલી ગુજરાતમાંથી જ આઈએમએ ના પ્રેસિડેન્ટ થાય છે મેં કહ્યું સાહેબ અનિલ નાયક સાહેબ છે ત્યાં સુધી તો આ ઓલું જીનપિંગ જેવું અને પુતિન જેવું છે કે નિયમમાં એવું જ છે કે જ્યાં સુધી છું ત્યાં સુધી હું જ છું
14 साल के बाद आया नंबर 14 साल के बाद मेरे पहले थे वो बिहार के थे आपके रवि वानखेड़कर थे महाराष्ट्र के राजस्थान के एस अग्रवाल थे हाँ, ऐसे
thank you very much Dr. Anil Nayak for coming and for giving a very short lecture but very inspiring lecture please.
आपकी टीम जो एडवाइजिंग है उसमें आधा घंटा डेली आपका भी डोज होना चाहिए
આર્થિક માનસિક અને શારીરિક તંદુરસ્ત એક જ ડોક્ટર છે
બધા રિપોર્ટ નોર્મલ છે
And the last
સિટીમાં રહું છું એટલે ઓબેસિટી છે
ક્યાં વાત
હમણાં દેતો તો ના હોત સિટીના કારણે ઓબેસિટી
the last, I will request Dr. Hemant Meghani sir to give vote of thanks.
Before I come, I just want to take blessing of everyone on the dais.
सो हेमंत मेघनानी सर के लिए 2 वर्ड्स 3 दिन पहले ही रियल में घर में इमरजेंसी थी बच्चा अभी एनआईसीयू में है फिर भी वो यहाँ है थैंक यू वेरी मच हेमंत
So, good evening, everyone. So I am a little jittery, speechless for many reasons. The first reason being that I am ideally and appropriately chosen as the conference secretary. Why? Because the conference is TYAcon, and among all the people here and all the people down, I am the preteen here. Preteen or a teenager here, not even a young adolescent or an adult. I am actually a preteen in terms of my career, in terms of my growth, in terms of everything. So I thank you everyone for giving me this opportunity, especially Dr. Bhavesh Parekh sir. उन्होंने मुझे जब दिया, I thought I would be much more active and be part of this conference in a much more robust way. And then something in the family side came up, and it was all of a sudden. And we had to have a preterm, mild preterm, late moderate preterm, 34-week child. So फिर अभी थोड़ी देर पहले मैंने कुछ तैयार नहीं किया था, अनिल सर का सब सुना तो मैंने उनको कॉन्ग्रेचुलेशन और उनकी एक बात पे कहना चाहता हूँ, दिस इज माय सेकंड चाइल्ड. सो कम से कम 2 डॉक्टर के, सो उस पे अभी तक ठीक है. देन मैं सबसे जब यहाँ पे जो बैठे हैं उन सबसे मिलता हूँ तो आई लाइक के 2-2 मिनट बात होती है. I mean, I have met many of Banavali sir. I've met only for 2 minutes on 2-3 conferences with all of your careers. कई बार आप लोग हमारा पाथ जब क्रॉस होता है तो हम बहुत ज्यादा सीख जाते हैं. आपके लिए it might be a few minutes discussion because you meet so many people all your across your journey. पंकज शाह सर मैं कई बार मिला हूँ लास्ट 4-5 ईयर्स से. आई डोंट नो इफ ही रिमेम्बर्स मी और नॉट, बट आई रिमेम्बर हिम अ लॉट बिकॉज छोटी बातों से ही आप सीख जाते हैं इन आवर यंग कैरियर. मैं एक पीडियाट्रिक हेमेटोन्कोलॉजिस्ट हूँ. वेरी इन्फेंट कैरियर इन द फर्स्ट 4-5 years, 6 years of my careers. Learning all of these things has been great. So my job today is to quickly wrap this up, क्योंकि सुबह 7 से शाम के 7 तक ही डॉक्टर्स की बात सुननी चाहिए. It's way past 7 now. So I am the last doctor standing here before we move out, eat our dinner and move on to our non-doctor friends. So Pankaj sir, thank you so much. Thank you for everything all over the years. आज अभी जो पूरा
सेटअप है उसके लिए थैंक यू सो मच। शशांक सर आप आए उसके लिए थैंक यू सो मच। एंड और यस्टरडे का जो पूरा फंक्शन था ऑडिटोरियम में विद ऑल ऑफ द हमारे कैंसर सर्वाइवर्स, उनकी प्रेजेंस एंड देयर इन्फ्लुएंस जो उन्होंने बताया, वो कल का जो टॉक था वो नॉन एकेडमिक था, मोर अबाउट म्यूजिक, मोर अबाउट ऑल द अदर थिंग्स, स्कूल रिलेशनशिप्स। सो उसमें उनका जो इनटेक था, उनके जो गाइडेंस थी, दैट वाज रियली रियली अप्रिशिएटेड। थैंक यू सो मच। अनिल सर आप तो आए, मैं कई बार आईएमए के टॉक्स के थ्रू आपसे मिला हूँ, मैसाना के टॉक्स के थ्रू, व्हेन यू यूज्ड टू बी द मैसाना, तो मैं टॉक देने आता था सीएमईस करने, तब से बिग फैन ऑफ योर टॉक्स, बिग फैन ऑफ योर इंस्पिरेशंस। आपके साथ अगर आधे घंटे बैठेंगे तो कम से कम 20-25 बार तो हंसी लेंगे, विच वी ऑल सॉ टुडे। थैंक यू सो मच। हेमंत सर से आज मैं पहली बार मिला, प्लेजर मीटिंग यू। एंड चितलकर सर, आप दोनों से गुजारिश है कि आगे वाली कॉन्फ्रेंसेज में भी इस टीनेज को थोड़ा मौका देना and guide to them to the young adult journey. So I will like to be a part of TYAcon over the years moving forward. Thank you so much. भावेश सर का मैंने ऑलरेडी बहुत बहुत थैंक यू बोला, क्योंकि सेक्रेटरी होने के बावजूद मैंने एक्चुअली सेक्रेटरी का बहुत ज्यादा काम ऑनेस्टली किया नहीं है। To be here and actually to give a thank also is I'm very thankful to him. Thank you so much, sir. And all the other faculties who are present here for talks, for orations, everyone, thank you so much for coming. All the delegates, so much for coming. Our pharma delegates, बहुतों को मैं जानता हूँ because they are based out of Gujarat, and thank you so much for being helpful to this conference. And obviously Mice Ideas for being the event partners. Thank you so much. I won't take lot more of time. If I am missing everyone, I would like to apologize from my part, but I want to thank everyone who's been here today and also who are going to be here tomorrow for it. Thank you so much. Enjoy the evening. Thank you.
All are invited for the dinner, and thanks Dr. Vijay, my wife, and all the team members and TYAcon 2025. Thank you everyone.
एक ग्रुप फोटो।
Kurkure madam, please. I ordered. Yes, sir.